Welcome to day 2 of 3 of this month's ACIP. Good morning, and I'm going to hand it over to Dr. Wharton for some introduction.
Thank you, Dr. Talbot. Next slide, please. I'm delighted to introduce the 4th of the new ACIP members who are joining us at this meeting, Dr. Bonnie Maldonado from Stanford University, where she's Chief of the Division of Infectious Diseases in the Department of Pediatrics, and directs Stanford's Global Child Health Program and serves as Medical Director for Infection Prevention and Control at the Children's Hospital at Stanford. Dr. Maldonado, we're delighted to have you join us, and welcome to the committee. Next slide, please. And we wanted to acknowledge the long service of Dr. William Schaffner from Vanderbilt University, who recently concluded a more than 40-year engagement with the Advisory Committee on Immunization Practices. Dr. Schaffner started his service in the early 1980s when he was a member of the ACIP from 1982 to 1986, and following that served as a liaison representative for the American College of Physicians, the American Hospital Association, the Infectious Diseases Society of America, and the National Foundation for Infectious Diseases. I don't know that we've got a medal for the longest service to ACIP, but if we did, I think Dr. Schaffner would get it. And so given this extraordinary record of service to the committee, we wanted to acknowledge that this morning. I also wanted to just make a brief personal note that I probably would not be sitting in this chair today were it not that as an Epidemic Intelligence Service officer in 1987, when Dr. Schaffner was a principal mentor of mine, he encouraged me to undertake an outbreak of a vaccine-preventable disease in Nashville, Tennessee in 1987. So we are very grateful for Dr. Schaffner's contributions to the committee. And I will say, I think he continues to serve on some work groups, so he's not actually done. Dr. Talbot?
I get to say a few words too, because I would not be in this seat if it had not been for Dr. Schaffner either. He actually mentored me all through residency, fellowship, and now, and actually he was the one that recommended me for ACIP. Dr. Schaffner has a wonderful way of being direct in a good way and taking the problems on the work group and simplifying them, getting to the point, and keeping us from being distracted. His years of wisdom, despite his young age, and his experience has really helped guide us through many a work group. I'm so thankful that he continues to serve. I'm very thankful he continues to act as a mentor. And I would like to thank him for his advocacy for diversifying ACIP and really encouraging women and others to step forward and serve. So, Dr. Schaffner, thank you. And I believe you may want to hop on and say a few words.
Well, Dr. Wharton and Dr. Talbot and colleagues, thank you very much for your kind words. I assure you they are deeply, deeply appreciated. My long association with the ACIP continues to be one of the most rewarding aspects of my professional career. You know, it's not often that one has the opportunity to participate in deliberations with learned and devoted colleagues and then make decisions that immediately become public policy and the standard of care. Now, from time to time, I've provoked discussion by posing the following question. Of all the extraordinary diverse contributions that CDC makes to the public's health, which of these activities has the most direct, the most immediate, and the most sustained impact? My vote goes to the ACIP. The ACIP also has created many personal friendships with colleagues at the CDC, state and local public health, academia, and with colleagues who create and produce the vaccines. I treasure these friendships. I've rotated off as liaison representing the NFID. My friend and colleague, Dr. Bob Hopkins, now sits in that chair and you are lucky to benefit from his insights and experience as both a pediatric and adult provider. I'll continue to tune into the meeting deliberations with great interest. Please let me know if there's anything that I might do to support the ACIP, particularly in the spirit of continuous quality improvement, making a great ACIP even better, helping to further enhance adult immunization. Again, thank you for your kindness.
Thank you, Bill, and I think one more round of applause would be appropriate. I love doing fun things like that. Okay, so along those lines, because I just have to do it multiple times during this meeting, as Dr. Schaffner said, moving forward, adult vaccines also deserves a plug for vaccines for adults. Okay, time for roll call today. I would like the members, the voting members, to state their name if they have any conflicts. Basically, you introduced yourselves yesterday, so I think a name is adequate. Dr. Brooks.
Oliver Brooks, no conflicts.
Dr. Chen.
Wilbur Chen, no conflicts.
Dr. Sineas.
Sybil Sineas, no conflicts.
Dr. Daly.
Matt Daly, no conflicts.
Dr. Jameson.
Denise Jameson, no conflicts.
Dr. Cotton.
Camille Cotton, no conflicts.
Dr. Lair.
Jamie Lair, no conflicts.
Dr. Long.
Good morning, Sarah Long, no conflict.
Dr. Maldonado.
Yvonne Maldonado, Stanford PI for the pediatric COVID vaccine trials. Otherwise, no other conflicts.
Dr. Schechter.
Robert Schechter, no conflicts.
Dr. Shaw.
Al Shaw, no conflicts.
And I'm Dr. Talbot, or Kip Talbot, and have no conflicts. All right, our ex officio members, Centers for Medicare and Medicaid Services. Food and Drug Administration.
David Caslow, no conflicts.
Health Resources and Services Administration.
Commander Reed Grimes representing HRSA.
Indian Health Service.
Matthew Clark representing Indian Health Service.
Great. National Institutes of Health.
Good morning, John Weigel representing the National Institute of Health.
Office of Infectious Diseases and HIV/AIDS Policy.
Good morning, Tim representing OIDP.
Okay, once again, Centers for Medicare and Medicaid Services. All right, now we get to start the morning with COVID-19 vaccines, and I believe Dr. Daly is going to get us started.
So I'm ready once there they go. Okay. So I'll be introducing the session today on behalf of the ACIP COVID-19 Vaccines Work Group. Next slide, please. So just to review where we're at the present moment with regard to 23-24 COVID-19 vaccine recommendations. The ACIP met September 12th of 2023.
Dr. Daly,
yes.
I hate to interrupt, but I skipped the agency updates.
I was a little surprised that I was on already, but I just figured I'd go with it. So,
I'm very excited to get started this morning. Okay.
All right.
Let's start with the agency updates, and we'll start with the CDC.
Finishes one meeting on time and look what happens. Just kidding. Thank you. Thanks, Dr. Talbot. So hi, everyone. I'm Dimitri Daskalakis. I'm the director for the National Center for Immunization and Respiratory Diseases, and I will just double click on the importance of ACIP, and I will, as Dr. Talbot said, double click on the importance of vaccinations for children and also vaccinations for adults. So a really great way to start the day here. So we have a lot of activity always, and so I'm just going to briefly go over some of our highlights. And I think probably the first is retrospectively looking back at seasonal respiratory viruses. Last year was very exciting with the commercialization of the COVID-19 vaccine, multiple RSV products that launched, as well as our staple work in seasonal influenza, and we'll talk more about other influenza soon. So though, again, a very exciting time, we also have some significant challenges and important issues that we need to continue to address. So as of May 11th, 2024, let's talk about COVID-19 vaccine first. 22.5% of adults older than 18 years of age, and 14%, that's 14% of children aged 6 months to 17 years were reportedly up to date with the COVID-19 2023-24 vaccine. So I think we'll be hearing a lot of data today about the importance of the vaccine and, again, the challenge of having coverage that is really not adequate. Vaccination coverage, however, does increase by age and was highest among adults with receipt of at least one of the updated COVID vaccines, reaching 41.5%. That's 41, not 14, 41.5 among adults over 75 years of age. Still not okay. So still more work to do in that space. Also important to talk about the Bridge Access Program. It did launch in fall 2023 and provided no-cost COVID-19 vaccines to adults who did not have health insurance and adults whose insurance did not cover all COVID-19 vaccine costs. About 1.5 million doses had been provided through that program from September 2023 through May 2024. This program, which was temporary, a bridge to somewhere, I hope, will end in August 2024. Moving on to RSV, I think we had some great conversations yesterday about RSV, and I think probably one area I wanted to highlight was teamwork, and the teamwork around the Nursivimab story that we all lived through very intimately last year, or last season. So despite challenges in Nursivimab supply, our survey and health record data suggests that over 40% of infants less than 8 months of age received Nursivimab by February 2024. So by any gauge of a new product, that is a pretty successful launch. Additionally, just under 18% of eligible pregnant persons received the RSV vaccine at 32 to 36 weeks of gestation by the end of January 2024. Taken all together, that means about 2 million infants were protected against RSV because of those new products. So again, really important to say CDC has been deeply engaged with other government agencies as well as the manufacturers to really make sure that we're checking the math for how this is going to roll out next year. And again, really working closely across government, both our colleagues in FDA who are working diligently on the regulatory side, as well as us preparing for the launch of the next season. In terms of what we've seen for adult RSV, 24.4% of adults 60 years and older have reported being vaccinated against RSV, and that's using our National Immunization Survey, which is a tool that we frequently use to estimate coverage. So along with the work that we're doing to make sure that supply is adequate and timing is synced better to what needs are, CDC and our great colleagues at FDA continue to monitor for any adverse events, including cases of GBS, which we heard a really robust conversation about yesterday, as well as other inflammatory neurologic events after RSV vaccination through our robust vaccine adverse event surveillance systems. So seasonal flu, a foe that we know very, very well, continues to create a lot of disease burden in the U.S. We estimate that there have been at least 35 million illnesses, 390,000 hospitalizations, and 24,000 deaths from flu in the last season. So again, the recommendation is that everyone 6 months and older get an annual flu vaccine so long as flu activity continues. And then always important to remember that there are antivirals that we know work for flu, and especially individuals who are at higher risk. The sooner you start, the better it is. Additionally, I think when you put these all together, this really makes up our suite of seasonal vaccines. I think as you can see through some of the work that we've done in the last year, we're really trying to weave these together into a respiratory virus season package, and that's reflected both in the way that we display our data at CDC as well as our respiratory virus guidance that we launched in March. So it does not end there. Other respiratory viruses continue to be the focus of attention at NCIRD, including avian influenza. I know you'll be hearing a bit more about that today. Just to remind you that our current risk assessment for the general population is that the risk remains low. We continue to be avidly connected to farm workers and farm worker organizations and those that serve them, because we think that there is risk in acquisition of this virus for individuals who are working very closely with dairy cows and products that are from animals with potential H5N1 virus. So again, this is primarily a veterinary event, but we are working in One Health space with close collaboration with USDA and FDA to make sure that we continue to monitor impact on human public health and also use our seasonal influenza system to do what it does so well, which is to identify what's happening with the flu season, characterizing the viruses, but also identifying if there are any new or novel threats in the flu space as well. Measles, we're going to move on to another foe that we know very well. As of June 6, 2024, there were a total of 151 measles cases reported by 22 jurisdictions in the United States. That compares to 58 measles cases in 2023 that were reported by 20 jurisdictions. So when we look at risk, jurisdictions at highest risk for measles continue to be those that contain communities of focus that may have persistently low vaccination coverage. And this tends to be a scenario of importation. So at that global village that we work in and live in, the work that we do on the ground to increase MMR coverage is critical, but also work that's happening globally to address some of the gaps that have occurred even more pronounced after the COVID-19 pandemic peak. Notably, the spring was really busy for us, and we supported some really great local health departments in response to measles outbreak within a migrant shelter, specifically in Chicago, and with the state of Illinois. And that outbreak resulted in 57 cases. And again, there are several really important MMWRs that really tell the story of what we saw. And very importantly, I think especially in this space in ACIP, what we didn't see but could have seen if we didn't actually work so closely with the Department of Health and launch a very, very aggressive, in a good way, measles vaccination campaign. So in that setting, I think really seeing sort of the importance of confidence. We had very high uptake among the individuals offered vaccine, and what could have been an outbreak that potentially could have impacted hundreds of people was controlled. So the power of vaccination, not only from the perspective of preventing disease and sort of routine primary care, but the importance of vaccination and robust public health in addressing outbreaks. I'm going to move on to Mpox and just highlight that there was a report, a MMWR in May, that showed that the vaccine was very effective in preventing infections among vaccinated individuals. So it's estimated that infections happened in less than 1% of fully vaccinated people, so that's 2 doses. And very notably, individuals who did get infected with Mpox despite vaccination had a milder course of their disease. So vaccines work even when they don't, which I think is a really important message. Moving on to our bacterial pathogens, lots of activity in the meninge space. So very specifically around prophylaxis, CDC issued guidance on selection of antibiotics for close contacts, especially in areas where ciprofloxacin resistance is seen. Additionally, we also in March issued a health alert about the increase in serogroup Y meningococcal disease in US, and that disproportionately affected 30 to 60-year-olds, Black or African American people, and adults with HIV. In May, we subsequently issued another health alert and travel health notice about cases of meningococcal disease associated with Umrah travel to the Kingdom of Saudi Arabia. So despite a lot of ways to prevent, still a lot of activity and lots of messaging around how to best prevent using chemoprophylaxis or vaccine. Moving to pertussis. Reports of pertussis were lower than usual during the past few years, but we are starting to see in the US the return to pre-pandemic patterns with more than 10,000 cases reported per year. So it is just mainly an important reminder that we have vaccines that work, and the importance of making sure that folks are up to date with that one as well. Moving to a pathogen that's a bit different. Briefly, anthrax. Emergent Biosolutions announced in July 23 that FDA had approved Cefendis, or anthrax vaccine absorbed adjuvanted for post-exposure prophylaxis of disease following suspected or confirmed exposure to Bacillus anthracis in individuals 18 to 65 years when administered in conjunction with recommended antibacterial drugs. So the vaccine is comprised of the previously FDA-approved anthrax vaccine absorbed AVA and additional adjuvant CpG 7909. It has been demonstrated that by using an additional adjuvant, 2 doses administered over 14 days result in protective levels of immune response as opposed to 3 doses over 4 weeks. So this vaccine is currently a component of the U.S. government strategic national stockpile for use in an anthrax public health emergency, and it will replace AVA as it expires. Importantly, and why I'm sort of going deep into anthrax, is that ACIP will soon convene an anthrax work group to review data and provide recommendations for its use to the ACIP committee. And lastly, though it is, sometimes we don't think about it as vaccine preventable, antimicrobial resistance is another important topic. If you don't get the infection, it can't become resistant, is I think the important message. And in September 2024, the US will have an opportunity to demonstrate leadership in combating resistance at the second United Nations General Assembly high-level meeting on antimicrobial resistance. So we have set in US government really ambitious goals to reduce healthcare-associated infections, including those caused by antimicrobial resistant pathogens, and protect patients and healthcare personnel. So again, CDC has demonstrated a long history of success in making progress towards these goals, and we're going to be really excited to share that at the General Assembly high-level meeting. With that, I will pass it back to Dr. Talbot, and we'll resume our normally scheduled programming. Thank you.
Thank you so much. There's a lot of information, a lot of news. I'd like to have our FDA colleagues go next.
Thank you, Dr. Talbot. Again, David Kaslow, Office of Vaccines Research and Review, CBER FDA. So since the last FDA agency report at the February ACIP meeting, and apropos to this convening of ACIP, our Vaccines and Related Biologics Products Advisory Committee, or VRPAC, convened twice, and the Office of Vaccines Research and Review took several major regulatory actions, of which I'll briefly highlight just 3. So in March, VRPAC met in open session to discuss and make recommendations on the selection of strains to be included in influenza virus vaccines for the 2024 to 2025 influenza season in the Northern Hemisphere. Having discussed the need to transition from quadrivalent to trivalent influenza vaccines at several previous VRPAC meetings, committee members generally agreed on transitioning to trivalent influenza vaccines only for use in the United States starting in the 2024-2025 respiratory virus season, and US licensed quadrivalent vaccines for ex-US distribution purposes only. There was also general agreement among VRPAC members for changing the H3 component, but maintaining the currently recommended H1 and B components. VRPAC again met in open session in June, this time to discuss and make recommendations on the selection of the 2024-2025 formula for COVID-19 vaccines for use in the US beginning fall 2024. VRPAC unanimously voted to recommend a monovalent JN1 lineage vaccine composition and discuss considerations for the selection of a specific strain, be it JN.1 or KP.2. Subsequently, FDA communicated to manufacturers of licensed and authorized COVID-19 vaccines advice on the use of these two specific strains for the 2024-2025 formula. As for major regulatory actions taken since February, I'll briefly mention three. On the 31st of May, respiratory syncytial virus vaccine, an mRNA-based vaccine, was approved for active immunization for the prevention of lower respiratory tract disease, or LRTD, caused by RSV in individuals 60 years of age and older. On the 7th of June, respiratory syncytial virus vaccine adjuvanted was approved for active immunization for prevention of LRTD caused by RSV in individuals 50 through 59 years of age who are at increased risk for LRTD caused by RSV. And then on the 17th of June, pneumococcal 21-valent conjugate vaccine was approved for active immunization for the prevention of invasive disease caused by 22 Streptococcus pneumoniae serotypes in individuals 18 years of age and older, and was approved under accelerated approval for active immunization for the prevention of pneumonia caused by 21 strep pneumoniae serotypes in individuals 18 years of age and older. As in the past, I'd like to take this opportunity to personally thank the CBER review teams, our supervisors, and the management at CBER who continue to work diligently to conduct research and review to protect and enhance public health. Our VRPAC members, who we call upon frequently to opine on complex topics, such as the two mentioned earlier. And let me end, as I have in the past, by thanking our CDC colleagues for their many contributions and their commitment to consilience in the collective regulatory and policy efforts needed to protect and enhance public health through immunization. Thank you.
Thank you. Our HRSA colleagues?
Good morning. I'm excited to provide important updates on 3 vaccination efforts that HRSA undertakes to support the nation's public health. First, HRSA's Health Center program is a cornerstone of our country's healthcare system, providing affordable, high-quality, comprehensive primary care services to more than 30 million medically underserved people nationwide, especially for individuals and families who are uninsured, enrolled in Medicaid, living in rural, remote, or underserved areas, struggling to afford their health insurance copays, experiencing homelessness, residing in public housing, or otherwise finding it hard to find a doctor or pay the cost of care. Today, the nearly 1,400 HRSA-funded health centers operate more than 15,000 healthcare sites, as well as mobile clinics, community outreach events to engage patients in accessible settings, and other satellite sites. HRSA's Health Center program has been essential in vaccine uptake for COVID-19 vaccine doses. As of April 2024, over 24 million vaccine doses have been administered by all health centers, 70% to racial and/or ethnic minority patients. Additionally, the Countermeasures Injury Compensation Program, or CICP, continues to make unprecedented progress in reviewing claims alleging injuries from medical countermeasures, for example, Mpox vaccine, anthrax vaccine, or COVID-19 vaccine, deployed in response to pandemic, epidemic, and security threats. As of June 1st, 2024, CICP has specifically rendered decisions on 2,814 COVID-19 claims and continues to work through the backlog of claims filed following the extraordinary deployment and administration of over 676 million COVID-19 vaccines in response to the pandemic. For the National Vaccine Injury Compensation Program, or VICP, they continue to actively process claims. In fiscal year 2024, as of June 1st, petitioners have filed 783 VICP claims. Nearly 119 million was awarded to petitioners, and over 34 million was awarded to pay attorneys' fees and costs. In addition, the VICP has approximately 600 claims alleging vaccine injury awaiting activation for review. For more information about VICP, CICP, or HRSA's Health Center program update, please visit our website. Thank you.
Thank you. Indian Health Service.
The Indian Health Service remains committed to immunization as our #1 clinical and public health prevention priority. As part of our ongoing national E3 vaccine strategy, we offer every patient at every encounter every ACIP recommended vaccine when appropriate. To date, we've designated 29 E3 champion pilot sites in 9 IHS areas. In the past several months, utilizing a grassroots approach, our pilot sites have shared and we have disseminated innovative strategies to promote vaccine acceptance and to improve vaccine coverage rates in tribal communities. Under the leadership of IHS Chief Medical Officer Dr. Loretta Christensen last month, as recently recognized by our partners at CMS, we announced our E3 Champions Pilot Community Development Project to cross-pollinate our IHS system of care with multidisciplinary best practices. We've recently designated 3 IHS E3 champions, including 1 federal, 1 tribal, and 1 urban site in 3 IHS areas, who have demonstrated excellence by exceeding established thresholds to improve vaccine coverage rates for American Indian and Alaska Native people. Today, I'd like to draw particular attention to the outstanding work of one of these IHS E3 champions, our tribal partners in the YK Delta region of Alaska. The YK region is a landmass roughly equivalent in size to the state of Oregon and larger than half of the states in the country. Serving a population of 23,000 indigenous people in 58 remote tribal communities off the road system, the YK Delta historically has the highest rate of severe RSV disease in the United States and arguably in the world. During the 2023-2024 respiratory viral season, with support from the Vaccines for Children program and a supplemental allocation from IHS, the Yukon-Kuskokwim Health Corporation vaccine team conducted regular bush plane flights to remote tribal villages, sometimes up to 3 villages in one day, to administer nirsevimab and other recommended vaccines to eligible infants and toddlers, with a vaccine acceptance rate over 60%. In addition, among newborn infants born in the YK Delta region during the first season of availability, immunization with nirsevimab approached 100%, with an obstetric delivery rate of roughly 30 to 35 newborns per month. Notably, preliminary data analysis pending publication indicates that no single infant in the YK Delta region who had been effectively immunized with nirsevimab experienced severe disease, including hospitalization. Indicative of a virtuous cycle resulting from proactive efforts to promote RSV protection among this high-risk service population, our tribal partners at YKHC also managed to raise the baseline composite immunization rates among infants ages birth to 1 year by over 10% for all ACIP recommended vaccines. Working in collaboration with immunization exemplars like our tribal partners in the YK Delta region of Alaska, the Indian Health Service will continue to mitigate the risk of vaccine preventable illness in Indian country. Thank you, and I'll turn it back over to you, Dr. Talbot.
That's such a wonderful success story. Thank you so much for sharing that with us. And hopefully that'll continue to motivate everyone when supplies better to move on. All right, OIDP.
Good morning. Thank you, Dr. Talbot. Chinedu Okeke representing OIDP OASH. The National Vaccine Advisory Committee met on June 12th and 13th, 2024. At this meeting, Admiral Rachel Levine, the Assistant Secretary for Health and Human Services, charged the committee with providing guidance and recommendations to support the development of the next 5-year National Strategic Plan. This plan provides a vision for the nation and helps to ensure we continue to be responsive to an evolving vaccine and immunization landscape. Therefore, Admiral Levine asked NVAC to review and access the goals, objectives, and indicators in the current plan and evaluate if they are still relevant, flexible, and responsive. She also asked the committee to seek expertise as needed and to recommend and prioritize 3 objectives within each of the goals the committee thinks will make the greatest impact on the U.S. immunization system in the next 5 years. Also, during the meeting, the committee heard presentations on vaccine production readiness capabilities, the mpox vaccination response, planning for the 2024-2025 fall and winter respiratory disease season, the outbreak of measles in Illinois, CDC already talked about this, Other presentation focused on immunization data, global immunization successes, vaccine dose administration. We heard updates from our federal agencies, members, and our liaison representative about work they are doing to advance immunization. And we closed both days of the meeting with public comments. The next NVAC meeting will take place on September 12th and 13th, 2024, in person as well as live webcasted on hhs.gov/live. Updates on the meeting will be made available on the meeting page later this summer on hhs.gov. Now, moving on to the next, the planning for the next iteration of the National Vaccine Strategic Plan 2026 to 2030 updates. The Office of Infectious Disease, OIDP, in collaboration with HHS Interagency Vaccine Work Group, has started planning, data gathering, and engagement efforts for the next iteration of the National Vaccine Strategic Plan for the years 2026 to 2030. The NVAC report and its recommendation is a parallel process which will inform an inclusive and robust consultation process that will include listening sessions with stakeholders and other inputs. Also, we are putting together a request for information to be released very soon. We encourage ACIP members to actively submit feedbacks and recommendations during this process. Moving on to promoting vaccine confidence in local communities. In fact, today, June 27th, my colleague Sean Dade from OIDP vaccine team and Laurie Consella from the Office of Regional Health Operations in the Office of the Assistant Secretary for Health in Denver, Colorado, to conduct an in-person site visit with Immunize Colorado. This well-respected organization has achieved a new level of reach into rural and Latinx communities with trusted messengers. During an all-day meeting, the team will discuss current activities and target measures submitted by Immunize Colorado in their Year 3 work plan and evaluation plan. This visit will also give us an opportunity to learn more about effective intervention strategies to increase vaccine confidence within a local community. Moving on to responding to Senate Appropriation Committee, the Office of Infectious Disease, OIDP, prepared a report that just went into official clearance in response to the request from the Senate Appropriation Committee that encouraged OASH in partnership with CDC to lead the development of a government-wide coordinated efforts to ensure the implementation of the Advisory Committee on Immunizations Practices, ACIP recommendation that all adults between 19 and 59 be vaccinated for hepatitis B. The committee requests this report be prepared before the end of fiscal year 2024. Thank you for your attention. Over.
Thank you. NIH.
Good morning. The National Institutes of Health continue to support multiple areas of vaccine research for multiple pathogens. I just wanted to highlight a few of these that I think will be of interest to the ACIP. For influenza, in response to the human and bovine H5N1 cases, the National Institute of Health released an H5N1 influenza research agenda. That agenda describes our ongoing and planned efforts to meet 4 key objectives. First, understanding the biology and virulence of H5, developing and evaluating preventive strategies, including vaccines, advancing existing and novel treatments, including antivirals and monoclonal antibodies, and supporting diagnostic strategies. A link to the agenda can be found on NIAID website and will be provided in the written updates. For Ebola and our continuing efforts to advance vaccines for pandemic and outbreak preparedness, scientists at the VRC, the Vaccine Research Center, evaluated a heterologous prime boost strategy for Ebola. This was done in a phase 1 trial, both in the US and in Uganda. The strategy uses a ChAd prime with an MVA boost. That heterologous prime boost regimen was well tolerated and induced a robust immune response, which persisted up to a year. The results were published in MPJ Vaccines. For malaria, the NIH published interim trial results showing an injected dose of an experimental malaria monoclonal antibody was 77% effective at preventing disease in children in Mali during the country's 6-month malaria season. Monoclonals are seen as a possible component to minimize morbidity and mortality from malaria. In efforts towards an HIV vaccine, there have been some important advances in the development of broadly neutralizing antibodies. A class of broadly neutralizing antibodies called 10E8 is a priority for HIV vaccine development because they can bind to conserved regions in glycoprotein GP41. This has been difficult to advance previously. Germline targeting is an approach that guides naive B cells to develop into B cells that can produce these broadly neutralizing antibodies. Recently, scientists described an approach to germline targeting that was done in mice that developed broadly neutralizing antibodies to this GP41. The findings published in Nature Immunology are encouraging. It's an incremental step, but incremental and important step in developing a preventive HIV vaccine. So details and links for all of these, as well as several other additional updates, will be provided in our written summary. And this concludes the updates from the National Institute of Health.
Thank you so much. And last but not least, CMS.
Great, thank you so much, and appreciate the opportunity to provide a couple updates from CMS. First, I want to just highlight that back in February, we released an updated coverage and payment of vaccines and vaccine administration guide for Medicaid that provided updated information on Medicaid coverage for vaccines. I also just wanted to amplify that CMS continues to share with all of our partners and stakeholders highlight coverage of vaccines, as well as to amplify activities that are being taken by Medicaid agencies and other partners throughout the country to really encourage uptake of vaccines and to increase vaccination, particularly for pediatric vaccines. And we will continue to look for these opportunities to amplify this and to emphasize coverage of vaccines throughout the Medicaid, Medicare, and Marketplace. Thank you so much for the opportunity to provide an update.
Thank you to all our ex officio colleagues. I promise to get a second cup of coffee. Now, Dr. Daly, will you start us with COVID?
Gladly. So I'm introducing the session on behalf of the ACIP COVID Vaccines Work Group. Just to start with a slide that reviews the 23-24 COVID-19 vaccine recommendations. ACIP met in September and recommended 23-24 COVID-19 vaccines as authorized under EUA or BLA in persons aged 6 months and older. This includes recommendations for Moderna vaccine in persons 6 months and older, recommendations for Pfizer vaccine in persons 6 months and older, and then recommendations for Novavax vaccine in persons 12 years and older, with some additional details in the footnotes. And then to be a little bit more specific, everyone aged 5 years and older should get at least one dose of a 23-24 COVID-19 vaccine to protect against serious illness from COVID-19. And then children aged 6 months to 4 years need multiple doses to be up to date, including at least one dose of 23-24 COVID-19 vaccine. And then individuals who are moderately or severely immunocompromised may receive additional doses of COVID-19 vaccines. And then one additional recommendation that I'll highlight on the next slide is regarding additional dose in adults age 65 and older. Next slide, please. So in February, this is reviewing the meeting, we reviewed evidence to inform recommendations for an additional dose of a 23-24 COVID-19 vaccine for adults age 65 and older. We reviewed evidence regarding hospitalizations, coverage, and vaccine effectiveness in this age group, and then an additional economic analysis of an additional dose of COVID-19 vaccine, and then the evidence to recommendations framework. Based on this evidence, ACIP voted to recommend an additional dose of 2324 COVID-19 vaccine in persons 65 years of age and older. And then at our meeting in February, we also discussed next steps for the COVID-19 vaccine program, including a recommendation that we shift to a vote in June about future vaccine updates, and that's what we're going to talk about today. Next slide, please. So, to review ACIP COVID-19 vaccines work group meeting work, we started after that February meeting with some initial planning. And that planning was regarding framing the policy question for the 24-25 vaccine. And where the work group started was with considerations for a universal recommendation versus a risk-based recommendation. To inform that conversation, we reviewed international COVID-19 vaccine policies from countries with risk-based and age-based recommendations. And then we discussed various attributes of a potential risk-based recommendation, including defining risk groups for severe outcomes, deciding whether to take into account high risk of exposure in those considerations, and then also we had extensive discussions about recommendations for persons who did not meet risk criteria, including those who were not previously vaccinated. And then in addition, we discussed implementation challenges with a non-universal policy option. Based on an extensive and deliberative conversation in the work group consensus was to proceed with deliberations for a universal recommendation for everyone aged 6 months and older for the 24-25 COVID-19 vaccine. Next slide, please. So then to review our work from March to June, again, we talked about the framing of the policy question for the 24-25 season, and that was an important step in the process. After that conversation, we moved on to review of COVID-19 epidemiology, including risk factors for hospitalization due to COVID-19, as well as the epidemiology of multi-system inflammatory syndrome in children, or MIS-C. We also reviewed the epidemiology of post-COVID conditions. We then reviewed vaccine effectiveness of the 23-24 COVID-19 vaccine. We heard a presentation on COVID-19 vaccine safety, including longer-term outcomes of myocarditis. We also reviewed economic analysis for COVID-19 vaccination, as well as a number of programmatic considerations. And then that all was integrated into the evidence to recommendations framework. And what I'm reviewing here on the slide is also very closely aligned with what we're going to review today in this morning's session. Next slide, please. And then as we heard from Dr. Kaslow, FDA's VRBPAC met to discuss strain selection and advised manufacturers to develop a monovalent JN.1 lineage with a preference for a KP.2 strain if feasible, with the anticipation that 24-25 vaccine doses will be broadly available in the fall. Next slide, please. So here's the agenda for this morning. We will hear from Dr. Havers around COVID-19 associated hospitalizations. Following that, we'll hear from Dr. Link Gellis, who will review data on COVID-19 vaccine effectiveness. Following that, we'll hear from Dr. Duffy, who will review vaccine safety updates for the 23-24 COVID-19 vaccine. Following that, we'll hear from Dr. Prosser, who will review an economic analysis of COVID-19 vaccination. Following that, we'll hear from Dr. Panayotopoulos, who will review the evidence to recommendations framework. And following that, we'll hear from Dr. Stokely, who will review various aspects of COVID-19 vaccine implementation. And then there will be a vote today on the use of 24-25 COVID-19 vaccines in persons aged 6 months and older. Next slide, please. So, a sincere, heartfelt thanks to the work group members, including the ACIP members who join us on the work group. That includes Dr. Brooks, Dr. Schechter, and Dr. Talbot. I want to thank the ex officio and government members, the liaisons and the consultants, and then the outstanding leadership of our CDC co-leads, Dr. Wallace and Dr. Panayotopoulos. And next slide, please. As well as a long list of CDC participants who I'd like to, again, thank so much for the work that they do so that we can do all the thoughtful considerations around COVID-19 vaccine policy decisions. Next slide, please. So turn it back to you, Dr. Talbot.
It truly takes a village. You have a very nice village, too. So we're going to start with Dr. Havers and then move on to Dr. Link-Gellis. These two presentations will be back-to-back, and then questions will be after. Just as a reminder, questions start with the voting members, and then our liaisons can ask questions. They just have to raise their hands in the meeting. So, Dr. Havers.
Thank you, Dr. Talbot. Today, I'm going to be presenting on COVID-19 associated hospitalizations among children and adults. Next slide. So most of the data today will be coming from the COVID-19 Hospitalization Surveillance Network, or COVIDNet. COVIDNet is a population-based surveillance that collects data from more than 300 acute care hospitals in 98 counties across 13 states. The COVIDNet catchment area includes about 10% of the US population. And hospitalizations reported to COVIDNet include all of those where a positive SARS-CoV-2 test result was reported within 14 days prior to or during hospitalization. And the testing for SARS-CoV-2 is driven by clinical judgment or facility policies. Data on rates and basic demographic data are collected on all patients, and clinical data are collected on age and site stratified representative sample. Next slide. This slide shows two figures. The figure on the left shows the weekly rates of COVID-19 associated hospitalizations among all age groups from the beginning of the pandemic, from March 2020 through May of 2024. The figure on the right shows cumulative hospitalization rates by age group from October 2023 through May of this year. I'm going to be showing variations of these figures as I talk first about all age groups, then focus on pediatric hospitalizations, then adult hospitalizations. As you will note, rates among adults ages 75 years and older, indicated by the dashed purple line, were among more than 3 times as high as those in the next youngest age group, adults ages 65 to 74, indicated by the solid green line. Rates among adults ages 65 to 74 and infants less than 6 months, shown in pink, have roughly equal rates of COVID-19 associated hospitalization, a trend that is evident in both figures. Next slide. Since the beginning of the pandemic, we have been reporting on disparities in hospitalizations by race and ethnicity. This slide shows recent cumulative age-adjusted rates of COVID-associated hospitalizations from October through May. As you can see, racial and ethnic disparities persist, with the highest hospitalization rates among non-Hispanic American Indian and Alaska Native persons, shown in red, and non-Hispanic Black persons, shown in blue. Rates among Hispanic persons in purple and non-Hispanic white persons in yellow were similar during this period, although this differs by age group. The lowest rates were among non-Hispanic Asian persons and Pacific Islanders in green. Next slide. This figure shows the percent of COVID-19 associated hospitalizations by age group by week from March 2020 through May of 2024. Adults over 65 and older are shown in varying shades of blue. Younger age groups are shown in gray. Over time, the proportion of hospitalizations has shifted to older age groups. For the period of October through May of this year, highlighted in the red box, adults ages 65 years and older comprise 67%, or 2/3, of all COVID-19 associated hospitalizations captured in COVIDNet, with adults 75 years and older comprising almost half of those hospitalizations. Note that children and adolescents ages 17 years and younger are shown in the darkest gray, and they comprise 4% of all COVID-19 associated hospitalizations. Next slide. I'm now going to shift the focus to focusing on epidemiology of pediatric hospitalizations. Next slide. These are the same figures that you saw earlier, but showing only pediatric age groups. Infants less than 6 months, shown in pink, had recent cumulative hospitalization rates that are approximately 6 times that of hospitalization rates in children ages 6 months to 4 years, the pediatric age group with the second highest rates. Of note, as you all know, infants less than 6 months are not eligible for COVID-19 vaccination, and maternal vaccination during pregnancy is critical to providing protection for this age group. Next slide. This slide removes the less than 6 month age group to allow more insight into differences among age groups 6 months and older. Hospitalization rates in infants and children 6 months to 4 years are higher than those among 12 to 17 years, shown in green, and those 5 to 11, those are shown in yellow, and then those 5 to 11 years shown in green, which is the age group that has the lowest hospitalization rates currently. Next slide. The next few slides focus on underlying medical conditions of those children that are still being hospitalized for COVID, which in this data includes data from July 2023 through March of 2024. Overall, 50%, or half of pediatric hospitalizations, the children have no underlying medical conditions. But the prevalence of underlying medical conditions in children hospitalized with COVID-19 increases with increasing age. This slide here shows, splits out age groups for children under 5, the age group that currently comprises about 70% of all pediatric hospitalizations. The majority of hospitalized children less than 2 years have no underlying medical conditions. In this age group, shown in the left with children less than 6 months, and those in the center cluster of columns for those ages 6 months to 2 years, prematurity, indicated by the light blue column, cardiovascular disease, including congenital heart disease, indicated in purple, are the most common underlying medical conditions in children hospitalized for COVID. In children ages 2 through 4 years, and the final cluster of columns, a majority of children, approximately 2/3, do have an underlying medical condition, the most frequent of which were asthma or reactive airway disease in yellow, and neurologic disorders in green, as well as feeding tube dependence in orange, and cardiovascular diseases in purple. Next slide. This is a similar chart, but showing the most frequent underlying medical conditions in children hospitalized for COVID in those ages 5 to 11 on the left and 12 to 17 years on the right. As you can see here, the prevalence of underlying medical conditions is much higher, and only about 1 in 5 children in these age groups have no underlying medical conditions, which is different than the epidemiology we saw in infants and younger children. Between these age groups, the most prevalent underlying conditions include asthma, the yellow column, and neurologic disorders in green, as well as feeding tube dependence. And the high prevalence of neurologic conditions is notable because it's very disproportionate to the proportion of how frequent those conditions are seen in the population. Next slide. So this is a slightly different way of looking at similar data. And it shows data on conditions by the age groups listed in the left column. The first column with percent shows the proportion of all children hospitalized for COVID who had no underlying conditions by age group, which is the same numbers that you had seen on the previous slides. And then the next column shows what proportion among those admitted to the ICU had no underlying medical conditions. So overall, among pediatric patients admitted to the ICU, 40% had no underlying medical conditions, although this was somewhat driven by infants and young children under 5 who had a higher proportion with no underlying medical conditions compared to older children and adolescents admitted to the ICU. And then the rightmost column shows the percent of hospitalized patients with no underlying conditions who were admitted to the ICU. Overall, among children and adolescents hospitalized for COVID-19 with no underlying conditions, 18% were admitted to the ICU, suggesting that severe illness can occur in previously healthy children. Next slide. So this final pediatric slide describes the proportion of COVID-19 associated hospitalizations by vaccination status among vaccine-eligible age groups from October through March. Hospitalized children who had a record of the most recent vaccine that was available in fall 2023 are shown in green. Those who had a record of a vaccine from fall 2022 onwards, but not the most recent vaccine, are shown in blue. And those with no record of any vaccine since August 2022 are shown in yellow. Overall, 5% of children and adolescents hospitalized with COVID-19 had received the vaccine that was available in 2023-24, the most recent available prior to hospitalization. And the vast majority of hospitalized children had not received the vaccine, had not received this vaccine that was available in fall 2023 or any vaccine in the preceding year. Next slide. I am now going to move on and focus on the epidemiology of COVID in adults. Next slide. Again, these are similar figures to what we've seen before, but now just showing adult age groups. Again, we see the cumulative rates beginning in October 2023 through May 2024 on the right, highlighting again the disproportionate burden of disease in adults 75 years and older in the dashed purple line. The cumulative rate in this population was 948 per 100,000 population, or just under 1% of the population of this age group. Next slide. This slide is highlighting an important adult group, namely long-term care facility residents. And what you're seeing in the bar graph is the proportion of those hospitalizations in adults 65 years and older that occurred among those who resided in a long-term care facility by quarter. And the dates from the slide is from January 2022 through March of 2024. Overall, about 19%, or about 1 in 5 adults 65 years and older, were hospitalized with COVID-19 resided in a long-term care facility. And if you look only at adults 75 years and older, that number is about 1 in 4. Next slide. I've been talking about hospitalizations, but this slide is focusing on in-hospital deaths. The bar chart shows the population-based rates of in-hospital deaths during COVID-19 associated hospitalizations by age group from October 2023 through March of 2024. Rates of in-hospital death during hospitalization increase with increasing age, with the rates in adults 18 to 49 being less than 1 per 100,000, but increasing to 62 per 100,000 population among adults 75 years and older. The table below shows the weighted percentage of in-hospital deaths by age group. Those 65 years and older comprise 82% of all in-hospital deaths, and half of all in-hospital deaths for all COVID hospitalizations occur in those 75 years and older. This proportion is actually even higher when out-of-hospital deaths are considered, as those in the oldest age groups with COVID may be more likely to be discharged to hospice or die in other care settings. Next slide. This is a similar slide to what I showed you for the pediatric age groups, but this is among hospitalized vaccination status among hospitalized patients by age group for October through March of 2024. Although the proportion of hospitalized adults who had received a vaccine in the most recent season, as shown in green, is higher than for pediatrics. Only about 11% of COVID-19 associated hospitalizations among adults 18 and older were associated with having received a vaccine this season. And the majority, more than 57%, had not received any COVID-19 vaccine since August of 2022, which are the bars shown in yellow. Next slide. I think in the interest of time, I may skip over this slide. This is showing the prevalence of underlying medical conditions by age group among COVID-19 hospitalizations, but we have similar data in another analysis, so we can come back to that if there are questions. Next slide. This is an ongoing analysis of risk factors for hospitalization, and for this, which is an analysis conducted by Dr. Sarah Hamid, we use data from COVIDNet, the US Census, and the Behavioral Risk Factor Surveillance System, or BRFSS, to compare the prevalence of chronic conditions among persons hospitalized with COVID-19 to the general US population. Briefly, BRFSS is an annual telephone-based survey that collects health data from US residents, and including self-reported history of select chronic conditions. So this is an ongoing analysis, and so please consider these results as preliminary. Next slide. So this chart shows the prevalence of select underlying medical conditions in the analytic study population. And this is restricted to COVID-19 associated hospitalizations, which are shown in blue. And the prevalence for these conditions are shown for the states participating in COVIDNet, which is in gray, and the US population as a whole, which is shown in black. And you can see that the prevalence of these underlying conditions in the COVIDNet states is similar to that of the US population, the gray and the black bars. But as expected, the prevalence of most of these underlying conditions is higher in the COVIDNet hospitalized cases, the blue bars, than in the US population. There are some exceptions on this graph here, including asthma and obesity, where the prevalence between hospitalized COVID-19 patients and the general population is similar. Although when we restricted to severe obesity or a BMI of 40 and over, the prevalence among COVID-19 hospitalized cases was higher than in the general population. These columns show unadjusted prevalence of these conditions, but adjusted models were also created to examine these conditions by age group, as the prevalence of these conditions vary by age group. Except for obesity, all the other conditions examined in adjusted models were found to increase the risk of COVID-19 associated hospitalizations. But even in models that adjusted for chronic conditions and other factors, increased age, specifically ages 75 years and older, remained a strong risk factor for COVID-19 associated hospitalization. One other caveat is that BRFSS is limited to community-dwelling adults. So adults admitted from long-term care facilities were excluded from this analysis, including from the COVIDNet cases. So this is one limitation of this analysis and may limit the generalizability of these results to non-community dwelling populations. So next slide. So in summary, for recent pediatric hospitalizations, rates of COVID-19 associated hospitalizations are highest among those 4 years and younger. Rates among infants ages 6 months and younger than 6 months who are not eligible for vaccine and are the highest. And this population requires a different approach for prevention, namely maternal vaccination during pregnancy. Among all pediatric patients, 50% have no underlying medical conditions, although this varies a lot by pediatric age group. And among those children admitted who have no underlying medical conditions, 18% were admitted to the ICU. And then again, for the recent October through March period, only 5% of the children who were hospitalized for COVID, who were in vaccine-eligible age groups, had received the most recent recommended vaccine prior to admission. Next slide. And to summarize for adults, 2/3 of all COVID hospitalizations occur among those 65 years and older, with a disproportionate burden in those 75 years and older. And from October through March, again, most hospitalized patients who had been hospitalized for COVID had not received the most recent vaccine. Only about 10% of adult patients had. Underlying medical conditions do increase the risk for hospitalization, but age remains strongly associated as an independent risk factor for hospitalization as well. Next slide. So I would like to acknowledge a large number of people in the Corona and other respiratory viruses division, as well as the RespNet site investigators and staff. And I think on that note, I'm going to turn it over to Dr. Link Gellis, and then we'll take questions.
Thank you. Next slide. So today I'll be presenting on updated COVID-19 vaccine effectiveness data from CDC among children and adults with against various outcomes shown here. But before we dive into the main content, I wanted to share a brief refresher on VE methods and some context for interpretation of COVID-19 VE. Next slide. There are a number of study designs used for vaccine effectiveness, but the most common for COVID-19 VE has been the test negative design, or TND, which you also heard about during yesterday's RSV adult vaccine effectiveness presentation. In a TND, everyone who meets a clinical case definition, in this case persons with acute respiratory illness or COVID-19-like illness, are enrolled, and those who test positive for the disease of interest, in this case SARS-CoV-2, are classified as cases, while those who test negative are classified as controls. Finally, vaccination status between cases and controls is compared, yielding an odds ratio. In a TND, enrollment is not based on test status, but based on a clinical case definition. Data can be ascertained through electronic healthcare records and based on clinician-ordered testing, or based on active enrollment and swabbing of persons meeting the clinical case definition. VE is calculated as 1 minus the adjusted odds ratio times 100%, with the adjusted odds ratio comparing the odds of vaccination among cases and controls. Next slide. There are a number of benefits of the test negative design. First, the TND reduces bias from healthcare seeking behavior by including cases and controls with similar symptoms who presented to care and received testing, usually at the same facility. Second, TNDs are an efficient use of resources because cases and controls are identified through the same healthcare system or testing location, rather than needing one system for cases, such as a hospital, and another for controls, such as random digit dialing. There are also a number of considerations for TNDs. First, they're dependent on the sensitivity and specificity of diagnostic testing and can be particularly impacted by decreases in test specificity, which can result in truly negative individuals testing positive and being misclassified as cases. Second, because vaccination behaviors for different diseases can be correlated, controls who are positive for another vaccine-preventable disease can bias results. For COVID-19, it can be helpful to consider if the exclusion of influenza-positive controls meaningfully changes vaccine effectiveness estimates. Next slide. Finally, it's helpful to keep in mind that vaccine effectiveness is a population-level estimate, not an individual-level estimate. If a vaccine has a VE of 80%, it does not mean that the vaccine will only work 80% of the time. It does mean that in a vaccinated population, 80% fewer people will have the outcome studied when they come in contact with the virus. Next slide. So now moving on to some context for interpretation of the VE estimates I'll share today. These graphs show COVID-19 vaccination coverage among adults on the right and children on the left from September 2023 through April 2024. As with previous years, coverage rates increase with increasing age, and the lowest coverage rates are among children in the youngest age groups, which impacts ability to estimate VE. Next slide. And as some additional context for interpretation of our VE estimates, it's helpful to see SARS-CoV-2 infection-induced immunity. By July through August of 2023, just before the 23-24 vaccines were introduced, individuals in the US had high rates of infection-induced immunity, above 70% for all age groups and almost 90% for those aged 16 to 49 years. Infection can provide some protection from future infection, and VE findings should therefore be interpreted as the incremental or additional benefit provided by COVID-19 vaccination in a population with a high prevalence of infection and vaccination-induced immunity. Next slide. Before diving into VE estimates, a note here on what the studies presented today evaluated. Previously, for COVID-19, we presented results as absolute or relative VE, shown here in the top and middle rows. Absolute VE compares the frequency of health outcomes in vaccinated versus unvaccinated people, for example, those who received a 23-24 dose to those who received no COVID-19 vaccine ever. Relative VE compares the frequency of health outcomes in people who received one type of vaccine to people who received a different type of vaccine. For example, people who received a 23-24 dose versus those who received a bivalent dose. This year, COVID-19 VE studies have largely shifted to looking at a combination of absolute and relative VE. Today, I'll present estimates of VE comparing those who received a 23-24 dose to those who did not receive a 23-24 dose, regardless of past vaccination. In other words, the comparison group includes people who are unvaccinated, as well as those who received original monovalent or bivalent doses. Of note, this is similar to how influenza vaccine effectiveness is measured. Next slide. I'll first share VE against symptomatic SARS-CoV-2 infection from the Increasing Community Access to Testing, or ACIP program. Data shared today represent updates to analyses published in CDC's MMWR at the beginning of February. Next slide. ICAT includes data from nationwide community-based pharmacy testing for SARS-CoV-2. COVID-19 vaccine history is self-reported at the time of test registration and uses a TND. For this analysis, we included adults aged 18 and up with one or more COVID-19-like symptom and testing via nucleic acid amplification, or NAT. We excluded adults who reported an immunocompromising condition and those who reported a positive SARS-CoV-2 test in the preceding 90 days. The full analysis shared today uses methods previously published in MMWR, but is updated with data through May 2024. A sub-analysis uses S-gene target failure as a proxy for BA.2.86 and JN.1 infection with slightly different dates. Next slide. Here we see results from the full analysis with people 18 and up included in the top block above the blue line and then split by age group 18 to 49 and 50 plus below the blue line. VE is shown comparing receipt of a 23-24 dose to no receipt of a 23-24 dose by time since receipt of that 23-24 dose, 7 to 59 days, 60 to 119 days, and 120 to 179 days. In the second column from the right, note the median time since receipt of last dose, which was almost 2 years for younger adults and over 1.5 years for older adults. VE for the full time period for those 18 and up was 45% and was similar by age group, although there were less tests in the older adult group and therefore the confidence intervals are wider. Next slide. As mentioned, we were able to use S-gene target failure as a proxy for infection with BA.2.86 and JN.1. This graph shows estimated proportions of SARS-CoV-2 S-gene target results and variant proportions in red and blue from genomic surveillance during the analytic period. The red indicates S-gene target presence or likely XBB lineages, while the blue shows S-gene target failure or likely BA.2.86 and JN.1 lineages. The black line shows the proportion with S-gene target presence from ICAT data, which tracks the proportion via the genomic surveillance, indicating that S-gene target failure is a good proxy for BA.2.86 and JN.1 lineages. The proportions deviate slightly in the most recent weeks when there was relatively little ICAT testing, though this did not impact our analysis. Next slide. This slide shows results of the sub-analysis using S-gene target failure. Because of the timing of emergence of JN.1, There was not statistical power to estimate VE in the 7 to 59 days after vaccination. So here we show only the 60 to 119 day period. S gene target presence, or likely non-JN.1 lineages, is shown on the top with a median of 73 days since the last dose and a VE of 58%. S gene target failure, or likely JN.1 lineages, is shown on the bottom with a median time since dose of 89 days and a VE of 37%. Note that while the point estimates differ quite a bit, the confidence intervals between the estimates do overlap somewhat. Next slide. Moving on now to estimates against emergency department and urgent care visits from Vision. As with ICAT, these methods were published this past winter in CDC's MMWR, but the results today include additional, more recent data. Next slide. Vision is a multi-site network of electronic healthcare records using a test-negative design. This analysis included adults visiting one of more than 360 emergency departments or urgent cares, or 229 hospitals with COVID-like illness and a SARS-CoV-2 NAT test result within 10 days before to 72 days after the encounter. Cases were patients with a positive NAT for SARS-CoV-2 and no positive NAT for RSV or influenza. Controls had a negative SARS-CoV-2 test and no positive influenza test. Vaccination was documented by electronic health records and state and city registries. Next slide. As before, this slide shows results with adults aged 18 and up on the top block and separated into age groups 18 to 64 and 65 plus on the bottom. And as before, we show VE split by 7 to 59, 60 to 119, and 120 to 179 days since the 23-24 dose. In the 18 plus group, where we had the most power, VE was 50% in the first 7 to 59 days post-dose, 32% in the 60 to 119 days, and 2% in the 120 to 179 days after the 23-24 dose, with non-overlapping confidence intervals. This same trend was apparent in both age groups, and VE was generally similar for 18 to 64-year-olds and those 65 plus. Next slide. Now we'll move on to results from Vision and IV networks for VE against hospitalization, which have also been updated since the MMWR during the winter. Next slide. Starting with Vision results, and as with previous result slides, we have VE for 18 and up on the top and split by age group on the bottom, with results shown by time since dose. VE was 50% for 18 plus in the first 7 to 59 days after the dose, 41% in the 60 to 119 days after the dose, and 16% in the 120 to 179 days, with some overlapping confidence intervals. Note that due to both lower vaccine uptake and lower hospitalization rates, confidence intervals for the 18 to 64 group were wide, particularly in the longer time since dose strata. Next slide. Here we have VE against hospitalization split by immunocompromised status. The estimates on the top are for those without immunocompromising conditions and are the same as those shown on the previous slide for those 18 plus. On the bottom, VE for adults with immunocompromising conditions is shown. Trends are similar across the two groups, with point estimates somewhat lower in the immunocompromising group, though confidence intervals overlap. Next slide. Here we have VE against critical illness, which is defined as admission to an intensive care unit or death while hospitalized or within 28 days after hospital admission. As with previous formulations, we see what appears to be more sustained VE for critical illness, the most severe outcome, versus infection and hospitalization, though the confidence interval in the 120 to 179 day group is quite wide. Next slide. Moving on now to the IV network, a multi-site VE platform that uses a test-negative design with enrollment at 26 hospitals. Participants were adults hospitalized with COVID-like illness. Cases have a SARS-CoV-2 positive NAT or antigen test with no positive influenza or RSV test. Controls are negative for SARS-CoV-2 and influenza by NAT. Vaccination history is ascertained through electronic medical records, state and local vaccine registries, and self-report, and specimens are collected for central testing and sequencing. Next slide. As with the vision results, here we see 18 plus on the top and then split by age group on the bottom. Note that IV analyses did not have statistical power to estimate VE separately by age and time since dose. In the 18 plus group, VE in the first 7 to 89 days was 41%, and in the 90 to 179 days earlier was 27%, with overlapping confidence intervals. The point estimate for those 65 plus is lower than younger adults, but with confidence intervals that overlap. Next slide. The IV network also collects specimens and conducts whole genome sequencing. For this analysis, they restricted cases to those with sequence-confirmed JN lineage or XBB lineage infections during October 18, 2023 through March 9, 2024. During this period, sequencing was successful for 63% of case patients. VE was calculated separately using case patients with sequence-confirmed SARS-CoV-2 JN1 lineage and XBB lineage infections. Next slide. This graph shows results of the sequencing with XBB lineage admissions in blue and JN lineages in orange. You can see the gradual increase in JN lineages over time, taking off in December and January 2023, which matches the national sequencing data. Next slide. Here we see VE results by lineage with XBB on the top and JN on the bottom. VE estimates are similar to those from ICAT, with point estimates showing lower VE for JN lineages, though some protection remaining for those lineages. Next slide. Finally, I'll share some results of VE across age groups, including among young children from the Vision Network. Next slide. As a reminder, young children are recommended to receive more doses than adults. Previously unvaccinated children are recommended for a complete initial series of 23-24 vaccine, including 2 doses of Moderna or 3 doses of Pfizer vaccine. Children who previously received doses of COVID-19 vaccine are recommended to receive different numbers of doses based on how many previous doses they received, but all young children are recommended to receive a complete initial series, either including or with the addition of a 23-24 dose. Next slide. This slide shows VE results against ED-UC encounters in Vision, split by age group and time since dose. The top section includes the referent group, which includes persons who did not receive a 23-24 dose, including both unvaccinated persons and those who previously received original monovalent or bivalent doses. In the middle, we have VE by age group during the 7 to 59 days after receipt of a 23-24 dose. You'll notice that the youngest age group is those 9 months to 4 years of age. The 9-month cutoff was used to allow time for the 6-month-olds who were newly eligible for vaccination to complete the Pfizer primary series, which takes approximately 13 weeks. You'll see that VE is similar across age groups with wider confidence intervals in children due to both lower vaccine coverage and lower SARS-CoV-2 positivity. The bottom section includes VE in the 60 to 179 days since the 23-24 dose, and here the confidence intervals in the youngest children are really too wide to interpret, but the other age groups look quite similar. Next slide. So finally, just to conclude, the 23-24 COVID-19 vaccination provided increased protection against symptomatic SARS-CoV-2 infection and COVID-19 associated emergency department and urgent care visits and hospitalizations compared to no receipt of the 23-24 vaccine dose. Waning patterns appeared similar to previous COVID-19 vaccine formulations, with the most durable protection appearing to be for critical illness, though statistical power was lacking in the longest time period since vaccination. As with previous COVID-19 vaccine formulations, effectiveness was similar across age groups, and receipt of the 23-24 COVID-19 vaccine provided protection against JN1 and other circulating variants, though it may be lower than protection provided against XBB sublineage variants. Next slide. I'd like to thank the many investigators who contributed to these analyses, including Vision and IV site investigators. And I think we're happy to take questions now for both my presentation and for Dr. Havers.
Any questions? Go ahead.
For the audience, this is Sarah Long. Dr. Link-Ellis, your summary slide, your conclusions were a little brighter than the data seem to be. They're true, related, but you know, there are two possible conclusions. I think one more likely than the other. The first that's not as likely is it's not a great vaccine. Not only does it not have legs, but it doesn't have the kind of effectiveness that we would like if we give it to the entire population. The other, which I bet is more likely, is that those who had previous infection and those who have vaccine are getting a little closer together. And it may be difficult to get, and both infection-induced partial protection wanes, as does vaccine, and probably that's most likely considering this is a respiratory infection. And the lower levels of disease and hospitalizations that you showed us at the beginning probably go along with either a virus that's not quite as virulent or more likely that there's more partial protection. So that gets to be a very difficult thing also with a virus that's mutating all the time, to try to understand if more and more and more immunizations are going to be helpful. And you probably don't want to say anything about that, and we'll see what the work group thinks. Does anybody want to comment? Am I off in my conclusions? And it looked like the best protection was in the youngest, who probably are a little less naturally exposed by then, and that as you get older, until you get quite older, when you're protecting yourself better probably from exposures, it's an interesting, difficult thing. I suspect we'll see this in the cost-effectiveness models. And the other problem that I didn't know about that you showed us is that the hospitalizations looked like they were in every month. It wasn't all so seasonal as I thought it probably would have been in the last year. So it's really tough with a 6-month vaccine.
Yeah. Dr. Long, I think many of this will be addressed as I go through the ETR, because there are a lot of questions.
I guess I just want to check if anybody thinks that there's another interpretation or I didn't get it.
No, I think your interpretation is generally correct. The estimates that we have this year, which are fairly similar to the estimates that we saw for vaccine effectiveness last year, and sort of similar patterns of waning and similar patterns across age groups. I think it's really important, as you said, to keep in mind that this is really, should be interpreted as the incremental or additional effectiveness in a population with a lot of underlying immunity. So this is a population in the United States that has had, most of us, the vast majority, have had at least one, probably numerous, COVID-19 infections, and multiple vaccines for the majority of the population as well. If you think back to the early days, most of the population did get the primary series. And so because of that, we're not thinking here about whether the vaccine protects absolutely compared to a completely naive population that we had in 2020. It's really, if you think about a certain amount of immunity in the population, what can we give people beyond that? Can we get them a little bit better protected, a lot better protected? And I think especially as you're thinking about older adults, pregnant people, people with a lot of underlying conditions, or those that are immunocompromised, a vaccine effectiveness of 40% or 50% is really a substantial decrease in their risk of hospitalization, critical illness, or death. So it's not the 95% we were seeing in the very early days, but we also don't need that level of protection because we're really looking at increasing people's already existing protection.
And I guess the other thing I would just suggest in trying to let the public understand this, I don't think I would call it vaccine, infection-induced immunity. I would try to use a different word. Your studies, I suspect, are seroprevalence, is that right? And the seroprevalence marker that you use is antibody. And does the antibody distinguish prior immunization from from infection? Okay, so you know that. I think I would probably call it partial protection or antibody rather than say infection-induced immunity, because those people aren't completely protected either. As you've shown, there is additional benefit of a vaccine.
Thank you. Dr. Brooks?
Yeah, first of all, Dr. Long asked and addressed a number of the thoughts that I had. One about infection-induced immunity versus just immunity. I was really, and the other thing, incremental. I think that's really important to understand, or not understand, but to ingest that we're getting incremental benefit for a population that is highly immune already. But the most compelling thing was against critical illness and death, or critical illness including death, where that was the highest rate of benefit from the vaccine. And then just another comment on the first presentation up here was slide number 3. It had the cumulative rate for those 75 and older at 1,000 per 100,000, which means 1% of all those 75 years and older were hospitalized. That's pretty compelling. I think of everything we saw in both presentations, that on the right, 1 out of 100 got hospitalized. So if we're going to focus on anything as it relates to vaccinating, it's going to be, to me, that age group. And somehow we need to get that message out to the general population. They already are the highest level of those vaccinated anyway, but we need them to be at 99%.
Lots of questions.
Follow up on his?
I'm happy to answer a question, but I would say that I think we've seen over and over again that COVID in older adults is still a major problem and is causing a huge burden of disease in that population. And we also saw that among this population, they were definitely under-vaccinated. This is an area where there's a lot of room for improvement and could prevent a lot of hospitalizations, because we saw most of these patients that were hospitalized in this age group were not vaccinated with the most up-to-date vaccines.
All right, Dr. Lair, briefly, because we are over time. Really, Dr. Shaw, you can ask.
I guess I was just going to make a kind of more of a glass half full comment that I think we all know that antibodies required for acquiring any illness wane more quickly, but I think things like T-cell immunity that protects you against critical infection, they're boosted by vaccination and do not seem to be as affected by variants. And I think that's reflected in the fact that we see relatively robust, comparatively robust protection against critical illness that persists. So that's kind of what the vaccine is supposed to do.
Dr. Schechter?
Just briefly, what are the estimates of coverage of pregnant persons currently? I'm just continue to be struck by those 0 to 6 month hospitalization rates approximating age 65, and is there any additional information about effectiveness or any reason to think that we shouldn't be continuing our efforts to promote prenatal immunization?
So I'll save the question about coverage rates in pregnant people for later presentations that we'll get into the implementation. I will say, looking at Dr. Haver's presentation, we see very clearly that the highest rates of disease in kids are in those under 6 months, so not eligible for vaccination. So I think that really brings home the importance of maternal vaccination to protect those kids. We have not had statistical power this year to estimate vaccine effectiveness amongst pregnant people for protection of their infants, but we do know from past seasons that the vaccine does provide pretty substantial protection for infants in those first couple of months of life when they're most vulnerable.
Ms. Arthur?
Thank you. This is about Dr. Haver's slides on showing race, ethnicity, and age. And I think that's very compelling, but I wonder if it would be possible to also look at that data by socioeconomic status. I think that it would help very much the way Dr. Brooks suggested in helping people see themselves in the data. I would contend that probably someone who has low access to healthcare and low socioeconomic status in a rural area who's Caucasian American may have the same high risk of bad outcomes as an African American on the data. I wonder if we could look at zip codes or some other mechanism for parsing out by social determinants of health.
Yeah, thank you for that comment. We do have data, geocoding data, and we can look at social vulnerability index based on the data that we're collecting. We have an ongoing analysis that's looking at this now. We do know that a lot of the racial and ethnic disparities are correlated with socioeconomic status, and we definitely appreciate that comment.
All right, moving on. Dr. Duffy about vaccine safety updates.
Okay, thank you. CDC is continuing to monitor COVID-19 vaccine safety using 3 complementary surveillance systems. This presentation will summarize findings from each system for the 2023-24 monitoring period. The key points in this presentation will be the following. The vaccine safety data link identified 2 statistical signals this season. One was for Guillain-Barré syndrome following Pfizer vaccine among people aged 65 years and over. An association between mRNA COVID-19 vaccines and GBS had not been observed prior to this season in VSD or other systems. The increased rate observed this season may or may not represent a true risk, but if there is a true risk, it is estimated to be similar to what is considered acceptable for other adult vaccines. The other signal was for ischemic stroke following Moderna and Pfizer vaccines. The VSD previous, next slide. Next slide. The other signal was for ischemic stroke following Moderna and Pfizer vaccines. The VSD previously observed a statistical signal for ischemic stroke during 2022-2023 for the bivalent Pfizer vaccine. However, available data do not provide clear and consistent evidence of a safety problem for ischemic stroke with mRNA COVID-19 vaccines. No other new or unexpected safety concerns were identified for the 23-24 COVID vaccines. Next slide. So the first system is the Vaccine Adverse Event Reporting System, which is called VAERS for short. Next. VAERS is the National Passive Vaccine Safety Surveillance System co-managed by CDC and FDA. VAERS accepts individual case safety reports of adverse events following vaccination, and the report of an adverse event to VAERS is not documentation that a vaccine caused the event. Next. VAERS has received 13,491 reports following COVID-19 vaccines for the 23-24 season. Most were for Pfizer, followed by Moderna and Novavax. The median age of vaccine recipients was 59 years. 93% of reports were classified as non-serious. Next. The most frequently reported adverse events were COVID-19, fever, fatigue, headache, and pain. VAERS did not identify any new or unexpected safety findings for the 23-24 formulation. Next. The second surveillance system is vSafe. Next. vSafe is a web-based survey system. Participants self-enroll using the vSafe website. Surveys are sent daily during the first week after vaccination, then weekly through week 6. Surveys ask about post-vaccination experiences, including local and systemic reactions and health impact events. Next. For the 23-24 season, 10,143 people aged 3 years and older participated in vSafe. 99% were adults, with most over the age of 60. Next. About 50% of participants reported any local or systemic reaction within the first week after vaccination. About 10% had symptoms that made them unable to complete daily activities, but few sought medical care for a reaction. Next. The third system is the Vaccine Safety Data Link, called VSD for short. Next. VSD is a collaborative project between CDC and 13 integrated healthcare organizations with an insured population of approximately 13.5 million people annually. Next. The VSD uses a method called rapid cycle analysis to conduct vaccine safety surveillance. This method uses sequential monitoring as data become available to monitor a limited set of pre-specified outcomes of special interest. The method is designed to detect statistical signals, which are defined as values above specified statistical thresholds. Statistical signals are potential associations, and further investigation is required before concluding that a safety concern exists. Next. The VSD rapid cycle analysis for this season used data from September 23 through April 2024 and evaluated the first COVID-19 vaccine dose received per person during this period. The analysis used the COVID-19 vaccinated concurrent comparator method. The analysis was adjusted for outcome date, age, sex, race, ethnicity, and VSD site. A statistical signal was defined as a one-sided p-value less than a pre-specified threshold determined from an alpha spending plan that kept the overall chance of a type 1 error less than 0.05 during the surveillance period. Rate ratios with exact 95% confidence intervals were also calculated. Next. 11 pre-specified outcomes were monitored this season, including encephalomyelitis, myocardial infarction, Guillain-Barré syndrome, stroke, thrombocytopenia, myocarditis, pericarditis, pulmonary embolism, seizure, and transverse myelitis. Outcomes were identified using ICD-10 codes assigned to emergency department and inpatient healthcare visits. Next. Primary analyses were done for each vaccine type using both 21 and 42-day post-vaccination risk intervals for 5 different pre-specified age groups. The primary analyses included a total of 220 different comparisons across the 11 outcomes. Supplemental analyses were also pre-specified to assess the role of same-day vaccination. Next. Now for the results. Next. In the VSD population, there were 2.4 million doses of Pfizer vaccine administered and 239,000 doses of Moderna vaccine. There were 3,000 doses of Novavax vaccine administered in the VSD, so no safety analyses were conducted for Novavax. Next slide. This graph shows the number of vaccine doses administered by age group. About 90% of doses were administered to adults. Next slide. This graph shows other vaccines administered on the same day as the COVID-19 vaccine. Moderna is shown in the left panel and Pfizer on the right. The blue bars on the left side of each panel show COVID-19 vaccine doses given alone. COVID-19 vaccines were given alone. That's without other vaccines on the same day for almost half of all doses. The orange bar shows that about half of doses were given on the same day as an influenza vaccine. Other vaccines were given on the same day less frequently. Next slide. So statistical signals occurred for 2 of the 11 adverse events under surveillance. Those were Guillain-Barré syndrome and ischemic stroke. Next slide. So this section will provide details about the Guillain-Barré syndrome findings in VSD. Next slide. The statistical signal for GBS after Pfizer vaccine was for the 65 years and older age group. Next slide. To evaluate the signal, medical records were abstracted and potential cases were adjudicated by 2 independent reviewers using the Brighton collaboration case definition. There were 10 chart-confirmed cases. 7 had symptom onset in the risk interval, which was days 1 to 42 following vaccination. 3 had symptom onset in the comparison interval, which was days 43 to 84 following vaccination. Most cases did not receive other vaccines on the same day as the COVID-19 vaccine. Next slide. The chart-confirmed concurrent comparator analysis for Pfizer COVID-19 vaccine among people aged 65 years and older found a significantly increased incident rate ratio of 4.45. Next. When restricting the analysis to Pfizer vaccine given without other vaccines on the same day, the rate ratio was similar but not statistically significant. Next. The number of estimated excess GBS cases is 4.1 cases per million COVID-19 vaccine doses administered to people 65 years and older. Next. So in summary, VSD identified a statistical signal for GBS after Pfizer COVID-19 vaccine in adults aged 65 and older during the 2023-2024 season. The VSD had not identified any signals for GBS with previous mRNA COVID-19 vaccine formulations. The analysis did not suggest that other vaccines administered on the same day accounted for the increased rate. The increased rate ratio observed for Pfizer vaccine during the 23-24 season may or may not represent a true risk because a large number of analyses done over time may find some associations by chance alone, and surveillance analyses may have residual confounding. There were insufficient doses of Moderna or Novavax vaccines administered in the VSD population to assess the rate of GBS with those vaccines, and therefore it's not necessarily a difference in GBS rate following Pfizer compared to the other COVID-19 vaccines. Next slide. So this section will provide details about the ischemic stroke findings in VSD. Next slide. For ischemic stroke, statistical signals occurred for the Pfizer vaccine in the 18 to 64 years age group and for the Moderna vaccine in the 65 and greater age group. All of the following analyses for ischemic stroke were conducted using ICD-10 coded medical visit data. Cases were not chart confirmed using medical records. So first we will discuss the signal for the Pfizer vaccine. Next slide. The signal for the Pfizer vaccine was for the 18 to 64 year age group. Next slide. Analysis further stratified by age did not find an increased rate ratio among people aged 18 to 49, but did find an increased rate among 50 to 64 year old groups. Next slide. So this graph shows the incident rate ratio for ischemic stroke following Pfizer vaccine among people ages 50 to 64, as shown on the previous slide. Next. For comparison, here is the estimate for Moderna vaccine for this age group, which did not signal. Similar to last season, supplementary analyses were done to evaluate the potential effect of same-day influenza vaccination. Next. When restricting the analysis to Pfizer vaccine given on the same day with influenza vaccine, the result is similar. There is no estimate for Moderna for this analysis due to the smaller sample size for that vaccine. Next. In an analysis restricted to Pfizer vaccine given without any other vaccines on the same day, there is a similar point estimate, but it is not significant. The confidence intervals for the analyses with and without simultaneous vaccines overlap and do not indicate that there is a significantly different risk associated with receipt of simultaneous influenza vaccine. Next. So now we will discuss the statistical signal for the Moderna vaccine, which was observed in the 65 years and older age group. A statistical signal was detected in the sequential analysis. This slide shows the rate ratio estimate using the most recent end of season data, and the confidence interval is no longer statistically significant. Next. For comparison, this slide also shows the rate ratio estimate for the Pfizer vaccine in this age group, which again did not signal. Next. So this graph shows the incident rate ratios for ischemic stroke following Pfizer and Moderna vaccines among people 65 years and above. These are the same rates shown in the table on the previous slide. Supplemental analyses were again done to evaluate the potential effect of same-day influenza vaccine. Next. So when restricting the analysis to COVID vaccines given on the same day with flu vaccine, the result for Moderna has wider confidence intervals and is significant. Next. In an analysis restricted to COVID-19 vaccine given without any other vaccines on the same day, there is not a significant risk. Again, the confidence intervals for the analyses with and without simultaneous vaccines overlap and do not indicate that there is a significantly different risk associated with receipt of simultaneous flu vaccine. Next. So in summary for this section, VSD detected statistical signals for ischemic stroke for Pfizer and Moderna COVID vaccines during the 2023-2024 season. There was a lack of consistent findings across age groups or risk intervals. There was not a statistically significant risk associated with receipt of simultaneous influenza vaccine. The VSD previously identified a statistical signal for ischemic stroke for the 2022-2023 bivalent formulation of Pfizer vaccine in people 65 years and older using the 1 to 21 day risk interval. So this season's findings are consistent with CDC's Immunization Safety Office's prior interpretation based on data review presented in October 2023 that stated available data do not provide clear and consistent evidence of a safety problem for ischemic stroke with mRNA COVID-19 vaccines when given alone or given simultaneously with influenza vaccines. The statistical signals during the 2022-23 and 23-24 seasons do require further evaluation, and the VSD has a follow-up retrospective study in progress to further assess the risk of ischemic stroke. Next. So the overall conclusions about vaccine safety monitoring for the 23-24 season when considering information from all three surveillance systems are as follows. First, the rates of local and systemic reactions reported by VSafe participants during the first week after receiving a dose of the 23-24 vaccine were similar to last season. VSD identified statistical signals for GBS and ischemic stroke, but no other new or unexpected safety concerns were identified by any of the three systems. Next. The increased rate ratio of GBS following Pfizer COVID vaccine among people aged 65 and older observed during the 23-24 season may or may not represent a true risk. If there is a true risk, then the estimated excess of GBS cases of 4 per million doses is similar to previous estimates for other vaccines for adults, such as flu vaccine at 1 to 2 cases per million doses, or recombinant zoster vaccine at 3 to 6 cases per million doses. The VSD statistical signals for ischemic stroke after mRNA COVID-19 vaccines during the 23-24 season do not provide sufficient evidence to conclude that there is a safety concern. A follow-up VSD study is in progress to further examine the risk of ischemic stroke after mRNA COVID vaccines. FDA has 2023-24 COVID-19 vaccine safety surveillance ongoing using commercial health claims and Medicare claims databases, and those results are expected later this year, which will provide additional information about GBS, stroke, and other outcomes. Next. So finally, any real or theoretical risks of vaccine adverse events need to be placed in the context of the benefits of COVID-19 vaccines in preventing COVID-19 and its potentially serious complications. CDC and FDA will continue to monitor the safety of COVID-19 vaccines going forward. Next. The following individuals and organizations contributed to this work, and this concludes the presentation. Thank you.
Thank you very much for a thorough presentation. Any questions? That must have been a very clear presentation. All right, thank you so much, Dr. Duffy. We'll move on to the economic analyses by Dr. Prosser.
Great. Good morning, everyone. Please let me know if my audio is okay.
Perfect.
Great, thank you. Thanks for the opportunity to share the results of this economic analysis. Next slide. First, I'd like to acknowledge our research team, which includes collaborators from CDC and the University of Michigan, as well as many others at CDC who provided data for this model. Next slide, please. I'd also like to thank our expert panel who provided critical input into the pediatric model. Next slide. We do not have any conflicts to report. Next slide. As a reminder, the original objectives of the economic study were to estimate the annual disease burden and healthcare utilization associated with COVID-19 illness and vaccination against COVID-19, and to project the cost effectiveness of an updated vaccine against COVID-19 associated illness. In this third phase of the model, we have added pediatric age groups and made some updates to the adult model to reflect the rapidly evolving evidence base for COVID-19. Next slide. This presentation will review the parameters for the pediatric model and will also highlight key updates to the adult model. Next slide. The next few slides will review the methods for the analysis. Next slide. We use simulation modeling to project costs and health outcomes for each age group. This slide shows a simplified schematic of the simulation model. The intervention strategies included in the model were vaccination with an updated COVID-19 vaccine compared with no updated vaccine. In the model, an individual has some probability of remaining disease-free or experiencing COVID-19 illness. If they experience COVID-19 illness, they can then have an episode of non-hospitalized COVID-19 illness or become hospitalized due to COVID-19. Symptomatic illness can also occur in outpatient or an emergency department visit. If hospitalized, the severity of illness can require ICU care or ventilator assistance. All individuals who have COVID-19 illness are at risk for long COVID. Hospitalized patients also have probabilities of long-term permanent sequelae or death. As simulated individuals travel through the model, they accumulate costs and losses in quality of life associated with each health state. Also included in the model are adverse events associated with vaccination, including systemic reactions, anaphylaxis, and myocarditis. Each probability, cost, and quality adjustment is represented by a most likely value and a range of plausible parameter values. Identical cohorts are run through the two submodels, one in which all individuals in the cohort receive vaccination and one in which they do not. Next slide. The analysis projects disaggregated health and economic outcomes for each intervention strategy and stratified by age subgroup. The age groups included in the model were 5 to 11 years, 12 to 17 years, 18 to 49, 50 to 64, and 65 and older. The time horizon for the analysis is 1 year, with costs and qualities lost due to long-term sequelae and deaths beyond 1 year accounted for. The analysis uses a societal perspective with a costing year of 2023 and a discount rate of 3%. Incremental ratios, cost effectiveness ratios in dollars per quality adjusted life year or qualities are calculated, comparing an updated COVID-19 vaccine to no vaccine. This metric measures the additional investment in vaccination or cost savings associated with the change in health benefits and accounts for offsets due to averted illness. We also conducted a set of uncertainty analyses to explore the robustness of the results to changes in input parameters. It's important to note that this presentation reports results from an ongoing analysis and the initial results for the pediatric age groups. Next slide. In the next few slides, I'll briefly review a select set of parameters for the pediatric model and key updates to parameters for the adult model. The complete set of inputs is available in the supplemental slides. Modeling assumptions that remain the same as in the previous phases of the model are shown highlighted in gray. Next slide. This slide shows the probability of symptomatic illness for pediatric age groups. It was assumed that the probability for younger adults would be a reasonable proxy for school-age children and adolescents, as direct data were not available for these younger age groups. Next slide. This slide shows the rates of hospitalization across seasons from the COVID net data. The base case in the model uses data from the 22 to 23 season, represented by the green line. We also include a scenario analysis exploring a projection for the 2023-2024 season, which is shown in red. Next slide. The probability of hospitalization for all age groups was derived from COVIDNet data. Rates for pediatric age groups are substantially lower than for adults, as we saw in the previous analysis. Conditional probabilities of critical illness and death have also been updated for the adult age groups using more recent data from COVIDNet. Those are not shown in this presentation, but available in the supplemental slides. Next slide, please. There's limited evidence to derive assumptions relating to long COVID. In this analysis, we take a conservative approach to modeling long COVID and include only a higher severity definition, which assumes persistent symptoms of extreme fatigue and cognitive difficulties that continue beyond 3 months following initial infection. Shown in the table are conditional probabilities of long COVID following an initial COVID illness. These vary with the severity of initial COVID illness and by age. These estimates are derived from INSPIRE study data and calibrated to 2022 national prevalence estimates of long COVID. Proportion of all long COVID episodes, which is consistent with this higher severity definition, is approximately 10 to 20%. Next slide. This slide presents seasonality adjusted vaccine impact for the 5 to 11-year-old age group. The panel on the left shows vaccine effectiveness against emergency department or urgent care use for the updated COVID-19 vaccine by interval days since last dose, based on unpublished data from Vision for the first part of the 23-24 season. Using data available for 120 days following vaccination, 3 scenarios were used to extend the evidence to 1 year. An optimistic scenario, which assumed the VE observed in the last period remained for the duration of the year, a conservative scenario in which VE waned to 0 beyond 120 days, and a midpoint scenario, which assumed linear waning from 120 days until the end of the year. The figure on the right-hand side depicts how seasonality has been incorporated into vaccine impact. The top line shows hospitalizations by month. The blue area represents hospitalizations averted by month, applying the VE waning function on the left to monthly hospitalization rates. This yields a vaccine impact of 0.423 for the 1-year season. It's important to note that the evidence base for pediatric age groups for VE is much lower than for adults. Only V against the EDUC endpoint is available and was applied in the model to all of the endpoints. The associated range is very wide, as noted on the slide. Estimates for the 12 to 17-year age group not shown here are very similar to those for the 5 to 11-year age group. Next slide. This slide shows seasonality adjusted vaccine impact against symptomatic illness and hospitalization for all 5 age groups. So you can see impact is slightly higher for the pediatric age groups, but note that the confidence intervals are much wider. Not shown here are the vaccine impact estimates against critical illness and death. And for those estimates, the results are slightly higher for the older adult age groups than for children. Next slide. We also modeled additional scenarios which considered alternate patterns of infection across a 1-year season, one with a winter peak and one with a spring peak. In both of the alternate scenarios, the estimated vaccine impact is lower than the base case, as the peak of infection occurs farther from the timing of vaccination. Next slide. Costs of vaccination include direct medical costs of the vaccine dose, administration, and adverse events. Time costs for either the vaccine recipient or caregiver are also included. Children 5 to 11 years are most likely to receive vaccination in the physician office setting, while adolescent and adult age groups are more likely to receive vaccination in the pharmacy or mass vaccination setting. The cost of the vaccine dose assumes a mix of government negotiated pricing and private sector pricing, which varies by age. Next slide. Other direct medical costs included in the model are listed on this slide. These estimates are derived using primary data, published data, and supplemented by expert opinion where needed. Costs vary by age and by the severity of illness. Next slide, please. The model also includes time costs or productivity loss associated with lost time from work and other productive activities due to illness or vaccination-related adverse events. Caregiver time cost or caregiver productivity losses are included for pediatric health states other than deaths. Next slide. The effects of COVID-19 illness and vaccine-associated adverse events are incorporated into the model as losses in quality-adjusted life years. One quality-adjusted life year can be thought of as the equivalent of living for 1 year in perfect health. This slide shows quality losses for COVID-19 related illnesses. Values are based on published studies and primary survey data. Quality losses for long COVID, long-term sequelae post-hospitalization, and vaccination-related adverse events are also included in the model, not shown here. Next slide. Next, we'll move on to the results. This slide shows disaggregated results for projected cases, hospitalizations, ICU stays, and deaths. The left-hand panel lists projected numbers for each strategy, vaccination or not, stratified by age group. Results are presented for cohorts of 100,000. The right-hand side of the table lists numbers of cases averted by vaccination. Roughly similar numbers of cases are averted across the age groups, but other health outcomes vary substantially and increase with increasing age. So higher numbers of averted outcomes with older age groups. Next slide, please. This slide shows the same information from the previous slide with each panel depicting a health outcome by age. The total bar represents outcomes in the absence of vaccination, and the light blue represents cases averted under vaccination. So it clearly shows how the burden of illness varies across age groups, with higher burden and higher severity cases averted for the older age groups. Next slide. This slide shows incremental cost effectiveness ratios for each age group using a societal perspective. For all age groups, vaccination requires an additional investment as shown in the incremental cost column and yields additional health benefits as measured in QALYs. In this updated model, vaccination does not yield cost savings for any age group in the base case. Next slide, please. Incremental cost effectiveness ratios are roughly $200,000 per QALY for both pediatric age groups, similar for 18 to 49-year-olds at $212,000 per QALY, and more favorable for older individuals with an ICER of $113,000 per QALY for 50 to 64-year-olds and $23,000 per QALY for 65 and older. Next slide. The next few slides present uncertainty analysis as input parameters are varied from their base case values. This tornado diagram displays one-way sensitivity analyses for the most influential parameters in the analysis for the 5 to 11-year age group. Results were most sensitive to vaccine impact, QALYs lost, and probability of symptomatic illness, as well as the cost of the vaccine dose. This figure highlights the uncertainty associated with the pediatric age groups, with ICERs exceeding $400,000 per QALY when varying the top 3 parameters, and greater than $700,000 per QALY when varying vaccine impact. The tornado diagram looks very similar for 12 to 17-year-olds. Next slide. This tornado diagram displays one-way sensitivity analyses for the most influential parameters for the 18 to 49-year age group. Here, results were most sensitive to vaccine impact, QALYs lost for symptomatic illness, and the cost of the vaccine dose. But for this age group, the probability of hospitalization is more important than the probability of symptomatic illness. This figure also highlights the uncertainty associated with the age group. Next slide. The next few slides present additional uncertainty analyses as input parameters are varied from their base case values. Results are very sensitive to the probability of symptomatic illness, and keep in mind these are annual probabilities. The base case assumption is 28 to 33% depending on the age group. For values as low as 10% annual probability of illness, ratios are substantially higher, especially for the pediatric age groups and 18 to 49-year-old adults at more than $700,000 per QALY. Next slide. Varying the probability of hospitalization from 2 to 4 times the base case, a rough proxy for higher risk individuals, yields substantially more favorable cost effectiveness ratios across all age groups and cost saving for 50 and older. Varying the probabilities of critical care and death yields similar changes in ratios. Next slide. This table shows results when all parameters in the long COVID submodel are varied simultaneously to lower and upper bounds. For higher values, ICERs are substantially lower, especially for the adult age groups, and for higher values, for lower values, they are somewhat less favorable. Next slide, please. Varying the vaccine impact is highly influential for all age groups. This scenario analysis varied the seasonality adjusted vaccine impact for all endpoints across lower and upper bounds simultaneously. Using all lower bounds, yields ratios about $400,000 or higher for all age groups except 65 and older. Using all upper bounds, yields ratios less than $140,000 per quality and cost saving for the oldest age group. Next slide, please. Considering alternate patterns of infections with a winter or spring peak yields slightly less favorable ICERs, most notably for the 18 to 49-year age group. Next slide. Lower costs of vaccination are also associated with substantially lower ICERs. Varying the cost of the vaccine dose to $30 to $50 per dose would move the ICER to less than $150,000 per quality for the 3 youngest age groups and to cost saving for age groups 50 years and older. Next slide. Varying all vaccination-related costs to lower bounds yields ICERs less than $90,000 per quality adjusted life year for all age groups and cost saving for 50 years and older. Next slide. This analysis includes a number of limitations, not limited to those listed on the slide here. In general, it should be recognized that the evidence base for COVID-19 illness and vaccination differs from that available for most economic analyses presented to the ACIP and relies primarily on unpublished short-term data. The evidence base for long COVID is especially scarce and even more so for pediatric age groups. Next slide. In summary, vaccination averts morbidity and mortality for all age groups, but with substantial variation in impact by age. For the adult age groups, this phase of the model projects somewhat less favorable results overall due to declining burden of illness. The ICERs for the oldest age groups at $23,000 per quality are robust to changes in parameter inputs across plausible ranges. ICERs for the younger adult age groups 18 to 49 and 50 to 64 are sensitive to changes in parameter inputs, especially vaccine impact, qualities lost for symptomatic illness, vaccine dose cost, and the probability of hospitalization. Next slide. For pediatric age groups, both the ICERs for both 5 to 11 years and 12 to 7-year age groups are very sensitive to changes in parameter inputs, especially sensitive to vaccine impact, qualities lost for symptomatic illness, probability of symptomatic illness, and the cost of the vaccine dose. It's important to note that the evidence base for pediatric age groups overall is less robust, and the estimated results reflect the higher degree of uncertainty compared with adult age groups. Next slide. Thank you. I'm happy to take any questions.
Thank you. I'm sure there's going to be lots of questions for this. Dr. Lair.
Thank you for your presentation. Could you go to slide 34 for us? This is talking about the vaccine dose cost, and if my understanding is correct, it's not just the cost of the vaccine, but also the administration cost and the adverse events. Just a comment, for pediatric vaccines, when I just looked up my price as a private physician, it's $130 a dose for the vaccine, which does not include the vaccine administration cost, which is about $40 or $50. So I would say that this is, at least for my private practice, an underestimate of the cost of the vaccines. And so I'm just commenting on that, and would also like to make a note that for the manufacturers, if this were to, vaccines were to have lower costs, it would give clearly a much better cost effectiveness analysis. Thank you.
Great, thanks very much for that comment. I'd like to clarify that this slide actually shows only the variation in vaccine dose cost. And I'm looking to see in the supplemental slides if it would be possible to pull up, hang on just a minute. Slide number 35 from the supplemental slides. So I want to highlight that the overall cost of vaccination include the vaccine dose cost, which was shown on the previous slide, but also include administration costs, as well as either time costs for the recipient or time costs for a caregiver for the pediatric age groups. And then if we go back to the other slide set, the next slide shows the variation when varying those total costs, which, as Dr. Leary pointed out, are, depending on the age group, are substantially higher than the dose cost, roughly double.
Dr. Shaw.
Yeah, thanks very much. That was a great presentation. I just had a question whether your analysis included for older adults the potential costs of, postponing or preventing residence, temporary or permanent, in a long-term care facility?
No, this analysis does not include any costs associated with that type of decision.
Thank you for saying that. That was on my list too. Dr. Brooks.
Yeah, thank you for the presentation. It's excellent. Can you go to slide 23, please? And as you do, noting that this is cases averted, so it's not cost analysis. So I think that it's helpful, to have modeling, if you will. So, and the health outcomes averted, the cases, that's per 100,000, correct?
Yes.
So it would be helpful to me to have those as raw numbers, because the population in each age group varies in terms of the total number. Mm-hmm. And so it would give us, data on, how many cases of long COVID, let's say, total in the whole population of the U.S. So it's just compelling information regarding the benefit of vaccinating. Do you understand what I'm saying? Raw numbers versus cases.
Yeah, we don't have those.
And it's math. It's simple math, but it would be helpful to me to have that.
Absolutely. We don't have that available for this presentation, but can certainly provide that in the future.
Thank you.
Dr. Long.
Just a clarifying question. Did you use a single vaccine effectiveness through the season? You talked about a seasonal.
No, so we assumed waning of VE over the course of the year, as depicted in that slide 11. Sorry, I'm looking at my supplemental slides. Actually, that was 15. So on the left-hand side, this shows the assumption for waning of VE over the course of the year. We've also integrated that with the seasonality of hospitalizations by month on the right-hand side. But the left-hand panel, we have VE by month for all of the age groups. We have a little bit more data up to 6 months for the adult age groups. And those are available in the supplemental slides. You can also review those if that would be helpful. Would it be helpful to see any additional information?
Well, it just looked a little bit more optimistic than the data that we just saw on effectiveness, which looked like it was for hospitalization at over 120 days was 0 to 20%. And you started pretty high.
So that is for the 5 to 11 age group. I don't have a figure for the adult age groups, but those start substantially lower and do use the same set of data that was presented in the earlier presentation, with the exception that for the adult age groups, we're using data from the 22 to 23 season. And there it starts much lower, kind of in the 50% or so. depending on the age group, and then wanes more quickly than we see for the pediatric age groups.
Thank you very much.
That's why we see kind of lower overall vaccine impact for the adult age groups compared to kids.
Thank you.
Any other questions? Okay, thank you so much. We're going to move on to the evidence to recommendation. This is going to be a longer presentation, but should be very helpful. And I believe I'm turning it over to, oh no, we got to do the evidence yet first. Dr. Panayota-Tokopoulos. I actually wrote it down phonetically, just so you know. Dr. Panayota-Katopoulos.
All right.
Will you just say it so everyone actually knows the correct way?
Okay. My name is Dr. Lakshmi Panayota-Kopoulos, and I will now present the evidence to recommendations framework. Next slide. The policy question under consideration is, should 2024-2025 COVID-19 vaccines be recommended for use in persons 6 months of age and older? The products and ages under review for authorization or approval by FDA include the Moderna COVID-19 vaccine for ages 6 months and older, Novavax COVID-19 for ages 12 years and older, and Pfizer-BioNTech COVID-19 vaccine for ages 6 months and older. Next slide. We will begin with the public health problem domain. Next slide. This slide shows COVID-19 hospitalization rates by age group over the last year from COVIDnet. As you can see, hospitalization rates are substantially higher in those ages 75 years and older in the dashed purple line compared with other age groups. The next highest rates are seen in adults 65 to 74 years of age and infants less than 6 months of age. Next slide. This shows the monthly rates of COVID-19 associated deaths by age group from May 2023 to April 2024. The highest death rates are seen in adults 75 years and older, depicted by the burgundy line, followed by those 65 years and older. Next slide. On this slide, we are looking at the COVID-19 associated deaths by week over the past year in the United States. As you can see here, there was a peak in January 2024. And while rates are dropping, it is important to note that COVID-19 associated deaths do occur all year round. Next slide. This slide shows the total number of COVID-19 associated deaths in each age group during 2023. There were over 44,000 deaths in adults aged 65 years and older. When looking at the youngest age groups, there were 58 deaths in infants less than a year, 44 deaths in children 1 to 4 years old, and 81 deaths in children 5 to 19 years old. Next slide. When we compare pediatric COVID-19 associated deaths to those associated with influenza in 2023, we see that the number of deaths are comparable in all age groups. Next slide. The incidence of multisystem inflammatory syndrome in children, or MIS-C cases in the United States, has varied with COVID-19 variant predominance. While rates of both COVID-19 and MIS-C have overall decreased in the United States, cases of MIS-C continue to be reported, with 117 cases reported in 2023 and an incidence of 0.11 per 1 million. Next slide. As shown earlier by Dr. Havers, children without underlying medical conditions continue to be hospitalized and have severe outcomes. Of all children with a COVID-19 associated hospitalization between July 2023 and March 2024, 50% had no underlying medical conditions, and of those, 18% were admitted to the intensive care unit. Next slide. When comparing annual hospitalizations due to COVID-19 in the U.S. pediatric population compared to other vaccine-preventable diseases prior to their respective vaccine recommendations, we see higher rates of COVID-19 hospitalizations during 2022 to 23 and 2023 to 2024. Next slide. Similarly, when comparing deaths per year in the United States due to COVID-19 compared to other vaccine-preventable diseases prior to their respective vaccine recommendations, we see higher number of deaths due to COVID-19 in 2023. Next slide. Now we will look at equity for the public health problem domain. Does the problem impact all populations equally? Next slide. We see differences in the age-adjusted hospitalization rates by race and ethnicity in COVIDNet from October 2023 to May 2024, with the highest rates in American Indian and Alaska Native persons, followed by Black non-Hispanic persons, Hispanic persons, and white non-Hispanic persons. Next slide. In summary, COVID-19 associated hospitalizations and deaths occur all year round, but peak in December through February. COVID-19 associated hospitalizations and deaths are highest in adults 75 years and older. More pediatric hospitalizations and deaths occur each year associated with COVID-19 than other vaccine-preventable diseases at the time those recommendations were made for children in the United States. In children admitted to the hospital with COVID-19, 50% had no underlying medical conditions, and of those, 18% were admitted to the intensive care unit. And finally, racial and ethnic differences in COVID-19 hospitalization rates persist. Next slide. When asked if COVID-19 disease among persons 6 months of age and older is of public health importance, the work group said yes. Next slide. Now we will move to the benefits and harms domain. Next slide. The benefits and harms of COVID-19 vaccines are based on multiple years of data from the original, bivalent, and 2023-24 vaccines. This includes grade on the benefits and harms of updated COVID-19 vaccines, available data on grade outcomes without studies captured in systematic review, real-world safety and effectiveness of the 2023-24 COVID-19 vaccines, and modeling data on the potential impact of 2024-25 COVID-19 vaccine recommendations. Next slide. To inform the policy question, the work group defined one PICO question for the adult and adolescent population, and one PICO question for infants and children, which I will refer to as the pediatric population. For both populations, the intervention was an updated dose of COVID-19 vaccine, and the comparison was no updated dose. The work group identified 4 outcomes to inform the benefits in adults and adolescents, including the prevention of medically attended COVID-19, hospitalization and death due to COVID-19, and post-COVID conditions, and 1 outcome to inform harms, specified serious adverse events. The outcomes were the same in the pediatric population with the addition of the prevention of MIS-C as a benefit. I will now present data on outcomes for which we conducted a meta-analysis and summary of grade. The full evidence profile is included in the backup slides and will be posted online. Next slide. This forest plot shows VE estimates from 5 studies that met the inclusion criteria for the prevention of ED and UC visits among adults and adolescents. The studies are roughly ordered on the y-axis by median days since the receipt of an updated dose. The pooled relative VE estimate for protection against COVID-19 related ED-UC visits in these studies was 43%. Overall, we can see a general waning trend in VE estimates with increasing median time since receipt of an updated dose. Next slide. This forest plot shows estimates of relative VE against hospitalization. There were 8 studies that met inclusion criteria, and similar to ED-UC visits, we see a waning pattern with increasing median time since receipt. The pooled VE estimate against hospitalization was 44%. Next slide. We captured 3 studies in our systematic review that looked at VE against death. The pooled VE was 23%. The pooled VE against death may be lower than that of ED-UC visits and hospitalizations because we see more durable protection against critical illness, and therefore, we may be seeing less incremental increase in the protection with an updated dose. For all 3 outcomes shown, sensitivity analyses were conducted, and exclusion of manufacturer-funded studies, preprints, and bivalent vaccine studies did not meaningfully change the estimates. Next slide. Now I will review the grade certainty assessment for the outcomes. However, I would first like to provide a reminder on what a certainty assessment is and is not. A certainty assessment reflects our confidence the true effect lies close to that of the estimated effect. There are 4 certainty levels. High certainty indicates we are very confident that the true effect lies close to that of the estimated effect. All randomized controlled data starts at high and can be downgraded. Moderate certainty indicates that we think the true effect lies close to the estimated effect but could be substantially different. And low certainty indicates that we have limited confidence that the true effect lies close to the observed effect. Observational data starts at low certainty and can be downgraded or upgraded. Very low certainty indicates that we have very limited confidence that the true effect lies close to the estimated effect. A certainty assessment does not reflect our confidence in the quality of the individual studies or the overall confidence in the benefits and harms of the vaccine, which may be informed by additional data on benefits and harms. Next slide. Here you can see the summary of grade outcomes, importance, effect estimates, findings, and a certainty assessment. In the interest of time, I will not discuss each outcome, but the full evidence profile can be found in the backup slides. The final certainty assessments reflect the use of observational data which start at low certainty. There were downgrades for indirectness in 3 pediatric outcomes for which direct evidence could not be found, and instead, indirect evidence in adults was examined. Our overall findings were that updated COVID-19 vaccines were protective against medically attended COVID-19 hospitalization and death, and associated with 2 rare established adverse events, which are myocarditis and anaphylaxis. Next slide. Now I will review COVID-19 vaccine effectiveness, which was presented by Dr. Link Ellis earlier in the session. We saw that the 2023-24 COVID-19 vaccination provided increased protection against symptomatic SARS-CoV-2 infection and COVID-19 associated ED and UC visits and hospitalizations compared to no 2023-24 vaccine dose. The waning patterns appeared similar to previous COVID-19 vaccine formulations, with the most durable protection against critical illness, noting that the statistical power was lacking in the longest time period since vaccination. As with previous formulations, effectiveness was similar across age groups. Receipt of the 2023-24 vaccine did provide protection against JN1 and other circulating variants, although this may be lower than the protection provided against XBB sublineage variants. Next slide. Unpublished data from HEROES, RECOVER, and PROTECT study cohorts has shown that COVID-19 mRNA vaccine is associated with reduced recurrence of post-COVID conditions, or PCC, following SARS-CoV-2. Among children ages 5 to 17 years, completion of the primary vaccine series prior to infection resulted in a decreased symptoms ranging from 34 to 48%. Among adults, 3 doses of original formula vaccines prior to infection was associated with a decrease in symptoms of PCC ranging from 24 to 42%. Next slide. And COVID-19 vaccines have been shown to be effective in preventing multisystem inflammatory syndrome in children, or MISC, in U.S. children ages 5 to 18 years old. A multi-center case control investigation from July 2021 to April 2022 compared the odds of being fully vaccinated between MISC case patients and hospital-based controls who tested negative for SARS-CoV-2, and found that 92% of MISC patients were unvaccinated compared to 69% of hospital-based controls. Next slide. Moving to vaccine safety, we know that COVID-19 vaccines have a favorable safety profile as demonstrated by robust safety surveillance in over 3 years of COVID-19 vaccine use. Anaphylactic reactions have rarely been reported following COVID-19 vaccines, and there is a rare risk of myocarditis and pericarditis, predominantly in males ages 12 to 39 years. Reactogenicity symptoms occur, but are overall less frequent and more severe among older adults compared with adolescents and younger adults. Sorry, less frequent and severe. Next slide. Myocarditis is a rare risk of COVID-19 vaccination. The acute picture of COVID-19 vaccine-associated myocarditis tends to resolve quickly, with the majority of patients recovering within 90 days and symptoms improving over time. There may be a small set of patients with persistent MRI findings, specifically late gadolinium enhancement. However, there is an unclear correlation of this finding to clinical symptoms. Additional follow-up is needed to determine the long-term impact of these MRI findings. Next slide. Earlier in the session, we heard Dr. Duffy present on 2 vaccine safety data linked statistical signals after COVID-19 vaccines during the 2023-24 season. With regards to the signal for GBS following Pfizer COVID-19 vaccine among people aged 65 years and older, an association of mRNA COVID-19 vaccines and GBS has not been observed prior to this season in VSD or in other systems. The increased rate ratio observed may or may not represent a true risk. If there is a true risk, it is estimated to be similar to what is considered acceptable for other adult vaccines. With regards to ischemic stroke following Moderna vaccine in adults aged 65 years and older and Pfizer vaccine in adults aged 50 to 64 years, the VSD previously observed a statistical signal for ischemic stroke during 2022-2023 for the bivalent Pfizer vaccine in adults aged 65 years and older. Therefore, available data do not provide clear and consistent evidence of a safety problem for ischemic stroke with mRNA COVID-19 vaccines. No other new or unexpected safety concerns were identified for the 2023-2024 COVID-19 vaccines, and any real or theoretical risks of vaccine adverse events need to be placed in the context of the benefits of COVID-19 vaccines in preventing COVID-19 and its potentially serious complication. Next slide. So now I will shift to presenting data on models for the potential impact of different 2024-25 COVID-19 vaccine recommendations. The COVID-19 Scenario Modeling Hub, Round 18, looked at 6 scenarios for the 2024-25 recommendations, focusing on 3 vaccine recommendation scenarios under both high and low rates of immune escape. The 3 vaccination scenarios included no vaccine recommendation versus recommendation for only people at high risk versus a universal recommendation. High risk was defined as those aged 65 years and older and those with underlying conditions. The vaccine uptake assumptions were based on 2023-24 COVID-19 vaccine coverage estimates. The models assumed vaccine was available on September 1st, with 75% VE against hospitalization at that time. A constant rate of immune escape and waning was applied starting September 1st, and the models projected 1 year into the future. Next slide. The ensemble model projected that universal vaccine recommendations would prevent about 30,000 more hospitalizations over the next year compared with a risk-based recommendation. Next slide. Now for the equity question, are the desirable and undesirable anticipated effects demonstrated across all populations equally? Next slide. There is no evidence to suggest COVID-19 vaccine effectiveness varies substantially by race and ethnicity. Differences in vaccine hesitancy, uptake, crowding, access to care, and prior infection could also impact VE, and those factors may differ by race and ethnicity. Although there is no evidence to suggest that COVID-19 vaccine safety profiles vary by race and ethnicity, however, risk has been shown to differ by age and sex. For example, the risk of myocarditis is highest in adolescent and young adult males. The benefits and harms for the U.S. population are best assessed when clinical trial and study populations are optimally representative of the U.S. population. Next slide. So in summary, the 2023-24 COVID-19 vaccine is effective in preventing ED and UC visits and preventing severe outcomes related to COVID-19, including hospitalization and death. However, waning of immunity is expected. COVID-19 vaccines have a favorable safety profile as demonstrated by robust safety surveillance in over 3 years of COVID-19 vaccine use. The preliminary safety signals for ischemic stroke and GBS are not clear or consistent and are seen in the age groups with the highest burden of disease that would benefit the most from updated COVID-19 vaccination. Modeling projects more hospitalizations averted when the 2024-25 COVID-19 vaccines are universally recommended compared to no recommendation or recommended only for those at high risk. Next slide. When asked how substantial are the desirable anticipated effects, the work group said moderate and large. Next slide. When asked how substantial are the undesirable effects, the work group said small. Next slide. And when asked did the desirable effects outweigh the undesirable effects, the work group said that the balance favors the intervention, which is the 2024-25 COVID-19 vaccine. Next slide. Now I will present the domain values. Next slide. Approximately 1 in 5 Americans now consider COVID-19 a major threat to public health, which is down from its peak of 66% in March 2020. Next slide. If we look at the concern about the risk of COVID-19 by age, adults age 65 years and older are more concerned about getting a serious case of COVID-19, and younger adults ages 18 to 29 years are more concerned about unknowingly spreading the virus to others. Next slide. As far as key attitudes and experiences, approximately 30% of parents of children 6 months to 17 years of age reported being concerned about their child getting COVID-19 disease. Parents of older children generally reported more confidence in vaccine safety and confidence in the importance of COVID-19 vaccine to protect their child. Next slide. When looking at key attitudes and experiences among adults, concern about COVID-19 disease, confidence in vaccine safety, and the importance of COVID-19 vaccine all increased with increasing age. Next slide. For the equity component of the domain, is there important variability in how patients or populations value the outcome? Next slide. When key attitudes among parents of children ages 6 months to 17 years is broken down by race and ethnicity, we see the highest concern about the child getting COVID-19 disease and the lowest confidence in vaccine safety for the child in Black non-Hispanic persons. The lowest confidence in the importance of COVID-19 vaccine was seen among white non-Hispanic persons. Next slide. In adults, Black non-Hispanic persons reported the highest rate of concern about COVID-19 disease, followed by American Indian and Alaska Native persons. American Indian and Alaska Native persons also had the lowest confidence in COVID-19 vaccine safety and the lowest confidence in COVID-19 vaccine importance. Next slide. Black persons are more likely to be concerned about getting a serious case of COVID-19, whereas Asians are more concerned about unknowingly spreading COVID-19 to others, followed closely by Black persons. Next slide. Lower income Americans continue to be particularly concerned about getting a serious case of COVID-19. They are also more likely than middle and upper income Americans to worry about unknowingly spreading COVID-19, but the differences here are more modest. Next slide. To summarize the values domain, approximately 30% of parents reported concern about their child getting COVID-19, but confidence in COVID-19 vaccine safety and importance was highest among parents of adolescents. Adults ages 65 years and older were more concerned about COVID-19 disease and had higher confidence in COVID-19 vaccine safety and vaccine importance than those less than 65 years. Racial and ethnic minority groups, older adults, and those with lower incomes were more concerned about getting COVID-19 than other groups. Next slide. When asked if persons 6 months of age and older feel the desirable effects are large relative to undesirable effects, the work group said varies. Next slide. When asked if there was important uncertainty about or variability in how persons 6 months of age and older value the main outcome, the majority of the work group said there was probably important uncertainty or variability, and the minority said there was important uncertainty and variability. Next slide. The next domain is acceptability. Next slide. Over time, the percentage of U.S. adults who report they are up to date with COVID-19 vaccines has decreased from 69% in August 2021 to 28% in February 2024. Next slide. For the 2023-24 COVID-19 vaccine, vaccination rates increased with age, with over 40% of adults 65 years and older having received the vaccine, and just over 10% of adults aged 18 to 29 having received the vaccine on the left side of the slide. For pediatric rates seen on the right side of the slide, overall coverage was about 14%, with the youngest children having the lowest coverage. Next slide. Looking ahead, data on the intent to get the 2024-25 COVID-19 vaccine among adults shows higher intent with increasing age. Intent is also higher for those living in urban areas than rural areas, and higher for insured adults compared to uninsured adults. Next slide. This slide shows the intent to get an annual COVID-19 vaccine among adults. 1/3 of adults reported they would get a COVID-19 vaccine every year if recommended, but we know that fewer actually got the 2023-24 vaccine. Next slide. The most common reason why parents of children ages 6 months to 17 years reported not getting vaccinated were concerned about side effects in 88%, followed by vaccine is ineffective and child is unlikely to get sick from COVID-19. Next slide. Less than 29% of parents of children ages 6 months to 17 years reported a healthcare provider recommended they get the 2023-24 COVID-19 vaccine. Next slide. For adults, 17% aged 18 to 49 years reported a healthcare provider recommendation for the 23-24 COVID-19 vaccine. And this number was 24% for adults aged 50 to 64 years and 27% for adults aged 65 years and older. Next slide. Top COVID-19 vaccine concerns among adults varied by receipt. For those who received the 2023-24 vaccine or definitely would receive it, the majority had no concerns or issues. For those who reported they probably will receive the vaccine or were unsure, unknown side effects and too busy or kept forgetting were the most commonly reported among 18 to 59-year-olds, and effectiveness and unknown side effects were most commonly reported among those 60 years and older. And among those who probably or definitely would not get the 2023-24 vaccine, unknown serious side effects, not enough studies, and distrust of the government and pharma were the most frequently reported concerns. Next slide. For equity, is the intervention equally acceptable across all populations? Next slide. Among children ages 6 months to 17 years, vaccination coverage differed by race and ethnicity. Coverage was highest among white non-Hispanic children and lowest among Black non-Hispanic children. Vaccination coverage was higher in urban and suburban areas compared with rural areas. Children covered by health insurance had higher vaccination coverage than children who were uninsured or covered by Medicaid. And vaccination coverage increased with increasing household income. Next slide. Among adults, vaccination coverage also differed by race and ethnicity. Coverage was highest among white non-Hispanic adults and lowest among American Indian, Alaska Native, and Native Hawaiian other Pacific Islander adults. Like children, vaccination coverage was higher in urban and suburban areas compared with rural areas, and adults with health insurance had significantly higher vaccination coverage than adults without insurance. Also, vaccination coverage increased with increasing household income. Next slide. To summarize acceptability, vaccination coverage with at least one dose of the 2023-24 vaccine was approximately 20% among adults ages 18 and older. Since August 2021, the percent of adults who report being up to date with COVID-19 vaccination has decreased from 69% to 28%. Concern about side effects are the most likely reason for not being vaccinated, and less than 30% of people reported having a healthcare provider recommendation to get the 2023-24 COVID-19 vaccine. COVID-19 vaccination coverage varies by age, race and ethnicity, metropolitan statistical area, insurance status, and household income. Next slide. When asked, would recommending a dose of the 2024-25 formula COVID-19 vaccine for persons 6 months of age and older be acceptable to key stakeholders, the majority of the work group said varies, and the minority said probably yes. Next slide. Now for the domain feasibility. For feasibility of vaccine implementation, no substantial changes are expected. As a result, supporting tools and documents for the 2023-24 vaccine will not need to be significantly revised or reprogrammed, but COVID-19 vaccine recommendations remain complex. There will continue to be single-dose presentations and small minimal order quantities as listed below by vaccine manufacturer and age group. The preparations are also not expected to change. Moderna and Novavax vaccines require no dilution, and Pfizer vaccine requires dilution for the 6-month to 4-year formulation. Next slide. This slide shows storage and handling requirements for the different vaccines. Ultra-cold storage continues to be a challenge because most average provider offices will not have an ultra-cold storage unit. But the smaller minimum order quantities of 10 will help with this challenge. They can be used up within 10 weeks in the refrigerator without the worry of a larger quantity expiring. Next slide. There continues to be barriers in implementing COVID-19 vaccination, including an increasingly complex routine vaccination schedule that includes immunization products for 3 viral respiratory diseases. This requires storage space, education of vaccine providers, and can lead to more vaccination errors. In addition, there is a significant financial burden for healthcare practices to store the vaccine, which is costly, and for which there is a low demand. There will soon be a financial burden for uninsured and underinsured people with the end of the Bridge Access Program, which will be discussed in more detail. And finally, with fewer primary care practices carrying COVID-19 vaccines, there are barriers to access, particularly for those with difficulty traveling to another location for vaccination. Next slide. Is the intervention equally feasible to implement across all populations? Next slide. Free updated COVID-19 vaccines are available to most people living in the United States through private health insurance, Medicare, and Medicaid plans. Eligible children are able to receive the COVID-19 vaccines through the existing Vaccines for Children program. However, there are 25 to 30 million adults without health insurance and additional adults whose insurance does not cover all COVID-19 vaccination costs. The Bridge Access Program, which covers the COVID-19 vaccine for adults who are uninsured and underinsured, will end in August 2024, which will result in inequities in vaccine access. Next slide. To summarize feasibility, the 2024-25 COVID-19 vaccine will continue to consist of single-dose presentations and smaller minimum order quantities. Storage and handling requirements will remain the same as well. There are 3 seasonal vaccines for respiratory diseases to manage, which present limited storage space due to more vaccines and more opportunities for vaccine administration errors and the need for increased education among vaccine providers. Vaccines will continue to be accessible, however. The temporary Bridge Access Program will end in August 2024, resulting in decreased vaccine access for underserved populations. Next slide. When asked, is the 2024-25 formula COVID-19 vaccine feasible to implement among persons 6 months of age and older, the work group said probably yes and varies. Next slide. The last domain we will cover is resource use. Next slide. As we saw in Dr. Prosser's economic analysis, the incremental cost-effectiveness ratios demonstrated a cost per QALY of $23,000 in those 65 years and older, $113,000 in those 50 to 64 years, and around $200,000 for those age groups 50 years and older. 50 years and younger. The estimates in the younger age groups were very sensitive to changes in parameter inputs as described by Dr. Prosser. ICERs were more favorable for higher vaccine impact, higher rate of hospitalization, higher quality of life impact for symptomatic illness, and lower vaccine dose cost. Next slide. For equity, is the intervention a reasonable and efficient allocation of resources across all populations? Next slide. This table demonstrates the impact that changes in the probability of hospitalization for certain underlying conditions have on the ICERs. As the probability for hospitalization increases, the ICERs become more favorable, suggesting that COVID-19 vaccination is more cost-effective in those at increased risk of hospitalization, such as those with underlying conditions. Next slide. To summarize resource use, base case ICERs range from $23,000 in adults ages 65 years and older to $212,000 in adults aged 18 to 49 years. The cost effectiveness estimates in those 18 to 64 years were sensitive to changes in inputs, and cost effectiveness estimates for those 5 to 17 years were very sensitive to changes in inputs. COVID-19 vaccination is most cost-effective in older adults in whom disease burden is highest compared to younger adults. Also, COVID-19 vaccination is more cost-effective in populations with risk factors such as underlying conditions. And finally, ICERs would be more favorable in younger age groups if the cost of the vaccination was lower. Next slide. When asked, is the 2024-25 formula COVID-19 vaccine in person ages 6 months of age and older a reasonable and efficient allocation of resources, the majority of the work group said probably yes, and the minority said varies. Next slide. So now I'll go through the summary and the work group interpretation. Next slide. So COVID-19 burden is currently lower than at previous points in the pandemic. However, there are still thousands of hospitalizations and hundreds of deaths each week. And while people ages 5 to 49 years had the lowest hospitalization rates compared to other age groups, severe outcomes occur in the youngest ages, including children with no underlying medical conditions. Additional studies are needed to understand the VSD statistical signal seen for the 2023-24 COVID-19 vaccines. The increased rate of GBS following Pfizer COVID-19 vaccine among people ages 65 years and older may or may not represent a true risk. If it is a true risk, the burden of disease in this age group is such that the benefit of vaccination still outweighs the risk. The VSD statistical signals for ischemic stroke after mRNA COVID-19 vaccines do not provide sufficient evidence to conclude that there is a safety concern, and a follow-up VSD study is in progress. Next slide. 2023-24 COVID-19 vaccination coverage was low, particularly in children. Provider recommendation may encourage greater COVID-19 vaccine uptake. It would be important to understand why providers are not recommending vaccine, in addition to continuing to address inequities in vaccine access. High vaccine cost and decreased disease burden has resulted in less favorable ICERs for the younger age groups. The work group expressed concern about the current ICERs for those less than 50 years old. The work group noted that while the burden of disease in pediatric age groups supported recommending COVID-19 vaccine for these age groups, the high cost of vaccine was a concern. ICERs in pediatric age groups are sensitive to changes in parameter inputs, in other words, uncertain, and are still considered preliminary. Next slide. I will now present the work group considerations for a universal recommendation. As mentioned earlier by Dr. Daly, the work group began deliberations considering both universal and non-universal policy options. but the non-universal options had significant implementation challenges. Risk-based recommendations would not allow access to COVID-19 vaccines for those not in a defined risk group. The current list of conditions that increase risk for severe illness due to COVID-19 is extensive and includes the majority of the U.S. adult population. In addition, there are no groups without a risk of severe illness. Shared clinical decision-making would create barriers to vaccination, may not effectively target those at highest risk, and would likely increase inequities in vaccine access. COVID-19 vaccine epidemiology remains uncertain, and universal recommendations would need to be considered if there is an unexpected increase in burden following a risk-based or shared clinical decision-making decision. COVID-19 disease burden remains substantial, and consistent recommendations may increase coverage over time. Next slide. To summarize, benefits of COVID-19 vaccination vary by age and risk status. Under a universal recommendation, 2024-25 COVID-19 vaccines will be available to all persons ages 6 months and older. Additional implementation efforts should be targeted towards those that would receive the most benefit from vaccination, including people ages 65 years and older, people with underlying conditions, including immunocompromised, and pregnant people to protect themselves and their infants. The work group will continue to evaluate COVID-19 vaccine policy, including the need for a universal recommendation, particularly as COVID-19 epidemiology continues to change. Next slide. This slide shows a summary of the ETR domains and the work group polls. Next slide. When asked about the balance of consequences, the majority of the work group felt that the desirable consequences probably outweigh undesirable consequences in most settings, and the minority felt that desirable consequences outweigh undesirable consequences in most settings. Next slide. When asked the type of recommendation, the work group recommended the intervention. Next slide. The proposed voting language is as follows. ACIP recommends 2024-2025 COVID-19 vaccines as authorized or approved by FDA in persons 6 months of age and older. Next slide. I'd like to thank everyone here noted on this slide for their contributions. Next slide. Happy to take any questions. Thank you.
That was another tour de force. All right. Questions? Dr. Jameson.
I was really struck with the low proportion of healthcare providers that recommended it, and given what we know about influenza and other vaccines and the critical role that healthcare providers play in recommending vaccines, I wondered what we did know about healthcare provider attitudes and what some of the barriers may be. And as an aside, it worries me that if it were not a universal recommendation, that the role of the healthcare provider in identifying and appropriately counseling those with risk would become even more problematic.
Thank you for that question and comment. We will have more information on healthcare provider attitudes in the next talk on implementation. Thank you.
Dr. Long.
I didn't put it up, but I do have a question. I'm sorry, again, I couldn't find it in our written material, but regarding the impact part of your wonderful presentation, I think you said you started with the vaccine effectiveness right after vaccination of 75% in adults. And, you know, we just didn't come close to that in what we saw of real-world vaccine effectiveness. You did mention that you discounted for waning, which was good, but did I misread that?
Hi, Dr. Long. I believe you are referring to the scenario modeling hub's assumptions, and I think Dr. Lessler, who is part of the scenario modeling hub, is on the line to take any of those questions. So I think they started at 75%, but then had some pretty aggressive waning assumptions. Dr. Lessler, are you on the line to speak to that?
Yes, I am. So this is the impact at the moment of vaccination. So the observed impact is going to be lower. For instance, in our high immunoscape scenarios, due to immunoscape alone, by 3 months after the vaccine has been released, vaccine effectiveness would have gone down to 65%. And then with waning with waning as well, you will get vaccine effectiveness in the 50% range by 3 or so months after vaccination if you were vaccinated at the day of release. Our day of release data is based on a study for Denmark that is sort of the only good cohort data that we have for getting that instant time of release effectiveness. But when you look at the effectiveness over the course of a season based on the immunological waning assumptions and the assumptions about how the virus evolves to escape the immune system, these estimates are not inconsistent with what was observed and what was reported in the vaccine effectiveness.
Did you do any modeling of the sensitivity and the difference if, in fact, it wasn't as high as you had assumed?
We did not specifically design scenarios around that. Teams do make different assumptions about the aggressiveness or the speed at which immune protection wanes, and some of those assume very fast immune wanes, some of them assume less so. We do look at scenarios based on the speed of immune escape from the vaccine and look at slower and faster immune escapes. And you do see slight differences in the impact based on the two speeds of immune escape, but it's still a substantial, a positive effect in both.
The reason I ask is that for some of the age groups, the cost per quality is high. And if in fact what you used as the effectiveness against hospitalization, if that's not correct, in the United States in 2024, it will be even higher. Thank you.
Dr. Laird.
Thank you for this wonderful presentation. I'm torn between the recommendation for universal versus risk-based, especially for younger people where the burden of disease is lower and the cost effectiveness is much higher, as Dr. Long just noted. I came in here thinking that I was more in favor of risk-based, and I want to say that because of your presentations today, I'm actually more in favor of universal. I do want to make a sort of longish comment. We got about 4,000 public comments, written comments to the ACIP for this meeting. Of the over 3,000 comments that concerned COVID, the ones I reviewed, over 95% of them were in favor of a universal recommendation. I was very surprised when I saw that. And so it seems that at least the public who are commenting are very in favor of a universal recommendation and want the opportunity to get their vaccination. And I'm also very aware that there are a number of vaccine preventable diseases that we recommend now which probably do not have great cost effectiveness data, which have lower hospitalization rates and have lower death rates than we have with COVID right now. And so on balance, I'm in favor of the universal recommendation. But if I'm just facing this individual decision right now, the cost effectiveness of the younger children is concerning to me. And as I mentioned earlier, the cost of the COVID vaccines are about 5 times, if not more, expensive than the flu vaccine that we're recommending on a regular basis. And so I guess I would still like to make another encouragement for the manufacturers to take that into consideration, that we have a very good vaccine that protects against hospitalizations and deaths, and yet it's very expensive, and a large portion of the population is going to have a hard time affording this in the future as the bridge program goes away. Thank you.
Dr. Jameson?
I just wanted to underscore what Dr. Lair just said. I was really struck with the number of hospitalizations and deaths from COVID in the pediatric population compared to the annual rates of hospitalization and death for other vaccine-preventable diseases prior to vaccine. And so I think it's really important that we not get too caught up in cost effectiveness currently. If we compare it to other vaccine-preventable diseases, it seems like a really good investment.
Dr. Daly?
Yeah, so thanks so much. So first of all, thanks for the presentation. That was wonderful. Dr. Lair, I'm struck as always by your ability to integrate and then bring us to the sort of most pragmatic of decisions. So I really appreciate that. And Dr. Jameson, I was struck by your comments as well. I think let me just highlight a couple things that we've been thinking and talking about. I do want to highlight that I want to make sure we're asking the right question when we look at the cost effectiveness. And then I'll come back to the bigger picture. But to me, it's not a question of, is it more cost effective in an older adult than in a pediatric age group? Because the answer to that is definitely yes. But I think when we look at the cost effectiveness ratios in pediatrics, we need to keep in mind, is there burden preventable through those vaccines? And is it an efficient use of resources? And in order to answer that question, I think we need to take not a comparison to COVID vaccination in older adults, but a comparison to cost effectiveness of other vaccines. And in order for us to make decisions about whether it's an efficient use of resources, we would need essentially a cost effectiveness threshold that we apply equally across all vaccines. Okay. That comment should not be taken as sort of support of sort of profligate use of resources. I think what we need is vaccine costs go down, cost effectiveness goes up, and we need to recognize the burden in pediatric age groups. Okay, so then taking a big step back, I just want to highlight for everyone that's listening that we, in August of 2023, brought to the work group, are you in favor of risk-based strategy, or are you in favor of universal strategy? And the work group at that time reached a consensus that they were in favor of a universal strategy. That's August of 23, voted on in September 23. And then that same question was brought to the work group in March of 2024, and the consensus of the work group was that they were in support of a universal strategy. But that is recognizing, integrating, and interpreting all the data that Dr. Paniolakopoulos just ran through for us. And also putting into the context what Dr. Jameson just said about burden in pediatric age groups, morbidity and mortality from COVID compared to other vaccines, which we willingly vaccinate against. Okay, so I'll just close with one comment, which is that I feel like because the burden was so high in the oldest age groups, we lost sight of the absolute burden in pediatric age groups. And that was coming through early, 2020, 2021, 2022, when I think the message that got heard by parents of young children is COVID doesn't cause bad disease in children. And that was problematic. It does cause disease in bad children. It does cause bad disease in children, just less frequently than it does in older groups. And I think that narrative we need to change. We just need to remind all of us that there still is burden, vaccine preventable disease, and this is obviously my bias as a pediatrician as well, but there's significant burden in pediatric age groups that can be prevented through vaccination. Thank you.
Carol Hayes.
Hi, Carol Hayes with the American College of Nurse Midwives. I just want to kind of bring it all back for 1 second. Somebody said earlier, a couple people said that they were a little bit surprised that healthcare professionals are not recommending the vaccine. And I will tell you that a number of people that I've spoken to, healthcare professionals, the public in general, do not understand how much this virus has mutated, and that if we're not giving the current vaccine, you're not protected. And we have to just keep saying that over and over and over again. You need this year's vaccine to be protected against this year's strain of the virus. Thank you.
Why don't we get the voting language up while I take the liberty of making a comment? I think we're at a position where we still have a lot of morbidity and mortality in kids. And we feel compelled to make sure we protect them, which is the right thing to do. However, I'm not sure that the cost is sustainable. So it really needs to be taken into account that as we continue this program, it is a yearly program and has yearly high costs. And I anticipate as more and more of society is exposed either to vaccine or disease, it will become much less cost effective than it already is. So I think in the idea of keeping this a sustainable practice from year to year, we will need to have a less expensive vaccine to make this work. Dr. Daly?
Yeah, thanks so much for that comment, Dr. Talbot, because again, it's annual, and here, you know, as we've talked about, making comparisons with influenza vaccine is helpful at times, but also we need to be careful not to overinterpret. But in the case of an annual vaccine, I think it's fair to have a comparison with the cost of influenza vaccine because of the expectations on the system. Now, what would drive cost effectiveness up? Okay, one thing that would drive cost effectiveness up is if burden went down even further in pediatric age groups. That would be great, because then the implication is just the burden is low enough. What would drive cost effectiveness down? A less expensive vaccine. But I also want to highlight that this is to a point you made earlier, Dr. Long. If having prior vaccination, bivalent primary series, or having prior infection 1, 2, 3, essentially protected you, you would see no relative VE, okay? Because as Dr. Link-Ellis highlighted, that is relative VE, so it's the incremental benefit of a population who comes in with some level of prior infection and some level of prior vaccination. And if that was enough, you would see no relative VE. So I wanna highlight that point as well. Dr. Link-Ellis has sort of taught me how to think about the relative VE that we're seeing in a much more sort of nuanced way. So that ultimately is a response to your question in a way, Dr. Long, about sort of how much benefit do we get. And we're all disappointed that the waning is as fast as it is, but you would not see that relative VE if coming in the door you had enough protection to not have morbidity and mortality in all age groups, but in the context of this conversation about the cost effectiveness and pediatrics. Thank you.
I think I've worn out the button. This is the language that's proposed. ACIP recommends the 2024-2025 COVID-19 vaccines as authorized or approved by FDA in persons greater than or equal to 6 months of age. Dr. Daly?
I would move, I need to see if I get this right, but I would move to accept the proposed language that the ACIP recommend 24-25 COVID vaccines as authorized or approved by FDA in persons 6 months of age and older. Did I get that right?
Close enough. You made a motion. I'll take it as a motion.
I made a motion to do what I just said.
Brooks, second.
Thank you very much. Okay, later today we'll vote on this language. We have one more presentation prior to a break, which I'm sure everyone needs to get warm and to get their blood moving. We're going to look at COVID vaccine implementation by Dr. Stokely.
Thank you, and I will try to be brief, as I know I'm in the way of that break. So I'll be just reviewing what happened during this most recent season, as well as plans for the upcoming season. Next slide. So I'm going to go very quickly over vaccination coverage, because I think we've seen that in many of the presentations already. Next slide. So this just shows coverage for children aged 6 months to 17 years, as has been reported. As of May 11th, coverage was 14.4%, so very low. Next slide. And as we've heard before, coverage does increase by age group, and then it's also highest among the white non-Hispanic children and lowest among Black non-Hispanic children. Next slide. And then we also see vaccination coverage is lower among children living in rural areas, and then it's highest among households with an income greater than $75,000. Next slide. And so now I'd like to move on to adults. So as of May 11th, vaccination coverage among adults 18 and over was 22.5%. Next slide. So this shows it broken down by sociodemographic characteristics. Again, we see coverage increasing with age. It's lowest among adults in rural areas, highest among adults that are white, non-Hispanic, and lowest among Black, non-Hispanic adults. Also, coverage is highest among households with an income greater than $75,000, and lowest among households with an income that's below the poverty level. Next slide. And then just to compare to the previous season when we rolled out the bivalent booster dose in 22-23, vaccination coverage is about 5 percentage points below what we saw in the previous season. Next slide. Okay, so healthcare providers are the #1 trusted source for information on vaccination, and the recommendation is critical for motivating people to get vaccinated. And we have several data sources that I'm going to show that inform us about provider recommendations for this vaccine. Next slide. Okay. So first, based on data from the National Immunization Survey adult COVID module, adults reported fewer providers are recommending the vaccine compared to August 2021. So in May 2024, about 21% of adults indicated they received a provider recommendation, whereas back in August of 2021, it was roughly 40%. Next slide. So this is a different data source that I want to present, and this is from our internet panel survey. This shows that 67% of those of adults 18 through 64 reported they received a recommendation of any kind. So not necessarily just a provider recommendation, but some sort of reminder for vaccination. And it was 73% for those 65 and over. Next slide. But when we dig a little bit deeper and we look at an active recommendation, meaning that a provider, whether it's a physician, nurse, or a pharmacist, made a recommendation during a visit or made a personal telephone call, we see it's much lower. So about, looking at adults 18 to 64, 18% reported receiving a recommendation from their provider, and about 15% received it when talking with their pharmacist. For those 65 and over, it's a little bit higher, with about 41% receiving a recommendation during a conversation with their doctor, and 22% through a conversation with their pharmacist. Next slide. And so among those who reported having an in-person provider office since September of 2023, we asked if they received a recommendation, if they received an offer for the vaccine, or a referral for the vaccine. And so just note that these categories are not mutually exclusive, so someone could respond they received both a recommendation and an offer. But what we're seeing is that those age 65 and older were more likely than those in the younger age group to report receiving a recommendation during a visit. And then both the age groups are less likely to report receiving an offer or a referral for the vaccine. Next slide. We also break this down by the type of provider that the individual met with. In general, we don't see a difference by provider type in terms of what they talk about. But when they do discuss COVID vaccine, they usually emphasize that the vaccine protects the individual and their loved ones, and that it's important to receive. Next slide. This slide looks at the association of receiving a vaccine based on whether or not they got a recommendation or an offer for a vaccine. So for older adults, again, they're more likely to get the vaccine in general. But for this age group, we don't see a statistical difference in vaccination uptake between being offered the vaccine or receiving a recommendation. And we think that's for this age group, they may be more internally motivated to get the vaccine on their own and not waiting for that recommendation. Whereas with the younger age group, we definitely see a difference between those being offered the vaccine versus those not being offered a vaccine. So just because a recommendation alone may not be enough to get the vaccine. Next slide. And now I want to present results from a survey that's from the provider perspective. So what I just presented was from the patient perspective. So this is from what providers are reporting that they're doing. And so this is also from an internet panel survey conducted through the University of Iowa. And so first I'll focus on adult or providers that treat adult patients. And here most providers reported recommending the vaccine to adults most of the time or always, and there really was no difference by age group of the patient. But you see 40% recommend it most of the time and 26% or 25% always. But we also ask providers that do not recommend the vaccine, why? Why don't you, what is preventing you from recommending the vaccine? And the response is the main, next slide. The main reasons are that the provider thought the patient would refuse the vaccine. There was a medical reason for not getting the vaccine, and that parents are tired, or patients are tired of hearing about the vaccine itself. So there's a lot of vaccine fatigue out there. Next slide. So this just shows providers of pediatric patients. So we see a slightly different pattern. And here you see a little bit, it's more equally distributed between recommending the vaccine sometimes, most of the time, and always, about a third in each group. Next slide. And then looking at the reasons for not recommending the vaccine, the top three are that it's there's high vaccine hesitancy among the age group in their community. The parent will refuse the vaccine, or other recommended vaccines in the age group are a higher priority to administer. Next slide. So now I'm just going to briefly talk about implementation for this coming season. Next slide. This just shows the timeline of what to expect for the availability of vaccine. WHO and FDA have already met to make their recommendations about the lineage to be included for the vaccine. And then, of course, we're meeting today at ACIP. But after the FDA authorizes or approves the vaccine, then it will be available for ordering, shipment, and administration. And so we anticipate vaccine will be available in mid-August to late September. Next slide. And similar to the 23-24 season, CDC plans to approach the fall-winter respiratory season comprehensively to help prevent disease, disability, and death from COVID-19, flu, and RSV, and other respiratory diseases. We will share our everything messages and materials. So this is a campaign to promote protecting your loved ones through vaccination. And this will be done through unpaid channels. And we'll work with healthcare providers to ensure they can continue to be a champion for vaccination and increase awareness and uptake. And then, of course, with each season, anytime there's new vaccines or new recommendations, we develop and deliver clinical education materials for providers, and as well as training to increase their knowledge. Next slide. With respect to health insurance, we do expect that plans will cover the vaccine immediately. Because of the Affordable Care Act, that requires insurers to cover ACIP recommended vaccines without cost sharing. And as well as the CARES Act, that also provides, includes provisions to expedite coverage of COVID vaccines when they become available. So next slide. And then Medicare and Medicaid will also be covering the vaccines without cost sharing. Most Medicaid beneficiaries have access to COVID-19 vaccines, and of course the Inflation Reduction Act helps support providing these vaccines with no cost sharing. Next slide. And then last, a vaccine will be available through the Vaccines for Children program. And just for reminder, those eligible are children through age 18 years if they are Medicaid eligible, uninsured, American Indian, Alaska Native, or underinsured. Next slide. As mentioned previously, the Bridge Access Program has been providing free vaccine to adults who are uninsured or whose insurance doesn't cover all the cost of the vaccine for the 23-24 season. But because of funding rescissions, the Bridge Access Program will be sunsetting in August and will not be available to cover the 2024-2025 COVID-19 vaccine. Next slide. Finally, throughout the pandemic and even more recently, vaccines.gov was a trusted site to go to find where vaccine was available. This site will continue to be available. It is being updated and revised. It will include a search tool to help people find pharmacies near them. We've had some changes with reporting of inventory, so we will not be able to report the inventory available in different locations, but there will be a search tool to help people find a pharmacy near them, and with additional information to contact the pharmacy to make a vaccine appointment. And then the site will also include additional information to help educate the public about the vaccine and what's available. And that is it, so thank you.
Dr. Jameson.
Full disclosure, I'm from the University of Iowa, but I feel compelled to ask the question, was that a nationwide survey that was conducted by University of Iowa?
Yes, it's a national internet panel survey that they do, and frequently with healthcare professionals.
Great, thank you.
Dr. Lair.
Could we go to slide 17? This is reasons why providers are not asking their patients about COVID-19. And I would like to suggest that if we put the word smoking in here, I regularly offer my patients the concept that I want to encourage you to quit smoking. You've heard this from me 17 times. I'm going to keep on giving it to you. But just because the patient will refuse smoking or are tired of hearing about smoking or are tired of hearing about smoking in general doesn't mean that I'm not going to bring it up on a regular basis. So I just really encourage my colleagues to just, even if they've said no in the past or they're tired of it, this is an important preventive health measure that they have to just keep on listening to me, and they can politely decline. But I've had many people who declined in the past who finally said yes. So I encourage you to keep on offering this vaccine to our patients. Thank you.
I'm going to make a comment real quick. I don't want to be too hard on our colleagues. There has been increasing physical and verbal abuse in hospitals and outpatient healthcare settings. This is a very sensitive topic to many people, and some of our physicians may not be recommending it due to concerns about safety of them and their staff. I think that is something that needs to be quantified and studied, because if it's not that reason, then we can be a little disgruntled. But if it is a driving cause of the lack of recommending this vaccine, that is something that not necessarily we work on, but encourage further research and study and efforts. So I think that's really important. All right, Dr. Cotton.
thank you for those comments. I'd like to very much agree with you, Dr. Lair, and thank you for your comments, Dr. Talbot. As somebody who is a very active vaccinator, one of the issues is that somewhere between the two of you where often it derails the clinic visit, and that is quite challenging. So I think for that 40 to 50% of Americans that said that they would never get a vaccine that we saw earlier today, it's going to be hard to flip them, but I do strongly believe in the importance of a clinician stating the importance of vaccine and that we believe it's a good choice for them. My question was about the Bridge program, which was a wonderful way to provide immunologic equity. And I'm wondering if we have information on how many people accessed the Bridge program and then the anticipated lack of a Bridge program starting in August and what type of impact that will be. Thank you.
Hi, thanks for that question. So we do know from between September of 2023 through May of 2024, over 830,000 doses were administered through our pharmacy partners in the Bridge program. And then we know over 630,000 doses have been ordered by our public health infrastructure partners for this program. And then we do know, it is a challenge with this program going away. There is a limited amount of funding available for states to purchase vaccine for uninsured adults, but it surely won't cover the full cost. And as has been mentioned several times, we have been proposing the Vaccines for Adult program because it will be critical to help serve this population.
Thank you, Dr. Schechter.
Thank you for the presentations. I just wanted to highlight the VFC program and that those doses being given, I think, are around $80 a dose and are more cost effective because of those lower prices, and made me think back to the original contracts from the federal government, which I think were half that cost, maybe $30, $40, $20 to $40 a dose. And thinking about the cost effectiveness of that program as well. And then just another comment that I think in California we gave about 100,000 Bridge access doses, which would be more than our budget cost under our adult annual program, which we couldn't afford with our adult annual federal program, and looking for a way to provide those doses ongoing. Thank you.
Dr. Brooks.
They're cheering Dr. Schechter's comments over there. First, just on this slide, the number 2 reason, Dr. Lair, there is no medical reason for not getting vaccinated, generally speaking. So that's either they're making this up or they're uninformed. But there's, other than an acute illness where you may not do it, that is also inaccurate. And then please go to slide 7. And I'm just as a quick comment, again, the Bridge, the most striking contrast on this slide is insured versus not insured. So the uninsured are not getting vaccinated, and we're cutting the Bridge program. So just commentary.
Dr. Cotton, do you have an additional comment? Okay. All right. Dr. Hopkins?
Thank you for the opportunity to comment on behalf of National Foundation for Infectious Diseases, or NFID. I'm Dr. Bob Hopkins, the NFID Medical Director and ACIP Liaison. I want to first thank ACIP for its ongoing work to protect the health and well-being of individuals and communities across the U.S. Vaccine-preventable diseases have a significant impact on public health and the U.S. economy. Since the start of the pandemic, COVID-19 has caused more than 1 million deaths in the U.S. And during the 23-24 respiratory season, flu caused an estimated 390,000 hospitalizations and 24,000 deaths in the U.S., including 178 deaths in children. Pneumococcal pneumonia hospitalizes about 150,000 people each year in the U.S., killing about 1 in 20 of those infected, and RSV estimated to cause up to 160,000 hospitalizations and 10,000 deaths annually among U.S. adults 65 and older. And each year, the U.S. spends billions of dollars treating adults for diseases that could have been prevented through vaccination. Vaccination saves lives, but vaccines are not enough unless they're used. Unfortunately, U.S. vaccination rates remain suboptimal across all age groups, and rates among adults are declining for some vaccines. To address this problem, NFID has convened a diverse group of stakeholders and experts from partner organizations to share insights and best practices for enhancing uptake of all recommended adult vaccines, and several themes emerged. We need to improve immunization information systems, link performance measures, and align compensation with immunization metrics. We need to raise awareness about adult vaccine recommendations among patients and healthcare professionals and simplify our vaccine recommendations to facilitate strong recommendations from healthcare professionals. We need to position vaccination as an integral part of patient management, especially for patients with chronic health conditions and other high-risk adults. And we certainly need to establish a Vaccines for Adults program to cover all recommended vaccines at no cost for uninsured persons. Improving adult immunization rates requires a multifaceted strategy, including health system improvements, public health initiatives, and community outreach.
Dr. Hopkins, I completely agree with everything you're saying. It's very important, but unfortunately we're 30 minutes behind. So if you have something to add to the current discussion on the vote, please go ahead.
I just wanted to note that our summary is available on our website, and a more comprehensive call to action report will be coming later. Thank you for the time.
Thank you so much. All right, we are 30 minutes behind. We have a 15-minute break scheduled, which is now going to be 5 minutes. So quickly do whatever you need to do in 5 minutes, and we'll come back at 11:40. Is that correct? 11:40. All right, good morning, everyone. We're returning back to work.
We need a second.
All right, sorry for the delay. Now we can start. So we are changing topics to influenza, and our introduction will be given by Dr. Lair.
Thank you very much. This is the influenza work group. Next slide. These are the work group members, including myself, Dr. Jameson, who's joining us, Dr. Cotton, who unfortunately is leaving us, Dr. Schechter, who's joining us, and Dr. Talbot. I'd also like to thank, when we get there, all the liaisons and ex officio members, and especially the CDC lead, Dr. Groskopf. I would like to thank her especially for her incredible hard work. I've gotten texts and messages from her after midnight, sometimes asking questions. And so I just want to recognize how hard the CDC staff work, not only on this work group, but on many other work groups. And then on the third slide, when we get to it, the general CDC participants. I'm going to keep on going in the interest of time. We have two major topics today. On the fourth slide, you're going to see influenza A, H5N1 in dairy cattle. The issue is that this has been detected in dairy cows in 12 U.S. states, and 3 human cases have been reported to date associated with exposure to cows. And we're going to have an update from Dr. Vivian Dugan, the director of the Influenza Division, for information and discussion. And on slide 5, we have proposed recommendations for the 24-25 season. These are annual recommendations that we bring up every year for the committee to vote on. The draft recommendations include acknowledgement of the 24-25 U.S. influenza vaccine composition, and this year the vaccines will mostly, I think, entirely be trivalent vaccines. So thank you to the manufacturers for moving forward with changing to trivalent as recommended. There are also going to be new recommendations proposed for the vaccination of solid organ transplant recipients, based on an evidence review and work group discussion, and there will be a vote. In the context of sort of keeping key points up front, the work group has reviewed a policy question asking if 18 to 64-year-old solid organ transplant recipients should be allowed to receive a high-dose or an adjuvanted flu vaccine as an off-label option. This is something which the work group has considered and has found evidence that would suggest that this is a reasonable option. And so we will present an evidence to recommendations on this specific topic. And then I'm going to pass this over to Dr. Dugan, the next presenter. Thank you very much.
Thank you very much, Dr. Lair. Can you all hear me okay in the room?
Perfectly.
Great, thanks so much. I just want to thank you for the opportunity to provide an update on the current H5N1 avian influenza situation in dairy cattle and people. Next slide, please. I'm going to start with a brief overview of high-path avian influenza H5N1. This virus was first detected in birds in 1996. And so while sporadic cases of H5N1 infections in mammals have been reported since 2003, these viruses have undergone extensive genetic diversification as they move through animal hosts. And that really started in 2005, that extensive genetic diversification. And the clade 2344B viruses are the version of the virus that is currently circulating. They first emerged in 2020. They were introduced by wild birds to North America in late 2021. Globally, this particular clade of H5N1 viruses predominate. They have become widespread in birds, wild birds, aquatic migratory birds. They've caused record numbers of outbreaks in poultry as well. In April 2022, H5N1 was detected in a person in Colorado who was involved with poultry depopulation. This was the first US human case of H5N1, first detected ever. Since January of 2022, 29 human cases of high-path avian flu, H5N1, have been detected globally. So I think the overall understanding of the overview of where we are is that H5N1 is not necessarily a new threat to animals and people. So there's a lot that we do know and understand about this particular virus. And so CDC has really been confronting this virus globally for some time, for several decades. Next slide, please. So to put a little bit of historical perspective, since 1997, there have been more than 900 sporadic human cases of H5N1 reported from 23 countries. We've only really seen a small number of human cases reported since 2015. And so in that year, you can see that tall orange bar there on the graph. In that year, 2015, there were a large number of cases. It was close to about 350 reported in Egypt. But again, since then, only a small number reported since then. Next slide, please. So with that background, I'm going to talk about the current H5N1 situation in dairy cattle and the ongoing response in the United States. But I want to just start by stating up front that CDC's assessment of the overall risk for the general public remains low. However, people who have close or prolonged and unprotected exposures to infected animals, that includes livestock, or unprotected exposure and prolonged exposure to environments that are contaminated by infected animals, those folks are at the greatest risk of infection. Next slide, please. So briefly, where we are on dairy herds, this is data provided from USDA APHIS. They have confirmed HPAI, highly pathogenic avian influenza, in dairy herds from 131 farms across 12 states. They're there in the map on the right. Additionally, a few other types or species of animals have also been reported as positive for HPAI on these dairy premises, again, shown there in the slide. Next slide, please. Moving into human cases. So since the outbreak in dairy cows was identified in March, there have been 3 human cases of H5N1 that are associated with exposure to infected cattle. On April 1st, the state of Texas announced that a person tested positive. And in May, Michigan announced the detection of 2 cases occurring at different farms. All infections occurred in dairy workers who had direct exposure to cattle presumed or confirmed to be infected with HPAI. And all patients reported eye redness, watery eyes, and 1 patient also had a cough without fever. No patients have been hospitalized and all have recovered. Given the ongoing circulation and detections of H5N1 in dairy cows, the identification of additional human cases in the US can be anticipated. Again, CDC's current risk assessment of H5N1 for the public, however, is low. Again, the people who are at higher risk of infection are those individuals with close, prolonged, or unprotected exposure to infected animals or to the environments from those infected animals. Next slide, please. Moving into the sequence data of the virus, CDC has conducted sequencing of the viruses from the human cases and found that these are 2344B H5N1 viruses for all the cases, all 3 of them. This is, again, the same clade that has been circulating widely in birds and was also detected in dairy cows, other animals. Importantly, when we look at all of the data being generated from animals in the US, our current diagnostics are able to detect this virus. They maintain their utility. There are no known markers for influenza antiviral resistance predominating in animal populations or in the human cases. And then the virus is very closely related to 2 existing H5 candidate vaccine viruses that we generated here at the CDC, which have been made available to manufacturers and could be used as the precursor to a vaccine if that is needed. Next slide, please. Moving into surveillance, human monitoring, and testing. So CDC continues to assess and analyze emergency department data, influenza laboratory testing data, and other public health surveillance data, especially and in particularly in the areas where H5N1 viruses have been detected in dairy cattle, as well as poultry and wild birds. What we're looking for are any unusual trends in influenza-like illness, influenza activity, or conjunctivitis. So looking at the most recent week of data, the CDC influenza surveillance systems show no indicators of unusual influenza activity in people. That includes avian influenza H5N1 viruses. Since March 3rd, a total of over 30,000 specimens have been tested by public health labs in the US for influenza. Those data are reported to CDC. This number represents any specimen tested for influenza at the public health lab, but these also detect novel viruses or H5N1 viruses. And so as part of our efforts to support state and local public health in this current outbreak in dairy cows, we are supporting their efforts to monitor people who have been exposed to infected animals for any symptoms. And so as of today, more than 690 people have been monitored as a result of their exposure to infected cows, and at least 51 people who have developed influenza-like symptoms have been tested. Next slide, please. In May of this year, CDC began sharing influenza A virus wastewater data from across the US. And so these sites for wastewater are categorized based on the current level of influenza A virus detected in wastewater, compared with levels at the same site during the 2023-24 influenza season. And so these data can complement other human influenza surveillance systems that I just showed you on the last slide. And these current wastewater monitoring methods, again, they detect influenza A viruses. H5N1 is an influenza A virus. So are many other subtypes, but they do not distinguish the subtype specifically. They also don't distinguish a source of that influenza A virus, whether it's from a human or animal source. So when the wastewater system triggers a signal, CDC works with state and local health departments, USDA, and other partners to really better understand the factors that are driving these signals in wastewater, whether it's seasonal influenza circulation in humans, H5N1 circulation in animals, or a potential signal of H5N1 circulation in humans. Fortunately, this latter scenario has not occurred. We have had no potential signs of H5N1 circulation in humans to date. Next slide, please. In terms of epidemiologic investigations, CDC continues to utilize the One Health approach, and that's really where we work with the health and agricultural partners at local, state, and federal levels, as well as with the affected farms. The goal is really to try and answer important public health questions, looking at evidence of infection in exposed populations, looking at the spectrum of illness if we find infections, and a potential rate of asymptomatic infections, should they be occurring. We're looking for what types of exposures to H5N1 are happening on farms and dairy premises, and are there any behaviors that may be associated with human infections that will provide protection from infection. So overall, the focus is to really assess the risk for symptomatic and asymptomatic infection through specimen collection and through surveys or questionnaires to assess exposures and human behaviors leading to those exposures. CDC is providing technical assistance to the Michigan Department of Health and Human Services as the department launches a serologic epidemiologic study of people exposed to sick cows. Next slide, please. So CDC, in collaboration with our state and local public health agencies, we together developed a multifaceted enhanced summer flu surveillance strategy. And so the focus of the strategy is really aimed to identify the spread of H5 to and among people, beginning with monitoring those exposed to infected or potentially infected animals, and then extending to the general population. And this is really being done through our continued seasonal surveillance activities during the summer and spring months. And these activities would typically slow down during the off season, or they would be paused throughout the summer. So we're continuing that seasonal surveillance activity throughout these coming months, and it's ongoing work we're doing now. The plan also calls for increasing the number of influenza virus specimens that are tested and subtyped in public health labs across the US. So that can be H3, H1, H5. lots of the different subtypes. CDC also has been asking health departments to increase their outreach to healthcare providers to really raise that awareness about H5N1 so that patients with conjunctivitis or respiratory illness are screened and tested for H5 novel influenza if, again, that's warranted. This approach will maintain that increased level of testing during the summer months when seasonal influenza activity is typically very low and therefore testing activity often decreases. So we're trying to maintain those numbers and keep them up. Next slide, please. And then I think you're probably aware that CDC is one of several WHO influenza collaborating centers. So our global influenza program focuses on detecting and characterizing seasonal and novel influenza viruses like H5N1. And this really informs our seasonal and pre-pandemic preparedness activities, including vaccine strain recommendations and generating candidate vaccine viruses for pandemic preparedness. In the H5N1 space, we've been very engaged working with the Pan American Health Organization, or PAHO, and other World Health Organization regional offices, as well as the WHO main offices, to really keep our global partners informed of the situation here in the US. Our SMEs have also been participating in WHO updates to technical reports, as well as surveillance guidance and risk assessments for H5N1. Next slide, please. So again, currently, based on the data that we have available right now, the overall risk to the public remains low. But our guidance for people who work with or have recreational exposures to H5N1 infected animals is to monitor for symptoms after first exposure and for 10 days after that last exposure. And we recommend that testing should be done if a person who has been exposed shows symptoms of respiratory illness or conjunctivitis. We have more detailed guidance on our CDC's worker guidance page on our website. Next slide, please. CDC is part of the U.S. government response to the overall U.S. government response to the outbreak of highly pathogenic avian influenza. We're really working in collaboration with the U.S. Department of Agriculture, the Administration for Strategic Preparedness and Response, ASPR, FDA, and state and animal health officials using that One Health approach. We are participating in a unified coordination group, which is co-led by Health and Human Services and USDA. It includes representatives from various parts of the government, and CDC personnel are currently serving on working groups to really provide expertise in those various areas of the response, including epidemiology, lab testing, human vaccines, strategic communications, and stakeholder engagement. Our priorities in responding to high-path avian flu really include support that engaging public health and agricultural partners at state and local health and the federal level, protecting human health and safety by helping states stand up the monitoring of exposed people and testing programs for people working with infected cattle and animals, and assuring that they have the information and resources they need to really prevent infection. Understanding the risk to people from H5N1 through our epidemiological studies and identifying ways to prevent additional cases. And then, of course, assessing H5N1 viruses for any genetic changes that could indicate that the virus may be adapting and may spread more easily and readily among people. Next slide, please. And then lastly, to close us out, we've posted a wide range of resources related to avian influenza on our website. We're trying to really double down and commit to sharing information in a transparent and timely manner. These are a few key resources for your awareness. Happy to close out and take any questions.
Okay, questions? Dr. Shaw?
Thanks very much for that presentation. It's really important work. I think I heard most of the efforts were aimed at detection of cases, but I'm wondering if there are any efforts to evaluate seroprevalence, the assessment of antibodies to H5N1 among dairy farm workers.
Thanks for that question. Yeah, great question. So there are efforts, of course, looking at all of our surveillance systems across the US that we use for seasonal influenza, but they also serve the purpose of detecting novel influenza for any signals there. And then we are, of course, trying to support the states in monitoring those who are exposed to then test should they have symptoms. For serologic studies, that is one of our high priorities here at CDC, and we are supporting the Michigan Department of Public Health in their efforts to initiate an epidemiologic sero study, and so those efforts are ongoing. But certainly, we are looking for more opportunities and working with our partners to develop more opportunities for serologic studies in people as well.
Great, thank you.
Dr. Freihofer?
Thank you. Sandra Freihofer, representing the American Medical Association, but asking a question as a practicing physician. I have a lot of patients who are hunters, and I worry about their exposure to wild birds. You mentioned that current diagnostics will detect the H5. Will our the flu kits we already have to detect influenza A detect H5? Is that a good way to screen? And then if we got a positive, then reach out to our public health laboratory to get a specific H5N1 test kit?
Thanks. That's a great question. And while you're bringing up occupational exposures, we do have guidance available for hunters on our website as well, because I think those have been a population that have been had more increased exposure since this virus has been circulating in wild bird populations quite longer than dairy cows. That said, yes, I think current seasonal commercial assays are expected to detect this virus as a flu A positive. And so that specimen would be important to get that to a state or local public health lab that has these specific CDC assays that can provide that subtype. And so that's going to be important to, as we're messaging and doing outreach through the summer months, and then of course in the upcoming fall, to really think about getting that word out so that we're getting those specimens into the public health department laboratories for that subtyping to occur. But yes, seasonal flu commercial tests are expected to detect this H5 virus as a flu A positive. Over.
Thank you.
Dr. Hahn.
Yeah, thank you, Chris Hahn. I'm representing CSTE, but also I'm the state epidemiologist for Idaho, one of the most heavily impacted states. So I've been very involved with these investigations in our state. And first of all, I do want to thank CDC for really incredible support during this effort. And in particular, we've been working closely with Peggy Honane, who's been wonderful, but also many others. And it has been a really good partnership. I just wanted to comment on especially because this is ACIP, to talk a little bit about the vaccine. We are starting to get questions, more questions from the media about, when would we recommend a vaccine, and is a vaccine available? And there is information, of course, but it is a bit confusing to put into clear messaging that, yes, there is a H5 vaccine in the strategic national stockpile, but it is based on an older strain. And some of this is because of COVID, people are more familiar with these concepts. But then, of course, we've ordered this, the government has commissioned or ordered these new vaccines. But I would encourage, if possible, for CDC, I'm just looking at the current situation page, the H5N1 page. There's no messaging that I can see about vaccine, like it is not, even things like it's not recommended at this time, or there are some in development or would be available. I've seen messages here and there about, in fact, I heard on, I think, a national call, folks saying that we think that within, 130 days, we would have 180 million doses available. Those kinds of messages, if they could be put into talking points, particularly focused on the vaccine, even that it's not recommended at this time is, of course, important. But I would encourage that. I think we could use a little more help in that area, as I think vaccine are on people's minds as we start to talk about fall vaccination for seasonal viruses. So thank you.
Dr. Dugan, did you want to comment?
Sure, happy to comment. I think it's a great statement, and certainly, the ASPR is really the lead for vaccine development and distribution. And so we are working very closely with them. But to be very clear, an H5 vaccine program is not currently planned. U.S. government partners are really working on preparedness planning that includes a vaccine program should it be needed. CDC and ASPR and other U.S. government groups are we're leaning in to maintain that robust preparedness and that readiness stance. Again, should the situation change, but at this point, a vaccine program for H5 is not currently planned. But that's certainly messaging that we can pass along to our colleagues over at ASPR, and we can think about putting that and adding that, incorporating that into our messaging as well, providing those talking points to help our public health partners. Thanks.
Dr. Kimberlin.
I'm David Kimberlin, AAP Redbook. This question may reflect a knowledge gap on my part. Prior to this year, was it recognized that cattle could be readily infected with influenza viruses? And if not, could this represent a mammalian adaptation, albeit to a different species, that had not previously been recognized? And I suppose the same would go with cats.
Sure. Yeah, I'll do my best to try and answer that quickly. I think influenza D viruses, there are different types of influenza viruses. Those have been known to infect cattle. I think there have been some preliminary experiments prior to the current situation in cattle showing that influenza viruses can infect cattle in an experimental setting. That said, I think that we're looking very closely, of course, at the genetics, the genotypes, the phenotypes of viruses to understand that big question. I think from the scientific community, the public health community, the animal community, we do want to try and understand why is this happening now? What has changed? There's a lot of theories on that. I don't know that any of them are further ahead than others, but certainly I think that is a big question that's on the minds of many people right now to understand what has changed. I think the H5N1 virus has been circulating for several years now in wild birds, and it's impacted poultry. So we've had some experience with this particular version of the virus, but I think it's a much bigger question that may take some more time to really figure out.
Dr. Freihofer?
Yeah, Sandra Freihofer, American Medical Association, asking another question as a practicing physician. Any update on the safety of the milk supply and our beef supply? I know that's in the purview of USDA and FDA, but any insider information?
Thanks for that question. No additional information that I have on that. I think all the data and information are being posted on the USDA and FDA sites as they become available. But as far as we are aware and have been told, the milk and meat supplies are safe. Pasteurization works, and but there's continued efforts to work in that space, and so I'll defer to FDA and USDA for additional information.
Thank you. And of course, no raw milk, right? Stay away from that and stay away from steak tartare.
Yeah, raw milk, I think, has never been recommended. It has always been very clear that raw milk can provide lots of different pathogens. So this is just one more for the list where raw milk is never recommended. Over.
Dr. Schaffner.
Yeah, thank you. I'd like to pursue the issue of an H5N1 vaccine just a little bit further. I wonder whether it might be appropriate for the ACIP, through its influenza work group, to be presented data concerning the effectiveness or potential effectiveness of the currently available H5N1 vaccine, the results of studies in ferret, and to at least begin discussions of a possible utilization in a preventive fashion of H5N1 vaccine. I just observed that in Finland, they're starting to use H5N1 vaccine in potentially exposed dairy workers. I think these are issues that are quite appropriate for this committee.
All right, thank you. Thank you, Dr. Dugan, for coming. Any additional questions? All right, very helpful. We're going to shorten lunch a little bit, but not a lot. We will return at 1 o'clock to start promptly with the rest of influenza vaccines. Thank you, everyone.
Talbot and Dr. Wharton and everybody else here, good morning. And we're now going to see if this works. Do I have control over the box? Okay. Go. Should it be working? I'm sorry. I apologize. Great, okay. Before we get started, I'd like to first acknowledge those who assisted in this work or with whom we consulted, but in particular, my teammates on the Vaccine Policy Unit, Jill Ferdinand and Lene Blanton, who are in large measure responsible for getting this work done for this meeting. So this talk has a few topics. First, we're going to cover two quick influenza-related updates, one on the flu vaccine composition for next season, 24-25, and then a 23-24 end-of-season vaccine safety update. We'll then discuss an evidence review of higher dose and adjuvanted influenza vaccines for solid organ transplant, or SOT, recipients, and summarize the evidence to recommendations discussion that occurred within the work group. And finally, we'll review the proposed recommendations for the 2024-25 season. So with that outlined, we'll do our first part, the two influenza updates. The first of these concerns influenza vaccine composition for the U.S. for next season, which was the topic of discussion of the FDA Vaccines and Related Biological Products Advisory Committee on March 5th. All influenza vaccines marketed in the U.S. for the 2024-25 season will be trivalent. Quadrivalent influenza vaccines will not be available, as there will no longer be an influenza B Yamagata component following no confirmed detections of wild-type influenza B Yamagata viruses in global surveillance since March 2020. The U.S. influenza vaccine composition for 24-25 includes an update to the flu H3N2 component. This is noted in red on the slide. For the H3N2 component next season, it will be an A Thailand H2022 H3N2-like virus for egg-based vaccines, or an A Massachusetts 18-2022 H3N2-like virus for cell and recombinant vaccines. These replace the A Darwin 9 and A Darwin 6 2021 from last season. Next, also a brief update, our end-of-season vaccine safety monitoring update for flu vaccines. And we're grateful to Dr. Karen Broder and our colleagues in the Immunization Safety Office for pulling this information together. For the 2023-24 season, as of March 5th, approximately 158 million doses of flu vaccine were distributed in the U.S. In the Vaccine Adverse Event Reporting System, or VAERS, co-managed by CDC and FDA, no new safety concerns were identified for influenza vaccines. Within the Vaccine Safety Data Link, or VSD, a collaboration between CDC and 13 integrated healthcare organizations, which monitors pre-specified outcomes using rapid cycle analysis, approximately 4.8 million doses of flu vaccine were administered through this network as of May 31st, and no new safety concerns were identified in flu vaccine safety monitoring. For reference, the pre-specified outcomes for flu vaccines within VSD are acute disseminated encephalomyelitis, anaphylaxis, Bell's palsy, encephalitis, Guillain-Barré syndrome, seizures, and transverse myelitis. So with that, we'll move on to the biggest part of the presentation, which is the evidence review of higher dose and adjuvanted influenza vaccines for solid organ transplant recipients. First, some background about solid organ transplant in the United States. Over the past decade, a steadily increasing number of solid organ transplants have been performed in the U.S. In 2023, these totaled at over 46,000. Most of these, 72%, occurred in persons ages 18 through 64 years, 24% among those 65 and older, and 4% in children under 18. The most frequently transplanted organ is kidney at 59% of transplants in 2023, followed by liver, heart, and lung. The ACIP recommendations state that all persons 6 months and older should receive an annual influenza vaccine, and also further state that that vaccine should be an age-appropriate one, that is, one that's approved for their age. Specifically, for solid organ transplant recipients, the recommendation is that they should receive an age-appropriate inactivated or recombinant flu vaccine, that is IIV or RIV. Live attenuated influenza vaccine is not recommended in immunocompromised populations, including SOT recipients. However, immunosuppressive regimens taken by SOT recipients might contribute to diminished response to vaccines, and for this reason, high-dose or HD IIV and adjuvanted or AIIV inactivated influenza vaccines have been studied in SOT recipients. The American Society for Transplantation has stated that high-dose or boosted dosing of flu vaccines might be a preferable strategy for those who are post-transplant. And some transplant programs recommend that their patients receive high-dose vaccine if their insurance will cover it. However, HD-IIV and AIIV are approved by FDA for persons 65 years and older, and therefore might not be covered by insurance when administered to persons under age 65 years. If a vaccine is recommended for administration in a population, but not covered by insurance, this could present issues and problems with access. Moreover, if use of the vaccine occurs in practice, it's probably advisable to assess safety. Therefore, a systematic review and grade were performed on this topic. With that background, the policy question for this review was, should high-dose inactivated, adjuvanted inactivated, and/or recombinant influenza vaccines be administered as an option for influenza vaccination of solid organ transplant recipients who are younger than the approved age indication? This would be ages under 65 years for high-dose and adjuvanted influenza vaccines, and under age 18 years for the recombinant influenza vaccine. Next, we'll move through the domains of the Evidence to Recommendations Framework, or ETR, as discussed within the influenza work group. We'll start with Domain 1, Public Health Importance. As noted earlier, an increasing number of solid organ transplants has been performed each year over the last decade, and also post-transplant survival has increased for most types of organs. This has been associated with an increase in the number of individuals living with a functioning graft post-transplant. In 2020, considering the most commonly transplanted organs listed in the chart, and these are the most commonly transplanted solid organs for which systemic immunosuppression is generally required, there were approximately 430,000 recipients who were alive. This represents about 0.1% of the US population. For comparison, the number of persons aged 65 years and older in 2020, and 65 and older is the population which we discussed the last time we were discussing higher dose and adjuvanted flu vaccines, and also the population for which higher dose and adjuvanted are licensed. That population in 2020 was 55.8 million, or 16.8% of the US population. So this is a somewhat smaller population. While the overall number of people living after SOT might not be considered a very large population, however, influenza does impose important burden to these individuals. In general, SOT recipients require lifelong immunosuppressive medication regimens for as long, at least, as their graft is functioning. Manifestations of flu can be more severe in these individuals, with lower respiratory tract disease, including pneumonia, occurring in 22 to 49% of SOT recipients. In a 5-year multi-center cohort of SOT recipients with microbiologically confirmed influenza, 21% had lower respiratory tract disease on presentation, 69% were hospitalized, 11% were admitted to an intensive care unit, 8% required mechanical ventilation, and 3% died of all causes within 30 days. In considering these factors and the question, is influenza among solid organ transplant recipients a problem of public health importance, all influenza workgroup respondents answered yes. Now, the next ETR domain, benefits and harms, where we'll summarize highlights of the evidence review and grade, and this is the domain we're going to spend the most time on. We will get through it and we'll speed up after this. For the evidence review, the PICO was as follows. The population of interest was solid organ transplant recipients aged 6 months and older. Interventions were trivalent or quadrivalent high-dose HDIIV, MF59 adjuvanted AIIV, or recombinant RIV influenza vaccines. Other higher dose vaccination strategies, such as simultaneous administration of 2 doses of standard dose unadjuvanted influenza vaccine, were also included, but those will not be the focus of this presentation. Multiple doses not given simultaneously, but separated by a time interval, were not included. Comparators were single intramuscular doses of standard dose trivalent or quadrivalent unadjuvanted influenza vaccines. Primary outcomes included for benefits medically attended influenza, which was critical, influenza-associated hospitalization, also critical, and laboratory-confirmed influenza, for which immunogenicity data were acceptable as a surrogate. This last outcome was rated as important. There were 3 harms outcomes selected. These included transplant rejection or graft failure, rated as critical, neuroinflammatory conditions such as GBS and ADEM, also critical, and other immune-mediated adverse events, including new onset or exacerbation of an autoimmune condition, for example, also a critical outcome. A total of 9 papers were identified, which described 9 studies. These included 8 randomized studies and 1 cohort study. As far as vaccines and comparisons, there were 2 comparing high dose versus standard dose vaccine, 2 comparing double dose standard vaccine versus single dose standard vaccine, 3 comparing adjuvanted vaccine versus standard dose unadjuvanted vaccine, and 1 which compared adjuvanted, high dose, and standard dose unadjuvanted inactivated vaccine. Finally, there was 1, this was the sole cohort study, which did not have a comparison group, but included instead a single group of participants for which it was reported that most received AIIV3 adjuvanted vaccine. And then there were no papers, unfortunately, examining RIV. With regard to transplant populations, 4 studies included kidney recipients, 1 heart recipients, and 4 mixed transplant populations, within which a sizable proportion or the majority were kidney recipients. There were no papers that reported medically attended influenza as an outcome, or neuroinflammatory conditions, or immune-mediated adverse events, all of which had been considered critical outcomes before the start of the review. There was only 1 pediatric study. The results of this study were omitted from meta-analysis and GRADE, and we focused on adults. The 1 cohort study was excluded from GRADE given small size, lack of comparison group, and availability of randomized studies. This left 7 randomized studies that were included in GRADE. Because of the small number of studies per outcome, a fixed effects model was used for meta-analyses rather than a random effects model. So in the interest of time, of course, we're not going to go over all of the plots in the grade tables, so we're going to instead summarize the results in 3 slides. However, there are available at the back of the presentation should anyone want to see anything. So these slides are going to summarize in tabular format the outcome by outcome, the number of studies, number of participants, pooled rate ratio, grade certainty, and importance. We're going to start with the benefits outcomes, first with the adjuvanted vaccine compared with standard dose unadjuvanted vaccine comparison, which is on this slide. So benefits, critical outcomes, adjuvanted versus non-adjuvanted standard vaccine. For influenza-associated hospitalizations, there was 1 study, including 403 participants, and showing no significant difference between vaccines. Certainty was assessed as low. For medically attended influenza, there were no papers reporting this outcome. For the important outcome of lab-confirmed influenza, there was 1 study, also including 403 participants. There was no difference between the vaccines that was observed. The certainty level here was rated as moderate. Now, immunogenicity, again, was considered an acceptable surrogate for lab-confirmed flu, and therefore is also an important outcome, was reported in 3 studies. All immunogenicity results were downgraded for indirectness, given that they're an indirect surrogate of lab-confirmed flu and not lab-confirmed flu. Papers reporting immunogenicity generally described results in terms of geometric mean titers, seroconversion, and seroprotection. It was unfortunately not feasible to pool geometric mean titer results due to differences in how these results were reported among the various papers. It was, however, possible to pool seroconversion and seroprotection results, which were generally reported as binary outcomes. Seroconversion was generally defined in studies as a 4-fold rise in titer post-vaccination, as compared with pre-vaccination. Seroprotection generally defined as post-vaccination titer of at least 1 to 40. Since some participants might have already had a titer of 1 to 40 at baseline, seroconversion is perhaps more informative. So just describing the results after all that preamble, immunogenicity was also, one more thing, assessed at more than one time point in many studies. The time point selected in these slides was the one closest to 4 weeks. For most studies, this was about 28 to 30 days. Post-vaccination, for one paper, it was 21 days. Likelihood of seroconversion was greater with adjuvanted vaccine than with standard vaccine, with rate ratios ranging between 1.37 and 1.64 for all 3 vaccine components, H1N1, H3N2, and B. This evidence was assessed as low certainty. Likelihood of seroprotection was greater with adjuvanted vaccine for influenza A, H3N2, and B components, and was also assessed as low certainty evidence. For the high dose versus standard dose unadjuvanted comparison for critical outcomes, there was similarly no difference in flu-associated hospitalization, also rated low certainty here, and there were no data from medically attended influenza. For important outcomes, there was no difference for lab-confirmed influenza, which was assessed as moderate certainty. Again, we also have immunogenicity data here. There was evidence of greater rate of seroconversion for high dose, with rate ratios ranging from 1.9 to 2.46 for all 3 viral components. This was assessed as moderate certainty. There was also evidence of improved seroprotection to H3N2 and B, also of moderate certainty. As mentioned, it was not feasible to pool the GMT outcomes across papers because they were simply reported too differently across papers. In some cases, also did not include confidence intervals. However, we can summarize them narratively. For the higher dose influenza strategies versus standard dose, there were 3 studies, but really only one that was a true high dose versus standard dose study. The other 2 examined double dose standard vaccine versus single dose standard vaccine, and that strategy has only half the antigen content of our current high dose flu vaccine. For the true high-dose study, Nattori et al., median fold rise in titers post-vaccination versus pre-vaccination were greater for high-dose versus standard vaccine, and these differences were cited as statistically significant in the paper for all 3 vaccine components. For the double-dose studies, there was evidence of higher post-vaccination titers for the double-dose strategies, and these results were not statistically significant for Mombelli 2018, and no statistical test was noted for Odongo 2022. For adjuvanted versus standard dose comparisons, there were 3 studies. For Kumar 2016, geometric mean titers were noted to be similar between the 2 groups. Magnani 2005 noted that both groups had significantly increased titers only against flu B for both vaccine groups, but stated that when you compared the 2 vaccine groups, there were no significant differences in immune response between the 2. For Pollack et al., GMT ratios post versus pre-vaccination were higher for adjuvanted vaccine than for standard vaccine, but no statistical test was reported. The last study, Mombelli et al. 2024, the most recent one, was notable in that it was the largest with a total of sample size of 616, but also because it was the only one that compared high-dose adjuvanted and standard dose unadjuvanted vaccines with roughly 200 participants in each group. In this study, seroconversion factors, so that's the ratio of the post-vaccination versus pre-vaccination titer, at 28 days were higher for both high-dose and adjuvanted vaccine compared with standard dose. Slightly higher titers were obtained for high dose than for adjuvanted, though you can see that there's some overlap in confidence intervals between the groups, which isn't as evident in either of those vaccines versus the standard dose vaccine. Next, summarizing harms. Again, we had 3 pre-specified critical outcomes, but data were available for only 1, graft rejection. For both adjuvanted and high-dose comparisons with standard dose unadjuvanted vaccine, there were 3 studies, each comparison totaling over 500 participants. No significant difference in risk of rejection was noted for either AIIV or HDIIV versus standard dose unadjuvanted vaccine. So for a narrative summary of benefits, there's no significant difference for either adjuvanted or high dose versus standard vaccine for flu-associated hospitalizations, critical outcome, low certainty, or lab-confirmed flu, important outcome, moderate certainty. There was evidence of improved immunogenicity for both adjuvanted and high dose compared to standard vaccines. This was, of course, a surrogate outcome for lab-confirmed flu, so it's also an important rather than a critical outcome. There were no data for medically attended influenza, which was a critical outcome. One thing we did not cover in the interest of time, in the one study that included both adjuvanted and high-dose vaccine, there was evidence of better likelihood of seroconversion to H1N1 for the high-dose vaccine, but there were no significant differences in the other viral components or any of the other outcomes. Narrative summary of harms. There was no significant difference in risk of rejection for either adjuvanted or high-dose vaccine versus standard dose unadjuvanted vaccine. Critical outcome, moderate certainty. There were no data, again, for neuroinflammatory or other immune-mediated adverse events, also a critical outcome. In the one study that included both adjuvanted and high-dose vaccine, there were similarly no differences in the rates of rejection between those 2 vaccines. In summary, for adjuvanted versus standard dose vaccine, no difference in flu-associated hospitalizations, critical response, low certainty evidence, no difference in lab-confirmed flu, important outcome, moderate certainty evidence. Oh, shoot, okay. Sorry about that. And for immunogenicity outcomes, which were surrogates for lab-confirmed flu and also important outcomes, we did have evidence of better immunogenicity or better seroconversion for all 3 viral components. For harms, no difference in risk of rejection, critical outcome, moderate certainty. For high dose versus standard dose, no difference in flu-associated hospitalizations, no difference in lab-confirmed flu. Both the flu-associated hospitalizations, critical, low certainty. Lab-confirmed flu, important, moderate certainty. For immunogenicity outcomes, again, surrogates for lab-confirmed flu, again, evidence of better likelihood of seroconversion for all 3 components. This was judged to be moderate certainty evidence. For harms, similarly to the adjuvanted versus standard comparison, no difference in risk of rejection. Limitations of this review include there are few studies, and most of them are small, with 4 of the 7 included in grade having under 100 participants. Having few studies per outcome by comparison means that we did use a fixed effects model. This is something that's common within the ACIP grade framework. The general guidance is if you have fewer than 2 studies, you definitely should use fixed effects. Other sources don't put an exact definition on what few means exactly. We went, even though we had some comparisons with 3 outcomes, with a fixed effects model across the board. In general, this will of course tell you what the pooled results are for the studies that you have, but most authors say that that means there's less ability to make inferences to the general population. Nonetheless, this is something that's commonly done in grade evaluations within the ACIP framework. There was no direct evidence of relative benefit of either high-dose or adjuvanted vaccine versus standard vaccine because we only have immunogenicity data. Variability in timing of the immunogenicity endpoints and how they are reported is something that we need to consider. Also, we have variability in the GMT results that makes it difficult to pool the results. We have no information for several critical outcomes and no evaluations of RIV. Moving on to the workgroup determinations for this domain, the response to the first question, how substantial are the desirable anticipated effects, reflects some uncertainty consistent with the lack of evidence of benefit for the direct outcomes. The most frequent response was don't know. Almost as frequent, but slightly less common, was small. A minority of respondents answered moderate. Responses to the second question, how substantial are the undesirable anticipated effects, were somewhat more consistent, with a majority of respondents answering minimal and a minority answering small or don't know. In discussing the balance of consequences, we again have a little bit of uncertainty. Some in the work group acknowledge that data for use of the high-dose and adjuvanted vaccines among solid organ transplant recipients are limited, and that, again, there are no clear lines of direct evidence that these vaccines are more beneficial in this population. However, others noted the evidence of potentially better immunogenicity, though indirect, suggests the possibility that they might offer greater benefit, and that there also didn't seem to be greater safety concern as compared with standard dose and adjuvanted vaccines. These themes are evident in the diversity of responses for the question, do the desirable effects outweigh undesirable effects, for which the most frequent response was favors intervention, but fewer responded favors both, favors neither, or don't know. Lastly, for this domain, the certainty of evidence for both AIIV3 and HDIIV3 versus standard dose unadjuvanted vaccine based on the lowest certainty assigned among the critical outcomes was low for benefits based on certainty for influenza-associated hospitalizations and moderate for harms based on certainty for graft rejection. Now the next ETR domain, values and preferences. No direct evidence was identified reflecting values and preferences for specific flu vaccine types among SOT recipients. There might be evidence of healthcare provider preference for HDIIV as evidenced by the recommendations of the American Society of Transplantation and various transplant programs. With regard to the question of whether target population feels that the desirable effects are large relative to the undesirable effects, the majority work group response was probably yes. A lesser proportion responded don't know, and a still lesser proportion yes or varies. For the question of is there important uncertainty about or variability in how much people value the main outcomes, there was considerable variability of the answer here. The majority of the work group responded that there is probably not important uncertainty or variability, but a minority of respondents indicated that there is or probably is important uncertainty or variability, or that there is no important uncertainty or variability. The next domain is acceptability. Acceptability of a recommendation for acceptable use of high-dose vaccine as an option for SOT recipients is possibly evidenced by the recommendations of the AST and some transplant programs for the high-dose vaccine. However, acceptability might be limited among healthcare and public health systems and insurers by need for things such as changes in standing orders, immunization information systems, and electronic medical record platforms. For the question of is the intervention acceptable to key stakeholders, most workgroup respondents indicated probably yes, a minority indicated yes or varies. Next, resource use. Following consultation with our health economics group, no economic analysis was conducted for this assessment. The reasons for this is that the population is relatively small, again, roughly 430,000 as of 2020. And there was also insufficient data concerning some critical inputs that would go into the model assumptions, such as the relative effectiveness of different influenza vaccines for SOT recipient populations, and insufficient data indicating the extent to which use of these vaccines is already occurring among off-label use SOT recipients and how much that might improve with the difference in recommendation. It should be noted, however, that high-dose influenza vaccine and adjuvanted influenza vaccine are more costly at about $73 to $77 per dose than unadjuvanted standard dose influenza vaccines at $21 to $34 per dose. With regard to the question of is the intervention a reasonable and efficient allocation of resources, a majority of responding workgroup members indicated probably yes, with a minority indicating yes or don't know. Next, equity. No literature was found concerning use of enhanced influenza vaccines among transplant recipients to reflect issues related to equity. There is evidence of racial and ethnic inequities in the use of high-dose influenza vaccine among older adults 65 years and older, again, the licensed indicated population for these vaccines, from a study of Medicare beneficiaries age 65 and up, which found that Black, Asian, and Hispanic persons were 26 to 32% less likely to receive high-dose vaccine than white persons. Again, these are not data that are specific to SOT recipients, but rather older adults within the licensed indicated age range for these vaccines. However, a work group member noted other potential barriers for SOT recipients. SOT recipients face barriers in that to receiving newer influenza vaccines in that they are usually excluded from clinical trials, as are other immunosuppressed populations, and there are therefore fewer data for their use in this population. Moreover, transplant programs with greater financial resources might be able to afford to purchase these vaccines for their patients, whereas those that are less well-resourced might not. This could conceivably contribute or exacerbate inequities. For the question, what would be the impact on health equity? The most frequent answer provided by work group respondents was that equity would probably be increased. Lesser proportions indicated probably reduced, probably no impact, increased, or don't know. Next, last domain is feasibility. Since much of the impetus for this review concerns insurance coverage and that's an access issue, there was a good bit of discussion about this. The work group discussed a number of factors which might favor or not favor feasibility of a change in recommendations. Factors possibly favoring feasibility include the possibility that a recommendation might improve access to higher dose and adjuvanted flu vaccines if that recommendation makes it more likely that they will be covered by insurance. If they are covered, insurance and reimbursement concerns should be minimal. It was also noted that vaccination should be easily implementable in office and retail settings that serve adults, as these vaccines are already licensed and routinely stocked in many such settings. Factors possibly not favoring feasibility include the possibility that a recommendation stating just that use of these vaccines in SOT recipients under age 65 is acceptable might not compel users to cover them, and if that's the case, access might not be improved. Also, use of vaccines in new age groups will again require changes to things such as standing orders, electronic medical record programming, and immunization information systems, for example, which will require time and effort. On the question of is the intervention feasible to implement, the majority of the work group responded probably yes, and the remainder who responded indicated yes. Lastly, concluding questions in the ETR framework, balance of consequences, and sufficiency of information. With regard to balance of consequences, the majority of work group respondents indicated that the desirable consequences probably outweigh undesirable consequences, with a lesser proportion indicating either that the balance is closely balanced or uncertain, that desirable consequences clearly outweigh undesirable consequences, or that there is insufficient evidence to determine the balance of consequences. There were no responses indicating that the undesirable consequences probably or clearly outweigh undesirable consequences. With regard to whether there is sufficient evidence to move forward with a recommendation, the majority of work group respondents indicated yes, with a minority indicating no. With this, there was discussion of proposed draft language, and that is included in the next section, which is proposed recommendations. If it is preferred, I can stop and pause for questions now, or we can do the last slide. Shall I go on? Okay. So I'm going to mention the proposed recommendations for next season in totality here and include last the proposed recommendations concerning the evidence review we just discussed. The proposed 2024-25 recommendations include information on the updated vaccine composition for 2024-25 and a discussion of the fact and the reasons for next season's vaccines all being trivalent. No changes are proposed compared to previous recommendations for things such as the population recommended for vaccination, timing of vaccination, contraindications and precautions. All of those things are similar to last year, and therefore no votes are proposed for these topics. Proposed for vote are reaffirmation of the recommendation that routine annual influenza vaccination is recommended for all persons aged 6 months and older without contraindications, which is the same as previously. and also proposed our updated recommendations for solid organ transplant recipients, worded in draft as follows. All persons should receive an age-appropriate influenza vaccine, i.e., one approved for their age, with the following exception. Solid organ transplant recipients aged 18 through 64 years on immunosuppressive medication regimens may receive either HD-IIV3 or AIIV3 as an acceptable option, without a preference over other age-appropriate IIV3s or RIV3. The focus of adults, on adults in this language reflects the fact that we had minimal data for pediatrics, and the inclusion of both vaccines reflects the fact that there were relatively similar data for both high-dose and adjuvanted vaccines. RIV is excluded as there was no data available for that vaccine. So that concludes my presentation. Thanks very much for your attention through all of that, and I'd be happy to discuss any questions.
Questions and discussion at this point? Dr. Cotton.
Lisa, thank you very much for the excellent presentation and all the hard work over recent times. This is an excellent review of the situation. This is a topic that's near and dear to my heart, of course, as many of you know. We believe that transplant patients really suffer from a lack of good protection from the standard dose vaccine. And for a long time, we've worked to give people higher dose vaccine, but the vast majority of people aren't covered unless it's age appropriate for them. And so we've been in a situation where we have to fill out prior authorizations every single time we want to give an influenza vaccine, which is obviously not a tenable situation, and it's usually refused by insurance. So we're really hoping that if we voted in favor of this change for solid organ transplant recipients, that it would enhance equity and enhance protection for this vulnerable population. It does highlight the situation where almost all phase 3 vaccine studies automatically exclude immunocompromised patients. In the most recent survey data from the CDC, it's estimated that 7% of the US population is immunocompromised. So I think it's time that we really think hard about how to include immunocompromised patients in studies, and we have appropriate levels of information. I mean, we've seen this again and again, whether it's RSV vaccine, COVID vaccine, influenza vaccine. These patients who are the most vulnerable to infection are automatically excluded from trials, and then we don't have a mechanism to have, I apologize for the paucity of data. This data was put together by many of my colleagues nationally and in Canada, and in the Swiss cohort trial is the most recent one by Mombelli. But unfortunately, we don't have funding to do multi-center trials. So until such time as industry and regulatory agencies decide that immunocompromised patients must be included in clinical trials, we would have to continue working like this, which is not really an acceptable situation for a significant vulnerable portion of the population. So thank you very much for taking this aspect of the influenza vaccine situation on, as I think this will be greatly welcomed by my transplant community. Thank you.
Dr. Shaw.
Yeah, echoing Dr. Cotton, thank you very much for this presentation. I had a question on the wording of the proposal. So, as I understand it, there's no preference. So the folks who are 1864 could get the standard dose vaccine if they wanted, or the recombinant vaccine, or any of them.
Yeah. That's correct. There really is not evidence to support a preference.
Okay.
For adults, since the recommendation language as it's currently drafted focuses on adults, RIV was already an option and still is because it's already licensed for 18 and older. So the main change is that it would make it acceptable to administer high dose and adjuvanted, which are for 65 and older, to a younger population.
I see.
But no preference.
I mean, I think the recombinant vaccine is kind of interesting. It's actually a somewhat high-dose vaccine, right? It contains 45 micrograms of each HA compared to 60 for high dose and 15 for standard dose, but it doesn't have any of the other stuff that could be in the split vaccine like neuraminidase or something like this. So in some ways, it's kind of a little bit of a high dose. And there was a study, I think, in non-immunocompromised compromised 50 to 60-year-olds that suggested it actually had a decreased rate of influenza compared to standard dose vaccines. So I just bring it up. It's a little bit in a special category compared to standard dose.
Agree. It's definitely a higher dose flu vaccine, and it has 45 micrograms as compared with 15 in a standard dose inactivated vaccine versus 60 in a high dose vaccine per virus. And you know, as most folks probably remember, for the older adults preferential recommendation, high dose adjuvanted and recombinant are included, but we did have some data for recombinant that we don't have here. So the thinking, there was not a vociferous desire to include RIV in this recommendation. But that population could receive it because it's licensed for 18 and older.
Dr. Lair?
Thank you, Dr. Grothkopf, for this presentation. Could you go to slide 14? And while you're doing that, a question which came up for the work group was, what about pediatric solid organ transplants? And according to Dr. Cotton, there's an ongoing study that will be coming out very soon, so we'll have more data. In addition, it's only 4% of the population, so the work group was not ready to extend this to pediatric solid organ transplant people at this time. You can go back one slide, or wherever the one you just had. Nope, sorry, the other way. I was surprised that in a 5-year cohort of solid organ transplant recipients with influenza, 69% of them were hospitalized. And it just goes to show how important vaccines are for this community. Dr. Cotton gave a wonderful example of how vaccines have changed the life of immunocompromised and solid organ transplant patients. And I was wondering if you could give that example to the whole work group here, to the whole ACIP here. Thank you.
Thank you, Dr. Lair, for highlighting the importance of influenza for transplant patients. I have lost many patients to influenza, many of whom were vaccinated, but nonetheless not adequately protected. The situation I'd like to comment on is with Shingrix, for which in 2021 we made a recommendation for all immunocompromised patients 18 years of age and over to get shingles vaccine either before immunosuppression or while they're on immunosuppression. This has been an absolute game changer for my clinical work. About 50% of organ transplant patients get shingles at some point in their lifetime. It's 1 in every 3 Americans, 1 in every 2 immunocompromised, including organ transplant recipients. And it has been dramatic. I no longer see as much shingles as I did before. It's really been dramatically reduced. I'm still seeing shingles, unfortunately, in people who aren't yet vaccinated. And so it's been really hard to get all the adult vaccines administered. I think we really need to learn more from our pediatrics colleagues. It's always a sad day when I see people who should have gotten vaccinated and who have shingles. But nonetheless, it is truly impressive how much of a dent we have put into a very common disease by changing recommendations. So I'm very appreciative to the shingles work group and ACIP and CDC for making that change and really helping my patients. I often had seen disseminated disease with meningoencephalitis. I have patients who've had brain damage from shingles, and I am delighted to not be seeing nearly the amount I previously was. So thank you.
Dr. Brooks.
First of all, it's really nice to see a presentation just on immunocompromised patients, just not as a subset of something else. So 2 things. One, could you go to slide 28? That's not my 20. Okay, it's the slide that says benefit and harms, certainty of evidence. And keep going. And one more, I think. Yeah, so I listened to the presentation, and And I kind of understand the one on the left, the lowest, because there's just no data or very little strong data. But I missed why the work group felt that the harm of the intervention was not very low or no studies or something, but moderate. I mean, that's second to high.
It's the certainty of the evidence, not the level of harm. So they're pretty certain, they're moderately certain that that their data on harms is good, not that there's lots of harms.
Okay. Well, thank you. Then the other question I had was the language, and it was just brought up, and so that was, I guess, the next to last slide. And when I read it, it almost felt contradictory, but I think that the meaning of the language is that if you don't choose high dose, then there's no preference. So can we get to the language?
I think
there. So the very last phrase, either so-and-so can be as an acceptable option without a preference over other age-appropriate IV3s or RIVs. So is that saying that you can go high dose or not, versus if you don't go high dose, then there's no preference over the other regular doses? Do you understand what I'm saying is the distinction?
So the work group's goal was to not have a preference for high dose or adjuvanted over standard dose, because we did not feel comfortable that we had enough data to do that. And so we can finesse the wording in any way that that goal is met. The other goal was by making an off-label recommendation. The hope is by putting this in there, it is more likely to be covered by insurance. So those are the two goals of the work group, and I think we're open to whatever language the ACIP feels is appropriate to meet those goals.
So from my perspective, I think you reached your goal. I thought I was interpreting it wrong, but you're telling me that I interpreted it correctly. So that's fine.
Can I make a recommendation for the wording? All persons should receive an age-appropriate influenza vaccine without a preference. However, solid organ transplants may receive high dose or the adjuvanted additionally, or it may additionally receive, or something like that, as an option, as an additional option.
Can I say something?
Yes.
So there's been some additional work on wording as part of the background documents for this meeting, and it might be helpful to pull that up. I think it possibly will be helpful.
In the meantime, did you have a comment that's not wording related? Dr. Daly, would you please?
I've long struggled with what Dr. Cotton has said about why we don't have more data in this group, but I don't understand why we're not making progress. And I would say the same for pregnancy. And so first, I think we need to encourage vaccine manufacturers to very early in their program enroll patients with immunosuppression and pregnant women, as appropriate for the context, obviously. But we've said that for years, and it's not happening. And so is that, do we need legislation like that there needs to be a pediatric arm of a vaccine trial? And is that a legislative question to say we also need study in immunocompromised and study in pregnant women? And if it's not sort of legislative, where is the leverage?
Dr. Kaslow, could you comment on this question?
I think Dr. Daly stated it accurately, right? That
it's legislative.
No, that currently there's not a statutory requirement to collect data for these populations. And we do need substantial evidence in order to put that in the appropriate sections of the U.S. package insert. Over.
So can I ask, what would the vision be, perhaps you and Dr. Beigel, what would the vision be for how to ensure that that happens moving forward? Because we are leaving significant populations unprotected.
I think it needs some offline discussion. I don't have a clear solution for you. You know, I guess the concern is if you made it a requirement, you would delay, you potentially would delay the adult getting that. So it needs to be done, but it doesn't need to be done at the time of licensure. So I think there just needs to be some further discussions on what would encourage that.
I'd like to say, Dr. Cotton and Dr. Daly, I completely agree. And it's not just pregnant women and transplant. We don't do this with the frail elderly. We don't do this with our nursing home patients. And the issue is, this is the population who's at the highest risk of disease, but the same reason they're at highest risk of disease is that they're less likely to create an immune response even to immunization. And it is expensive and time-consuming to do these studies in a population that may or may not respond to immunization. But in all reality, the population that needs the vaccines are the ones that are not likely to respond and the ones where we need the most data. And so I do think an offline conversation, any conversation, is critical for these groups. We saw this with COVID. We got it licensed and everyone's like, use it in the nursing home patients, and we didn't even know if it would work in the nursing home patients. So I think this is a key topic for any group at risk that's unlikely to respond well immunologically. I believe this is the newest proposal that's up right now. So I'm going to read it and then y'all can. ACIP recommends high-dose inactivated and adjuvanted inactivated influenza vaccines as acceptable options for influenza vaccination of solid organ transplant recipients aged 18 through 64 years who are on immunosuppressive medication regimens without a preference over other age-appropriate inactivated or recombinant influenza vaccines. Okay, so I'm hearing very clear from some of the members without mics on. So I think our next step would be a motion if you. Oh, Dr. Schechter has a comment. I'm so sorry. Anyone close to me? I can't see. I see like the back. Yes, Dr. Schechter.
Two comments. So getting back to Dr. Shaw's question, for 65 plus, we've got three equally acceptable alternatives and include recombinant along with adjuvant and high dose. And if I could just hear again how why having recombinant alone is, it would be helpful to also have high dose and adjuvanted as options as well for this population, if it's about access or that we've got slightly more, we've got a bit of evidence around these two options where there isn't any specific evidence around recombinant, but just to clarify that, what the addition of the two options brings to, and how it compares or doesn't compare to the 65 plus. So that was comment one.
Why don't we have her answer that, and then we'll do the second one.
So one issue is that we see in many seasons that the sort of geography of how the different vaccines are distributed varies. If you're looking for Fluarix or regular Fluzone or Flulival, they're pretty. You can find a standard dose unadjuvanted flu vaccine everywhere. Geographically, because we only have one recombinant and we only have one high dose and we only have one adjuvanted, these things sometimes are in different places. So having a few options is probably a good thing. The other thing is that historically, there hasn't been a lot of recombinant vaccine as much as there has been of other vaccines. And so that, just specifying the vaccine that's within the approved, indication that's okay for 18 through 64 years based on approved age indication might limit people's options a bit. And again, we don't have data. There's, we saw in older adults that it looked very promising in the data we had, but we don't have it for this population, and there may be things we don't know. Recombinant only has the one antigen in it. There may be some interplay with other antigens that the more diverse antigen vaccines have that we don't know about in this population. So that would be my answer to that. Thank you.
My second question or comment was with the limited information we have, I would still feel very concerned about even after high dose or adjuvanted vaccine, the outcome of the person receiving that vaccine. And I'm just wondering if it's appropriate within the recommendations to reiterate prompt access to antivirals or other measures for this population, or if that's outside the scope of the document.
Dr. Groskopf, I'm trying to remember the MMWR. Isn't there something about vaccination is one form of prevention, but other forms may be appropriate, like additional forms? How does that word it?
Antivirals are definitely discussed very briefly, but that's something that is a more general statement that we could add that really applies to everybody that's at high risk. And we also do have links to the clinician guidance for antiviral use, both CDC and IDSA. So that honestly probably is appropriate for everybody, but particularly high-risk populations like this one. So that's something that we could be adding for sure. That would be a simple thing to do.
Okay. I have, yes.
The concern
Long,
about
let me get your name.
pregnant people, there's definitely concern, and I think the disease is because people are not vaccinated. Do you know evidence that pregnant people respond less well to the vaccines that are available?
No, I was trying to make a broader argument about studying vaccines in the populations most at risk or most likely to benefit. And we've had that conversation about pregnancy perhaps in the context of other diseases than influenza. So that comment was not specific to influenza. But thanks for
Helps the
clarifying.
baby too, so clearly influenza vaccine.
We have lots of work left to do in the field of vaccines, undoubtedly. Any other questions? I don't see any online. Yes, so we went back to, we have to have 2 votes. So we went back to vote 1, and then we can go back to vote 2. So, Dr. Cotton?
I'd like to make a motion to move vote 1.
Any seconds? Dr. Daly, second?
Second.
Okay, and before we move to motion 2 or vote 2, do we have any discussion on this motion? Okay. All right. May we move to vote 2 now? There we go.
I'd like to make a motion to move this to a vote.
Yes, any seconds? Dr. Lehrer?
Second, please.
Okay. All right. Any discussion on this motion?
The wording, when you really say people are on something, they're sitting upon it. So it's a little jargon. Who are receiving would be more correct English.
Absolutely, thank you.
Well done. Okay, any other influenza related? I would like to make one comment before we move on. One of the beautiful things about influenza is it was the simplest recommendation since 2010. It has been everyone over 6 months of age. I think as we're learning about these special populations and we have newer enhanced influenza vaccines, our recommendations are becoming more complicated, and there's nothing wrong with that. It's just a statement of fact and something we need to keep in mind as we continue to change the influenza recommendations. All right, we are going to move to pneumococcus. This has been a very adult-heavy day. This has been a very adult-heavy meeting. Dr. Kaslow.
Yeah, thank you. Just a really quick intervention to address a question that Dr. Wang brought up in terms of the flu-bot quadrivalent, and just direct you to a recent comment in the New England Journal from Dr. Wu and Dr. Holtz, which says that although flu-bot quadrivalent contains 45 micrograms per recombinant hemagglutinin per influenza strain per vaccine dose, so a total dose of 180 micrograms, it is not considered a high-dose vaccine because the manufacturer determined during clinical development that the increased amount of recombinant hemagglutinin, 45 micrograms per recombinant hemagglutinin, was necessary to induce an immune response that was adequate for further clinical development. Over.
Thank you for the clarification. All right, so we're moving on to pneumococcal vaccines, and we're going to start with an introduction by Dr. Lair.
Good afternoon. This is an introduction on pneumococcal vaccines. Next slide. I'd like to thank the members of the work group, Dr. Long, who's unfortunately leaving us, and Dr. Schechter, who's just joined us, the ex officio members, the liaisons, and the consultants. Next slide. I'd also like to thank Dr. Kobayashi, who's been a wonderful lead, who's helped us guide us through a lot of conversation and discussion that you'll hear about today. So thank you for all the hard work. Next slide. If you look back to 2010, we recommended the PCV13 pneumococcal vaccine in children. And as you can see, there was not only a reduction in the invasive pneumococcal disease rates in children, less than 5, but there are also decrease in rates in adults who are not targeted for vaccination. Next slide. Oops, sorry, go back one. You'll look then, however, around 2014, we recommended the same vaccine for adults, and unfortunately that had little population level impact on the IPD rates. COVID had a much more dramatic impact, as you can see in 2020. Next slide. These are some of the recommendations that we've made over the last several years. Next slide. And today we're going to be addressing PCV21. This is a very important slide that I'd like to spend a little bit of time on. Unlike PCV15 and PCV20, which were incremental changes to PCV13, PCV21 does not equal PCV20 plus one new serotype. Specifically, PCV21 has several serotypes that are not in PCV15 and PCV20, and those are at the right hand of the slide. And PCV21 is missing several serotypes that are in PCV15 and PCV20 on the left hand of the slide. And so this is a totally different combination of serotypes. One serotype to notice quickly is serotype 4, which is in PCV20 but is not in PCV21, and that'll come up in a couple of slides. Next slide. The reason the change in serotypes, I'm sorry. This is the new vaccines which are coming up in development, and so there's a PCV24 and a PCV31 which are being considered. PCV24 has completed the phase 1-2 study for adults, and PCV31 has completed the phase 1-2 study, completed enrollment of the phase 1-2 study in adults. Next slide. This slide is important because it explains why PCV1 is so important for adults. If you look on the left-hand side of the slide, PCV21 covers 81% of the serotypes that are commonly found in adults. So while it loses 13% of the serotypes that were in PCV20, it gains 36% of other serotypes that are more commonly found in adults. And so it has a broader application for adults and the serotypes that are commonly found. And you'll also see that for both 19 to 64-year-olds who have a risk indication, but also for over 65-year-olds. Next slide. There has been noted an increase in serotype 4. This again is not in PCV21, but is in PCV20, and this is in certain subpopulations. And so adults experiencing homelessness had a 100 to 300 times higher serotype 4 IPD incidence. And there are also adults in Alaska, especially Alaska Native adults, who had an 88-fold increase in serotype 4. And so this is part of our discussion when we were comparing PCV21 and PCV20. Next slide. So these are the current pneumococcal recommendations for adults for vaccine coverage. And so we have a general recommendation that the following groups are currently recommended to receive a dose of pneumococcal conjugate vaccine: adults over 65 who have not received PCV, adults 19 to 64 with certain underlying conditions or risk factors who have not received PCV, and certain adults who have received PCV but who have not received PCV20. Next slide. This is a comparison of risk-based versus age-based recommendations. So if you look at this, the coverage of any person who's received one dose of pneumococcal vaccine, for people who are over 65, almost 2/3 of the adults have realized a vaccine. But for those between 19 and 64 with a risk-based indication, only 22% of those people have received a vaccine. And again, this was part of our consideration. Next slide. So with all this in mind, the work group was considering 3 policies. The first policy was, should PCV21 be recommended for U.S. adults age greater than 19 who currently have a recommendation to receive PCV? And there's a star including the ones who are recommended currently. The next recommendation was, should PCV21 be recommended for U.S. adults age 50 to 64 who do not have a risk-based recommendation? And number 3 was, should PCV21 be recommended for U.S. adults age 19 to 49 who do not have a risk recommendation? So to sort of put this in perspective, option 1 adds PCV21 as an option to the current policy. Options 2 and 3 extend age-based recommendations to younger ages. To give context when you're listening to the rest of the presentations this afternoon, the work group was strongly in favor of option 1, and the work group will be bringing forth a formal recommendation with voting language, and that will be coming up later. The work group was comfortably against option 3, and we will not be recommending that. And the work group had mixed feelings on option 2, and in the end, we could not come to a consensus on whether to lower the age-based recommendation to 50. And so the work group will not be bringing up language in favor of option 2. But it was a strong discussion, and you'll hear much of the discussion when you're going through the presentations this afternoon. Next slide. This is the voting language that's recommended. The ACIP recommends PCV21 as an option for adults age greater than or equal to 19 years who currently have a recommendation to receive a dose of PCV. And next slide. Today's session will include an economic analysis and public health impact of PCV21 in adults from Dr. Stecker. There will also be a comparison of economic analysis of PCV21 use in adults from Dr. Leidner, because we have different models. There will be a summary of the workgroup interpretation and an ETR and policy options of PCV21 use in adults from Dr. Kobayashi, and then also clinical considerations for PCV21 use in adults from Dr. Kobayashi. And I think that's the end, so we'll move on to Dr. Stecker's presentation. Thank you very much.
Hi, I'm Charles Stecker from Tulane. Next slide. I have no conflicts. Next slide. Next slide. So I'm going to present some results of some modeling work that looks at program cost savings, some disease burden changes, and various indirect costs from changing the schedule. We're going to look across three main population buckets. We're going to look at the immunocompromised, the IC, those with chronic medical conditions, the CMC, and then others in the general population. Next slide. We're going to look at 5 basic questions today. So question 1 is going to be divided into 1A and 1B. So in 1A, we're going to compare vaccination at age 65 with PCV20 to vaccination at age 65 with to 21. Question 1B is the same thing, 20 versus 21 in the for the risk-based vaccinations. Question 2 is moving that age-based vaccination at age 65 now with 21 in the comparator to age 50. And then question 3 is moving it down to age 19. And then the rest of the questions on the slide are, what should we do about those people that have already had PCV20? Next slide. So we've got a cohort model. Our main outcome that we're looking at is cost per quality adjusted life year, which is this index that adds up various outpatient and inpatient cases and deaths, et cetera. Next slide. The health outcomes we're going to look at cases of IPD, cases of hospitalized NBP, outpatient NBP, and then deaths due to both of those and qualities, as I said. Next slide. Here's the model, how it's laid out, a very simplified version. Next slide. So our model inputs, they're going to be quite detailed. Many of them are in the appendix, but you can see that there'll be IPD rates separately for these risk categories by age. We're going to have some fatality rates applied to all of those. Vaccine effectiveness is going to be stratified by risk group. We're going to have lower VEs against serotype 3, but we're going to have the same vaccine effectiveness against vaccine type pneumococcus across both 20 and 21. We're going to have some coverage estimates, and then we're going to update our herd inputs from previous iterations of this model where we have a bigger initial effect and it's going to plateau after 6 years. Next slide. So I want to focus in some detail on the IPD serotype distributions. So you can see here the first few lines are what we're inputting into the model separately by age group for the general population. But I want you to focus on that last line, which is the ratio of the serotypes that are only in PCV21 to the serotypes that are only in PCV20, and you can see that it ranges from about 2 to about 9, depending on the age. Next slide. This is that same slide, but now for the CMC group, which is going to have some higher disease rates. Again, the range is about 2 to 9. Next slide. And then for the IC group, again, about, well, a little bit higher, about 3 to 8 or so. Next slide. And then these are those same ranges now for the non-bacterial pneumonia serotype distributions. So the range is 1.6 to 5.7. Next slide. For vaccine waning, we're going to assume no waning in the first 5 years and then waning to 0 over the next 10 years. So everything's done by 15 years after vaccination. Next slide. For vaccine price, we're going to assume very similar prices for the two vaccines, around $300, slightly higher for 21. And then there's going to be some administration costs and patient time on both of those. Next slide. So for sensitivity analysis, we're going to look at a higher PCV21 price. We're going to think about if there's no indirect effects from PCV20. We're going to go through various assumptions about the distribution of serotype 4, and then we're going to fix some quality decrements by age. I'm going to go into this more detail in a second when we look at the results, and then look at some alternative sources for quality decrements. Next slide. So here's our first main results slide. So for all of these slides, they're going to be the same. There's going to be health outcomes at the top there, case count changes, and then costs in the next block. And then our main outcome measure is going to be that second to bottom slide, which is going to be the cost per quality adjusted life year. So question 1A is in column 1. This is replacing PCV20 with PCV21 at age 65. You can see in that second to bottom line, it costs us $4,000 per quality adjusted life year, and the 95% confidence interval ranges from CS, which is cost saving, meaning that we get better health and we save money. So definitely a good idea from the economic perspective, up to $18,000 per quality adjusted life year. The next column is 1B, which is replacing PCV20 with 21 at diagnosis of high-risk condition. So this is going to be cost saving in the base case, and the 95% confidence interval is all going to be cost saving. Question 2, I'm going to go into some more detail on this on subsequent slides, but our base case value right there is CS, but it has an asterisk on the lower bound there, so that's $187,000 per gained per quality adjusted life year cost lost. So we're giving up health and we're getting some money back in that. Question 3, which is, okay, if it's a good idea to vaccinate at age 50, would you then also want to move the age-based recommendations down to age 19? This is going to be dominated. The D stands for dominated, which says that we spend more money and we get worse health. So definitely a bad idea from an economic perspective. So let's go into more detail in each of these. Next slide. So the base case you can see there, just as on the previous slide, $4,000 per quality adjusted life year. This is again for replacing PCV20 with PCV21 at age 65. When we assume a slightly higher PCV21 cost, it doesn't really affect our conclusions too much, though the cost goes up to $28,000 per quality. If we assume that there's no indirect effects from the childhood PCV20 program, so that would make removing PCV20 look relatively worse, the cost increases from $4,000 to $21,000 per quality adjusted life year. In the second to last column, we look at what happens if serotype 4 prevalence was 30% of pneumococcus serotypes, and this is dominated. So it costs us more money, and we get worse health if serotype 4 is so prevalent. And then the last column is the alternative quality values, and it's about the same as the base case. Next slide.
Dr. Stecker, feel free to slow down a little bit. You have an amazing amount of data on these slides, and it's really good data, so it's okay if you take a breath.
Sure. Yeah, so these ones, these 2 slides aren't very interesting or complex, I think, and I'll definitely slow down when we get to some things where it's a little bit more ambiguous. So this is the results for replacing PCV20 with PCV21 at diagnosis of CMC-IC. So you can see the base case in the first column there, it's cost saving. And then for the most part, our sensitivity analyses show that it's still cost saving, means that it saves costs and improves health. That second to last column there is what happens.
Dr. Stecker, I think we lost you now.
Oh, sorry, you can't hear me?
No, but now we can, thank you.
Oh, I'm so sorry. I guess it switched to, well, let's see what happens. Okay, so let me just start this slide over. So this is presenting the results for replacing PCV20 with PCV21 at the diagnosis of chronic medical condition or immunocompromising condition. At the base case, it's cost saving. And through our various sensitivity analyses, for the most part, it's still cost saving. The only exception is that second to last column, the what if scenario where serotype 4 prevalence was at 30% of pneumococcus serotypes. And so that costs us $111,000 per quality adjusted life year. Next slide. So this slide is still that same question of what happens if we replace PCV20 with 21 at the diagnosis of high-risk condition, but now we're varying that serotype 4 distribution from 5% to 35%. And if you look again at that second to bottom row on the slide, it's cost saving for anything that's 25% or below in serotype 4 prevalence. The second to last column is the one you've already seen with serotype 4 at 30%, with that $111,000 per quality adjusted life year cost. And then the last column is 35, and this is true for any serotype distribution of serotype 4 above 35%. It's dominated, again, meaning it's a bad idea. So depending on what you feel about the distribution of serotype 4, this would kind of nudge you toward different economic conclusions. All right, next slide. So now we're moving into the question with a little bit more ambiguity, which is what happens if we change the age-based recommendation from age 65 to age 50? So the comparator here is no longer PCV20, but it's PCV21, just at a different age. If we look at the base case in that first column, it's cost saving in that second to last row. But if we look at the rows above, we can see positive numbers. So that 215 in the upper left says that if we switch from an age-based recommendation at 65 to an age-based recommendation of 50, we'll have 215 additional IPD cases, we'll have 1,050 additional hospitalized pneumonia cases, et cetera. But due to the way that health quality decrements work and some magic of discounting as well, we wind up with positive total qualities. So what we're doing is we're shifting disease burden from the 50 to 64 adults who are now newly getting a vaccine to those adults who are age 65 and plus, which previously would have been recommended to get a vaccine, but are no longer recommended in this modeling scenario. So that's how we get this cost saving number. When we increase the vaccine price in column 2, it's still cost saving. In column 3, when we remove the indirect protection from the childhood program, it moves to a thing where we still save costs, but we now give up some health. So the headline number there in the second to last row is $15,000 that we save per quality adjusted life year we give up. So we're selling our health and we're not getting so much money back for it. In the next column, which is setting serotype 4 at 30%, we see that it is health improving, but it does cost us a lot for that health that we get. So it's $400,000 per quality adjusted life year gained. And then the second to last column is an interesting one. So this is where we fix those quality decrements. So this is trying to get an apples to apples comparison across the different ages. Each age group has different background, health conditions, et cetera. And so depending on if you save a life year at age 50 or you save a life year at age 65, that may have different implications for the economic model. So we're trying to fix those differences. In other words, make the 65-year-olds look just as healthy as the 50-year-olds in every respect other than pneumococcus disease itself. And here we can see that we're selling our qualities, and we're actually getting a pretty decent return on those qualities, which is $1.7 million, but it is health decreasing once we fix these quality decrements. All right, next slide. So that last slide was one way to think about moving this age-based recommendation, which is we were recommending at age 65. Let's no longer do that. Now let's recommend at age 50. So it's going to, as I said before, shift the disease burden from younger adults to older adults. And in the process, we're also going to save this cost of vaccinating the 65-year-olds. But there's another way to think about moving this age-based recommendation. What if instead of moving it from 65 to 50, we thought of adding a vaccination at age 50 in addition to 65? So in the second way to look at this, which I'll show you in a second, we're going to vaccinate at age 50 and 65 in the intervention, and then the comparison will only be a vaccination at age 65. So what this is going to do is it's going to isolate the disease burden reduction from the 50 to 64-year-olds, right? Because we're not changing anything about the 65 plus, and it's really convenient since we're assuming a 15-year vaccination duration. This is going to line up pretty nicely. This also captures this idea that clinicians may be unwilling to not revaccinate at age 65 in that previous one, the one I just showed you. So I know we're all thinking about the new pneumococcus vaccines that are coming down the pipe and saying, well, these are only temporary things. Well, all of these models rely on projecting the benefits from any vaccination today quite a bit forward in the future. So if we're going to give the vaccines credit for disease, prevented, say, 15 years from now, we also have to anticipate clinician behavior 15 years from now. All right. So with all that said, next slide. Here are the results when we change to a recommendation that vaccinates at both at age 50 and 65 as versus a comparison that just recommends PCV21 at 65. That first column is the base case. Looking at the second to bottom row, it costs us $269,000 per quality adjusted life year gained. So we have all positive health outcomes. All those disease case counts in the first 5 lines are negative. We get an increase in qualities, and then we get an increase in costs. And you can see the vaccination costs of adding an age-based recommendation at 50 is $450 million. That's the fourth to bottom line there. Our various sensitivity analyses, they don't change this conclusion very much. Sure, it gets a bit cheaper, $179,000 per quality if we assume that there is no indirect protection from PCV20 types. So remember, in this model, there's no vaccination of adults with PCV20. It's all 21, and those indirect protection from the kids at age from PCV20, that does share some serotypes with 21. So vaccinating at age 50 with 21 is going to protect you more from those joint serotypes shared by 21 and 20 if there's no indirect effects from the kid program. And then the next one is this, next column over is this increased serotype 4 prevalence, and it costs us $440,000 per quality. And the other two are about what the base case is. Okay, next slide. Okay, so now going back to the previous way of thinking about these things, which is what if we, so suppose that we thought that vaccination age 50 was a good idea. Would it also be a good idea to move it down further to age 19? And the disease prevalence is even lower at age 19, and you can see that it's dominated across all of our various sensitivity analyses. So that again means that we're getting worse health, and it's costing us more money to move this from 50 to age 19. Next slide. All right, so these next few slides are about what to do about those people that have already received PCV20. So this slide is a cohort of 66-year-olds who got their PCV20 at age 65. So it's 1 year later. Should we recommend them to get a vaccine? You can see the base case there is $442,000 per quality, and it ranges from there and a bit upwards. Next. What if instead we wait 5 years? So now we're talking about a cohort of 70-year-olds who received their PCV20 at age 65. You can see the numbers are pretty similar, $306,000 per quality in the base case. But it is certainly more economically efficient to wait 5 years than 1 year. Next slide. So this is what to do about the people with who got a risk-based recommendation. So column 1 there is, let's suppose that there's a cohort of 41-year-olds and they got their risk-based PCV20 dose, and then we wait 1 year and we consider giving them a PCV21 dose. So for them, it costs $335,000 per quality. Column 2 there is a cohort of 45-year-olds, so getting slightly into those higher disease rates at older ages. And then column 3 is a cohort of 55-year-olds. And you can see each of those gets slightly more economically efficient as people age. But those first 3 columns are all waiting 1 year between PCV20 and PCV21. And the next 3 columns are waiting 5 years. And if you look at all these, they're all in the range of $200,000 to $300,000 per quality, depending on how long we wait. Next slide. So here are some alternative efficiency measures. I think a lot of economists really prefer the quality adjusted life year metric because it is a way to aggregate deaths and outpatient visits and hospitalization visits, et cetera. But if you look separately just at one of these outcomes and ignore kind of like the overlap benefits that if you vaccinate someone, you prevent hospitalizations, cases, and deaths. But suppose we just look at these separately, focusing in on column 3. So column 3 is giving PCV21 at age 50 and at age 65 versus just giving PCV21 at age 65. So this is that marginal benefits of vaccinated at age 50. Just looking at that bottom row from the first table, we have to vaccinate 155,000 people to prevent 1 death. Skipping to the next table, we can convert that into dollars. So again, looking at column 3, which is PCV20 at 50 and 65, it costs us about $6 million to prevent 1 death through program costs and even netting out disease costs, et cetera. Okay, next slide. So wrapping up, some limitations from this model. We didn't model the IPD sequelae explicitly, though they are incorporated to some extent in our qualities and costs. We didn't have some ranges on some of our data, but we did impose them to make sure that we were getting some sense of uncertainty. A lot of uncertainty around what's going to happen with serotype 4. You've seen how that, depending on exactly what happens there, it could change the conclusions of the economic model. Some uncertainties about the indirect effects from pediatric PCV20 use in some of the questions. We didn't explicitly model some disruptions from changing the pneumococcal schedule. It's quite complicated, and you can imagine that providers that aren't as dialed into this as those on this current call, the more we change these things, there's increases some likelihood that people may slip through the cracks. And then lastly, disease rates are constant within age-specified bins, so we're going to have some slippage there, especially when we're looking at these precise age changes. Next slide. So to wrap up, replacing PCV20 with 21 at age 65 increases qualities with modest increases in costs. Next big bullet is replacing PCV20 with 21 at diagnosis of CMC or IC before age 65 is cost saving. Third big bullet, moving PCV21 vaccination from 65 to 50 increases case counts and deaths, but does result in this decline in qualities. If we think about this moving the age-based recommendation a different way, vaccinating in both age 50 and 65 costs around $300,000 per quality. But vaccination with PCV21 at age 19 instead of 50 is dominated, meaning worse health and less money. For the supplemental doses, this is PCV21 after PCV20. At age 65, It costs around maybe $400,000 per quality. It's slightly lower for the CMC icing group with a range of 200,000 to 300,000. Next slide. And I'd like to thank the rest of the CDC team. Thanks, everyone.
Thank you. I think we're still absorbing, but any questions? I actually have a list, so I do. All right, while y'all are thinking, I have one question that this is my simple idea of money. If it's cost saving at 50, and you're talking about giving a second vaccine at 65 where the disease burden is higher, why does it go from cost saving to $300,000? Because to me, you're saving even more cases. So what am I missing?
Yeah, so it's in what we think of as the comparison. So for the cost saving one, the comparison is vaccination at age 65, and we no longer vaccinate these people. So we save all the money. So if we could go back maybe 10 slides or so and just look in detail at that. Yes, great. Okay, so if you look at vaccination costs, so this is the fourth to bottom line in the cost saving model, it only costs us $75 million. And this is the case where we're shifting from vaccination at age 65 to age 50. Now go forward 2 slides, please. So in this one, the vaccine costs are $450 million. So what's the difference between the $450 million and the $75 million? Mm-hmm. It's $375 million, and that's the cost of vaccinating the age 65 cohort. So it's this comparison, whether we include a vaccination in the age 65 cohort in the intervention or not, right? So you can see the top line of the slide. I'm sorry, this is super complicated. It's hard to put it succinctly, but in this one, we're giving two doses, 50 and 65, and the previous one, we were only giving a dose of 50.
So I guess my question is, if it's cost saving at 50 and it's cost saving at 65, when you add them together, why all of a sudden is it so expensive?
Yeah, it's not cost saving at 65, so that's
regardless of if you just do it at 65 and not 50. I thought 65 was cost saving.
Right, that's, sorry, so that again, it's the comparators, right? So the results that we showed today is comparing 21 to 20 at age 65. And these 2 slides that we're going back on right now are just comparing 21 to 21. So we haven't actually modeled.
Why aren't we just comparing PCV 21 to nothing?
We could do that.
Because the 50 to 64 right now is not recommended.
To the current recommendations.
The 50 to 64 are not recommended to get PCV 20. So it should be PCV 21 compared to placebo.
Yes, so this slide is basically that, right? So I know it's labeled 50 and 65 versus 65, but both the intervention arm and the comparator arm are going to have vaccinations at age 65, so those are going to subtract them. So there's going to be no cost difference or disease difference above age 65 in the intervention or comparison arm on this slide. So this slide is, I think, exactly what you're asking for, which is 21 at age 50 versus nothing. And so obviously when we compare it versus nothing, there's some vaccination costs, right? Because the intervention arm is getting nothing at age 50. And that's where the 450 comes in this fourth to bottom row.
I still don't get it, but I'm gonna move on. Dr. Lair?
So if we go back 2 slides, what struck me when we did this first slide here was we're saving money because we're having the cases happen in the 50s. And so we're having more years of healthy life in the 50s. But when the work group looked at this, we said, but you're going to have more cases, which is the health outcomes. And when we have more cases in the 60s, that felt wrong to me to say, yes, I'm doing fewer cases in the 50s, but I'm having more cases in the 60s and 70s just to save money. And that didn't feel right to me personally and to the work group.
Yeah, and that makes sense. But I think one of the assumptions that the work group has looked at is that after 5 years, it's a decline. And that's left over from the polysaccharide vaccine, which is a T-cell independent vaccine. So yes, there was significant decline in 5 years. And actually, when you gave a second polysaccharide vaccine, there was no boost because it was T-cell independent. So the responses dropped every time you give the vaccine. It was still better than not getting a vaccine, but it never gets to that first level. This is a conjugate vaccine that's T-cell dependent. So the life of this vaccine, the impact that this vaccine should have, should be much, much longer than the polysaccharide vaccine. Additionally, giving that vaccine at 50 may actually give the vaccine before people begin having immune senescence, theoretically, except for the people who are already at high risk. So you actually might provide better protection for them at 70 if you vaccinate them at 50 than if you vaccinate them at 65. And so when this was modeled, I would think about this being something that would last 20 years. So you may be postponing cases to later, but it's not someone that's 60, it's someone that's 70. So that's just something to think about and be interesting for kind of modeling purposes. The other thing that I don't think was included in the model here is if you're 70 and you get pneumonia, you are likely losing your independence and losing your home and going to a nursing home, or you're moving in with a child that's going to take care of you and they have to leave their job. And so that is a huge cost that is not being captured in this cost analysis, which would have huge impact on increasing qualities and decreasing, cost per quality. Okay.
Good points.
Milwaukee.
Thank you, Dr. Talbot. I just wanted to make, one clarification related to duration of protection. So in the model, as Dr. Stecker showed, we're assuming duration of protection of 15 years after initial, for 5 years, there's no decline, and then in the next 10 years, it goes to 0. But then, as Dr. Stecker mentioned, the main limitation we have is we don't have data that gives us what's the duration of protection from PCV vaccination in adults. So that's one limitation that I wanted to share. And then in the model, in the additional dose given, and Dr. Stecker, please correct me if I'm wrong, we're assuming that they benefit from like a full vaccine effectiveness once they get the second dose. Is that correct? Regardless of the age?
Yes, that's correct.
Okay, thank you.
Do we have data, because PCV13 has been around for a long time in children, do we have data on the length of antibody responses in children for PCV13?
So for children, the challenge is the older they become, the risk of disease goes down. And then also in the active bacterial...
Not disease, just antibody levels.
Oh, antibody levels, not to my knowledge. I don't know if the pharmaceutical companies have them available. For adults, we're trying to look at it because it's been a while since PCV13 was recommended for adults.
I think that would be very interesting just because that might give you a better idea of how quickly antibody falls. Okay, Dr. Shaw.
No, thanks. I probably missed it, but I think, so the specific language that we're asked to, is in the question is vaccinating with PCV21 for adults with qualifying medical conditions over age 19. So was that modeled in this analysis? Was that the vaccination at age 19 assumes that they have the chronic medical conditions, or was that the supplemental 1 to 5 years after PCV20 among adults with chronic medical? I wasn't sure where that was.
That's 1B. And 3
Can we go back one slide? That's this one. Sorry, this. I was going quite fast because I wanted to get to age 50, but this is, I think, exactly what you're asking for. So it's vaccination at diagnosis with CMCIC.
He made up 42 compared, it's also 19-year-olds.
And if
Right, so 42 is the midpoint of this 1964 range. So it's just representative. It's going to be pretty consistent throughout that age.
Okay, got it. Thank you.
Oh, sorry, it's actually one more slide back. This is the serotype 4 sensitivity, but this is the one where most things are cost saving.
And I have one other clarifying question, because these are very high cost per quality. When we look at this for COVID, that would be an annual cost per quality. this would not be, correct?
No, so this is a cohort model, so every year we would incur these costs. Every year with every cohort we get this is a steady state model, so every year we get the same amount of quality benefits, and we get the same amount of costs. So this is kind of like every year we incur, if you go, let's see, well, I guess we could look at this particular slide. So every year we incur a net $12 million in vaccination costs by switching from 20 to 21.
But for COVID, it would be the entire, no, it'd be all children. That'd be the difference. Okay, never mind. Thank you. Any other questions? I don't see any hands up in the, okay. Thank you so much. And I guess we will move to the summary of the 3 economic by Dr. Leitner.
Hello, my name is Andrew Leitner. I'm an economist in the ARISE branch at Immunization Services Division. Happy to speak with you today about 3 economic models looking at PCV 21. Next slide. This presentation will summarize the work of 3 modeling teams, the Tulane CDC team, the Merck team, and the Pittsburgh team. Next. I have no conflicts of interest to disclose. Next slide. Here's some terminology for your reference if needed. Many of these you're likely already familiar with. Next slide. Here's my outline for today. The first topic is a quick background on cost-effectiveness analysis. Next. Since you've seen a few economics presentations at this meeting already, I'll try to be brief here. The main results we look at with these presentations is the cost-effectiveness ratio. That's the dollar per outcome term in the blue box on the far right side of the box. This is the ratio of the net change in cost divided by the net change in outcomes between 2 potential strategies. One strategy is called the intervention, the other is called the comparator. In this presentation, a few of the strategies we'll be looking at include PCV 21 versus PCV 20 for currently recommended adults, and PCV 21 at younger ages versus PCV 21 at older ages. Next slide. The cost effectiveness ratio is calculated using an economic model which accounts for disease burden and vaccine characteristics. In this way, you can think of the cost effectiveness ratio as a summary measure of value, capturing or summarizing the many different relevant economic and epidemiological factors that contribute to the value of a vaccination. Click to add the animation. Next slide. And now next slide. Sorry, I left that in. This figure is a way to consider cost-effectiveness results graphically. The y-axis is the change in costs, or the numerator from the equation in the blue box. The x-axis is the change in outcomes, which is the denominator in the blue box. A lot of new health technologies improve health and increase costs, so the cost-effectiveness ratio for a lot of new technologies in healthcare would be found in the first quadrant. That's the top right part of the graph. In this quadrant, you get better health, but you got to pay for it. Cost-effectiveness ratios can also be cost-saving, which is found in quadrant 4 on the bottom right. Here, costs are decreasing, health outcomes are getting better. A cost-effectiveness ratio that is cost-saving is unambiguously good economic value because you're saving money while also improving health. On the opposite end of the economic value spectrum, some cost-effectiveness ratios are characterized as being dominated. Dominated values are represented on the graph in quadrant 2, top left, where costs are increasing and health outcomes are getting worse. If costs are increasing and health is getting worse, the cost-effectiveness ratio is identified as dominated. But again, most cost-effectiveness ratios for new healthcare technologies are found in quadrant 1, where there's higher costs and better health. Next slide. The next subsections are going to look at a few of the assumptions in the models, and then we'll move on to the main results. Next slide. On this slide, I want to focus on 2 assumptions. Vaccine cost in the middle row of the table. PCV 21 cost per dose was higher than PCV 20 cost per dose. The next assumption I'd like to point out is the coverage of circulating serotypes by vaccines. That's the last row of the table. This coverage is higher for PCV 21 than for PCV 20. Later in this presentation, when 21 is being compared directly to 20, the 21 strategies are going to look fairly favorable because PCV 21 can prevent 3 to 9 times more circulating disease with a somewhat modest increase in cost per dose, where cost per dose goes up by about 10 to 30%. Next. On this slide, I'd like to point out 4 groups of assumptions. The indirect effects in the top 2 rows. The Tulane CDC model included indirect effects in the base case. The other models included them in sensitivity analyses. In scenarios where indirect effects were included, the indirect effects in the Tulane CDC model were of a greater magnitude than the other 2 models. Disability states in the 3rd and 4th row. The Tulane CDC model did not explicitly model disability sequelae. The Merck model had disability sequelae following IPD, but not inpatient pneumonia. The Pittsburgh model included disability sequelae following both IPD and inpatient pneumonia. So with respect to disability states, the Tulane CDC model is on the more conservative side. The Pittsburgh model was less conservative. The Merck model was somewhere in between. Inpatient pneumonia case fatality rates in the next to last row. Case fatality rates following inpatient pneumonia from the Pittsburgh model were on average higher than the Tulane CDC and Merck models. Productivity loss in the last row. In the models, when a person dies from pneumococcal disease, the lost economic productivity for the remainder of their expected lifetime is counted as a cost to society. So if a vaccine averts a death, then those productivity losses will get averted, and the averted productivity losses will then be counted as savings or gains to society that's attributable to the vaccination. All 3 models include productivity losses, but the Tulane CDC model adjusts productivity losses by a labor participation rate or employment status. The other 2 models did not make this kind of adjustment, so the Pittsburgh and Merck models have a higher productivity loss per death than the Tulane CDC model. Thinking about the Pittsburgh model, the combination of higher productivity losses per death, a higher death rate among pneumonia patients, and more disease burden assumptions around long-term disability states, all these contribute to why the Pittsburgh model will have more favorable estimates than the other models, which we'll see in the next few slides. Next. These are the main results for the first policy question, comparing the use of PCV 21 to PCV 20 among adults currently recommended to receive PCV at age 65 or due to a risk condition. Across the policy questions we looked at, these cost-effectiveness ratios were the most favorable among the different policy questions considered. Estimates ranged from being cost-saving to costing about $58,000 per QALY gained. Reasons for these relatively favorable estimates are primarily due to how PCV 21 confers broader protection against circulating disease types, was only modestly more expensive than PCV 20, and there is a higher disease burden in general among adults who are currently recommended for PCV. Next slide. Okay, policy question 2. Looking at lowering the age-based recommendation from 65 to 50, I want to say a couple things about the strategies in these comparisons before I get into discussing the results. First, remember in Dr. Stecker's presentation, he showed you 2 versions of this policy question, which were discussed. The second version of that policy question provided by Dr. Stecker is the focus of this slide. In the intervention column, we have vaccination at age 50 and age 65. In the comparator, we have risk-based vaccination between ages 50 and 64, age-based vaccination at 65. I focus on this version of the policy question for the following reasons. This version isolates the impact of vaccination between the ages of 50 and 64 in a way that was more consistent with workgroup discussions about the intent and anticipated outcomes of this policy option. In this version, the main difference between the 2 strategies is that in between the ages of 50 and 64, vaccination coverage will increase from a low level rooted around risk-based recommendation only to about 40%, which is the vaccine coverage assumption for the age-based use at age 50 in the intervention strategy. After discussions with the work group, this comparison seemed to better capture the intent of what this policy option aims to achieve, which in simple terms is broader coverage of PCV within the age band of 50 to 64. The last thing on this I want to mention before we get to the results, in the intervention there's A person could get a vaccine at age 50 and at age 65, but at least for now, for policy question 2, revaccination or a second dose of PCV is not currently under consideration. Okay, now let's get to the results. The Tulane CDC model estimates that lowering the age-based recommendation costs $270,000 per quality for PCV21, $630,000 per quality for PCV20. Note the Tulane CDC model for PCV21, there was a fairly broad range of value and sensitivity analyses. The Merck model estimates a similar value as the Tulane CDC model for PCV21. The Pittsburgh model has estimates that are quite a bit lower than the Tulane CDC model. We'll look at these again in a couple of slides when we compare these two models. Finally, note across both the Tulane CDC model and the Pittsburgh model, the cost effectiveness ratios were higher for PCV20 than for PCV21. Next slide. Looking at policy question 3, with the lowest age range across the set of policy questions, the cost effectiveness ratios were higher than the ratios for the other two previously looked at policy questions. This was generally due to the lower disease burden experienced by younger populations. Unlike policy question 2, the results here were reasonably consistent across the available models, both having estimated higher cost effectiveness ratios or dominated values in the case of the Tulane CDC model. Next. Not a policy question, but an additional set of results looking at supplemental dose of using PCV21 after a person has already received PCV20. Estimates here ranged from $200,000 to about $500,000 per quality gained. Previously vaccinated individuals are going to have a lower disease burden, so cost effectiveness ratios will be higher here than among vaccine-naive populations of the same age and risk group. The ranges were driven by the time since the previous PCV20 dose and the different age and risk groups of the person who received the supplemental dose. Next slide. Now we're going to move on to, we're going to sort of jump back to policy question 2 and then compare some results between the Tulane CDC model and the Pittsburgh model. Next slide. The Pittsburgh team very helpfully granted access to an online version of their model where the econ review team ran some scenarios to figure out why the models were different. The findings of that investigation are presented in this figure. The top row of the figure starts with the Pittsburgh model base case, and we sequentially update assumptions in the Pittsburgh model as we move down the figure. Each row for the Pittsburgh model has 2 data points. The point on the left is the societal perspective. The point on the right, which has the higher ICER, is the healthcare sector perspective. The second row from top adds indirect effects into the Pittsburgh base case. The next row down removes the long-term disability state. The last row for the Pittsburgh model lowers the inpatient pneumonia case fatality rate to a level comparable to the rate used in the Tulane CDC model. Notice in the last row for the Pittsburgh model, the healthcare sector estimate on the right and the societal estimate on the left from the Pittsburgh model encompasses the base case value from the Tulane CDC model. The remaining differences between the societal perspective of the Pittsburgh model on the left of the bottom row for Pittsburgh and the Tulane CDC base case model are likely because the Pittsburgh model has a lower magnitude of indirect effects and has greater productivity loss assumptions following death and diseases. Both of those would contribute to a lower ICER in the Pittsburgh model societal perspective. Next. Just to recap the comparison between the Tulane CDC model and the Pittsburgh model, this is a similar slide to the main results from a few slides ago. Several assumptions which we covered on the previous slide appear to contribute to the lower estimates in the Pittsburgh model. Next slide. I want to acknowledge there are several limitations that apply to these models. These limitations include uncertainties around several assumptions, which in the case of policy question 2, seem to contribute to a relatively wide range of estimates across models and within models. I'll also note the vaccine price uncertainty was a factor during the development of these models, but the list price of PCV21 has been released publicly about a week ago, and it is the same price that was used in the base case of the Merck model. Next. So just to summarize the model findings, policy question 1 for currently recommended adults had the lowest ICERs with several estimates of cost savings. Policy 2 was more expensive than policy 1, with policy question 2, PCV 20 was more expensive than PCV 21. There was a fairly wide range in estimates of value for this policy question, largely due to uncertainties around the assumptions and inputs. Policy question 3 for the youngest adults had highest estimated ICERs. As modeled, most strategies improved health, with one exception being the dominated result in the Tulane CDC model at age 19. Finally, I just want to acknowledge once again, there's a lot of uncertainty in the assumptions. This contributes to broad ranges in estimates that particularly for age 50 and 64. Next slide. With that, I'll thank everyone who contributed to this presentation, the 3 modeling teams, and the economics review team. Happy to take any questions.
Questions? Dr. Shaw, you have your name tag up. You're fine. Just making sure I don't miss you. Perfectly clear. Oh, Dr. Zimmerman.
Thank you. One of the things I did want to mention in the Pittsburgh model, and I disclose I am part of that, it is NIH funded, and we did separate non-Black from Black populations in our analyses. And those analyses are published and open for anyone to pull up on their phone or tablet. So I did want to point out there are differences, and the cost effectiveness, the ICER per quality is more favorable in the Black population because of the disparities that the Black population has exhibited historically and with pneumococcal disease. Thank you.
Thank you. Any other questions, comments? All righty, moving on. Our next talk is the ETR, the summary work group. So, Dr. Mwaka Kobayashi, are you ready? Okay.
Good afternoon. On behalf of the pneumococcal vaccines work group, I will present the work group interpretation of ETRM policy option on PCV21 use in adults. As a reminder, here are the 3 policy questions that are being considered by the work group. Should PCV21 be recommended for U.S. adults 19 years and older who currently have a recommendation to receive a PCV? I will refer to this group as Group 1 in my presentation. The comparison is current vaccine recommendations. For PCV-naive adults, either 1 dose of PCV20 or 1 dose of PCV15 followed by PPSV23. And for PCV-experienced adults who have not completed the recommended series, either 1 dose of PCV20 or 1 or more doses of PPSV23. Should PCV21 be recommended for U.S. adults 50 to 64 years who currently do not have a risk-based pneumococcal vaccine recommendation? I will refer to this group as Group 2. Should PCV21 be recommended for U.S. adults 19 to 49 years who currently do not have a risk-based pneumococcal vaccine indication? I will refer to this group as Group 3. For both of these groups, the comparison is no vaccine. The ETR framework consists of the 7 domains shown here. At the February ACIP meeting, we presented the workgroup interpretations on ETR domains public health problem, benefits and harms, and equity. In general, the workgroup believed that PCV21 use is more likely to benefit Group 1 that currently has a pneumococcal vaccine recommendation compared with group 3 that has the lowest risk of disease among the 3 groups. Today, we will present the workgroup interpretations of ETR domains values, acceptability, resource use, and feasibility. First is values and preferences. Does the population feel that the desirable effects are large relative to undesirable effects? And is there important uncertainty about or variability in how much people value the main outcomes? Here, the outcomes are vaccine type invasive pneumococcal disease, or IPD, vaccine type non-bacteremic pneumococcal pneumonia, vaccine type pneumococcal deaths, and serious adverse events from vaccination. Since data supporting discussions on these questions were limited, we will also review some data we considered for ETR domains presented in February. This figure shows the proportion of IPD cases in different age groups: under 5, 19 to 49 years, 50 to 64 years, and 65 years and older by different vaccine serotype groups. In adults, the proportion due to serotypes contained in PCV20 but not in PCV21, shown in blue, is relatively lower in older adults compared with younger adults. As a result, a relatively lower proportion of IPD cases were due to serotypes contained in PCV20 in older adults compared with younger adults, ranging from 54 to 62% shown in the red boxes. On the other hand, the proportion due to serotypes contained in PCV21 ranged from 77 to 85%, with a relatively higher proportion in older adults. This is a slide that was presented at the February ACIP meeting. We presented that immunogenicity data from phase 2 and 3 clinical trials showed that PCV21 met non-inferiority criteria for the serotypes shared with the comparator vaccines and met superiority criteria for most of the serotypes unique to PCV21. Safety data from the clinical trials showed that the percentage of serious adverse events was low and comparable to that of the comparator vaccines. Findings from the 2 online healthcare consumer surveys showed that a recommendation by a healthcare provider was one of the top factors influencing the likelihood of receiving a pneumococcal vaccine. In a survey that targeted adults 19 to 64 years with indications for risk-based pneumococcal vaccination, the top reasons for not getting a pneumococcal vaccine were not knowing a pneumococcal vaccine was needed and never receiving a recommendation by a healthcare provider. Does the population feel that the desirable effects are large relative to undesirable effects? For groups 1 and 2, the workgroup interpretation was probably yes, although for group 2, a similar number of workgroup members selected don't know. For group 3, none of the options reached a majority and varied across the options. Is there important uncertainty about or variability in how much people value the main outcomes? For group 1, the majority of workgroup members selected either probably important or not important, uncertainty, or variability. For group 2, the workgroup interpretation was probably important, uncertainty, or variability. And for group 3, the majority of workgroup members selected important or probably important, uncertainty, or variability. Next is ETR domain acceptability. Is the intervention acceptable to key stakeholders? Online surveys among healthcare providers funded by Merck showed that surveyed providers expressed more challenges in identifying patients eligible for pneumococcal vaccination based on risk factors rather than age. The top reason among physicians, nurse practitioners, and physician assistants were the need to focus on other priorities during the visit. For pharmacists, the top reason was unknown underlying health condition of the patient. The majority of providers reported they were either slightly likely, or extremely likely to support ACIP lowering the age-based recommendation for pneumococcal vaccines from adults 65 years and older to 50 years and older. Is the intervention acceptable to key stakeholders? For group 1, the work group interpretation was yes. For group 2, probably yes. For group 3, either no or probably no were selected by the majority of the work group members, but a few selected probably yes. Next is resource use. Is PCV 21 use a reasonable and efficient allocation of resources? As we saw in Dr. Leidner's presentation just now, PCV 21 use in vaccine-naive adults who are currently recommended to receive a PCV showed that the intervention was economically favorable. Age-based PCV 21 vaccination at 50 and 65 years compared with risk-based from 50 through 64 years and age-based at 65 years range from $3,000 to $270,000 per quality gained. The same comparison for PCV 20 also demonstrated improved health outcomes, but a higher cost per quality gained. And adding an age-based vaccination at 19 years to the above was the least economically favorable option that was assessed. Is PCV 21 use a reasonable and efficient allocation of resources? For group 1, the work group interpretation was yes. For group 2, probably yes and yes combined reached a majority, but a few members also selected probably no. For group 3, the majority selected no. Lastly, feasibility. Is PCV 21 use feasible to implement? The work group interpretation generally mirrored the interpretation for resource use. Some expressed that the interpretation of group 2 may depend on whether there are different age-based recommendations for PCV 21 and currently recommended PCVs. This is a summary of the work group's interpretations of all ETR domains. The domains we reviewed today are shown in the red box. Now I will present a summary of workgroup interpretation for each policy question. Should PCV 21 be recommended for US adults aged 19 years and older who currently have a recommendation to receive a PCV? The majority of workgroup members believe that the desirable consequences clearly outweigh undesirable consequences in most settings. Should PCV 21 be recommended for US adults aged 50 to 64 years who currently do not have a risk-based pneumococcal vaccine indication? Of the available options, desirable consequences probably outweigh undesirable consequences in most settings was selected most frequently by workgroup members, but did not reach the majority. Some selected desirable consequences clearly outweigh undesirable consequences, and the balance between desirable and undesirable consequences is closely balanced or uncertain, but few believe that undesirable consequences outweighed desirable consequences. Should PCV 21 be recommended for US adults aged 19 to 49 years who currently do not have a risk-based pneumococcal vaccine indication? The majority of workgroup members selected undesirable consequences probably outweigh desirable consequences in most settings. Since workgroup interpretations were variable for group 2, we reviewed additional data to consider the potential implications of expanding the PCV recommendation for all adults 50 through 64 years from the perspective of health equity. Racial disparities in IPD incidence have existed, with IPD rates in Black adults shown in pink and for white adults in light blue in the figures. After PCV 13 use in children in 2010, disparities in IPD incidence in adults caused by serotypes contained in PCV 13 decreased, shown in the middle figure. Most of the remaining disparities due to non-PCV 13 type disease, shown in the right figure. We'll take a closer look at the racial disparities in IPD rates that existed in the 50 to 64-year-old age group. This figure looks at the proportion of vaccine serotypes that caused IPD in white and Black adults 50 to 64 years during 2018 through 2022. In both Black and white adults, serotypes contained in PCV21 cause more than 80% of IPD. On the other hand, serotypes contained in PCV20 cause nearly 60% of IPD cases in white adults, compared with 50% in Black adults. So there was a larger difference in the proportion of IPD cases preventable by PCV20 between the two racial groups. This figure shows IPD incidence due to any pneumococcal serotype in 2018 to 19 in Black adults to the left and non-Black adults to the right by 5-year age increments from age 40 years. The red horizontal dashed line shows the IPD rate for adults aged 65 years and older, averaged across all race and ethnicity groups. In Black adults, IPD rates peak at a younger age at 50 to 59 years, compared with non-Black adults who have a steady increase in IPD rates with increasing age. And the IPD rates for Black adults 50 years and older exceeded the IPD rate for all adults 65 years and older. This is likely due to multiple factors, but differences in prevalence of conditions that increase the risk of pneumococcal disease may be one contributing factor. These figures show the proportion of Black versus non-Black adults with and without conditions that increase the risk of pneumococcal disease in 5-year age increments using the 2014 NHIS data. The figure to the left shows that the proportion of adults without risk-based indications for pneumococcal vaccination is lower in Black adults compared with non-Black adults, and the difference is the largest at around age 60 years. This is primarily driven by the higher proportion of adults with non-immunocompromising chronic medical conditions in Black adults shown in the figure to the right. However, adults 19 to 64 years with a risk-based indication of pneumococcal vaccination have had lower vaccine coverage compared with adults 65 years and older with an age-based vaccine recommendation. And disparity in vaccine coverage by race and ethnicity exists. Within adults 65 years and older, the proportion with receipt of any pneumococcal vaccine was significantly lower in Black and Hispanic adults compared with white adults. Another point that the work group considered was increase in IPD cases due to serotype 4, a serotype contained in currently recommended vaccines, but not in PCV21. Serotype 4 IPD cases had nearly been eliminated after PCV7 use in children, but serotype 4 IPD clusters have been reported in certain populations, such as people experiencing homelessness. In certain areas in the US and abroad, increase in serotype 4 IPD cases has been observed in routine surveillance in recent years, especially post-2020. In the United States, the increase has been reported mainly in Western United States, such as Alaska, Navajo Nation, and Colorado, New Mexico, and Oregon sites of CDC's active bacterial core surveillance. Affected populations appear to primarily be adults under 65 years with risk-based pneumococcal vaccine indications. Here is the summary of workgroup discussions on lowering the age-based recommendation for PCV21 to 50 years and older from the current 65 years and older. The pros of lowering the age-based recommendation expressed by the workgroup included the potential to improve vaccine coverage in adults aged 50 to 64 years who currently have risk-based vaccine indications, the potential to prevent more disease from broad pneumococcal serotype coverage with PCV21, and the potential to reduce racial disparities in pneumococcal disease burden given the differences in when pneumococcal disease rates peak and prevalence of conditions that increase the risk of pneumococcal disease. On the other hand, the cons expressed by the workgroup included lack of data on duration of protection from vaccination, potential unintended consequences of worsening health equity by improving access to those who already have good access to health care, higher costs per quality gained reported in some economic models, uncertainties with disease trends due to serotype 4, a serotype contained in existing vaccines but not PCV21, and implementation challenges of having different recommendations by product. Specifically, if we lower the age-based recommendation for PCV21 only, there'll be one PCV option for adults 50 through 64 years without a risk condition, but 3 options, PCV 15, PCV 20, and PCV 21 for adults with a risk condition. In summary, the workgroup agreed that available evidence supports PCV 21 use for adults currently recommended to receive a PCV, but the workgroup could not reach a consensus on whether the age-based recommendation for PCV 21 should be lowered from the current 65 and older to 50 years and older. The workgroup did not support lowering the age-based recommendation for PCV 21 to age 19 years, and the majority of workgroup members believed there was insufficient evidence to support lowering the age-based recommendation for currently recommended vaccines. The workgroup would appreciate any feedback from the committee on the discussions of the age-based recommendation. And before I proceed with the proposed voting language and clinical guidance, I'm happy to stop here for any questions.
Questions? Yes, Dr. Lair.
So as chair of the work group, I want to thank you for presenting this so well. I want to sort of summarize some of the thinking that I took away from the work group. There was the sense that, as I said, the work group agreed with proposal 1 very clearly. We clearly did not agree with proposal 3. So most of this conversation, I suspect, is going to be on proposal 2, lowering the age group to 50. And there is a lot of discussion within the work group about this, so it was not an easy process. There was a sense that there would be significant improvement in equity if we were to lower the age group. That would come at a significant cost, and you saw the numbers. We recognize that the model has a limitation that we don't know if the protection lasts for 15 years or if it lasts for longer. If it lasts for 30 years, that would change the model completely, and this might be a much less expensive vaccine. But this is the best model that we have right now. We were also torn by the confusion that would be in place if we lowered the recommendation for PCV 21 to 50, but not for PCV 20 to 50, because then, as Dr. Miyako said, we would have 3 recommendations for people in their 50s. And part of the complication that people have with the pneumococcal recommendations is they are just confusing. And even though it's beneficial, and we might have a reason to do that, that would be really confusing to say, if you don't have a risk factor, get 21, but if you do have a risk factor, you can get 21 or 20 or 15 plus 23, and it's just messy. So, as she said, we do appreciate your feedback and thoughts on this because we could not come to a consensus. Thank you.
Well, I keep calling you by your first name. Dr. Kobayashi. In Dr. Lair's opening on slide 12, he indicated the number of people less than 65 who have a comorbid condition or a high-risk condition who actually receive vaccination. Do we have those numbers for 50 to 64?
So I have looked, and the only data I was able to look at was some preliminary data for PCV 20, but then the issue with that is that overall PCV 20 uptake has been low consistently because it's a relatively new vaccine, and then people, there aren't as many vaccine naive adults right now, so I think that's another reason why the vaccine coverage in adults has been low. So the short answer will be nothing that would be helpful to present today.
Would you guess it would be closer to those 19 to 49, what was presented, or closer to those over 65?
So as part of this, I tried to look at other vaccine coverage data. So my guess will be it'll be somewhere between, it'll probably be higher in the 50 to 64-year-old age group compared to 19 to 49, but probably much lower than the 65 and older.
Still not what it should be. Okay.
That's my assumption.
Okay, understood. And then if we lowered the age to 50, would we lower it for 20 and 21?
So the work group talked about that, and then the work group was not supportive of lowering the age-based recommendation for the currently recommended vaccines, although I will acknowledge that there were some people who felt that if we're lowering it, it might be more easy in terms of implementation, and then also for the issues of serotype 4, maybe we need to be very clear in terms of who might be benefiting more from PCV20 versus PCV21.
And one last piece of information that might be useful. Can you tell the ACIP the percentage of people between 50 and 64 who already fall into that risk-based category?
Yes, thank you for that question. So this depends on the source of data you look at, but the range I've seen, so the question was the proportion of adults 50 to 64 years with indication for risk-based recommendations. It ranges from 30 to 50%.
So a significant portion who's not getting their vaccine. Okay, Dr. Jameson?
I share your concern about how confusing these recommendations are. So I would not be in favor of making them more confusing by accepting number 2, but would be supportive of number 1, because I think it's very confusing already. There's a lot of information that has to be delivered in a healthcare visit by a primary care provider. And I just am concerned that it's going to be almost uninterpretable.
Dr. Daly?
Yeah, I appreciate the conversation very much, so thank you all for that. I feel like I'm in a maze, and I'm being asked to look around not one corner, but 2 in the maze. And so, what I mean by that is that we always make these decisions in the context of some uncertainty, but I feel like there's even more uncertainty now. And interestingly, sometimes the economic analysis, I focus on the economic piece, but this actually just helped me understand the fundamental problem better, being several-fold, but particularly if vaccinating at age 50 has protection past 15 years or not is very fundamental to all of the decisions. And you gave a great example in the economic context that I'm also just thinking about in the disease prevention context apart from that. So, let's talk about complexity so that's point 1. Point 2 is around complexity, and let's talk about that for just a sec. I think, sort of clarity of policy leads to clarity of implementation, operationalization, that kind of thing. And when I just heard that there was a potential to have a different recommendation if you had high-risk conditions versus not, that was a clear indication to me that we would lose that argument at the stage of implementation in frontline primary care providers. It would just be too complicated to implement. And so let me just make a quick third point, which is that I've been trying to argue that our vaccination policy recommendations generally tend to they settle over time because we gather more knowledge. Is that true here too? I don't know, because the landscape keeps changing because of the new vaccines, but I would hope that this too would settle once we sort of know what vaccines we have and what the protection is, and a little bit more about what the duration is. Then I think we can make better decisions. But I don't want to have the perfect be the enemy of the good, because the last point was I was struck by the burden in 50 to 64-year-old Black individuals is comparable to greater than age 65 when we're all endorsing universal recommendation for over age 65. So I think we're missing something too by not deciding. So I'm in support of policy 1. I'm in support of not extending down to age 19. And I appreciate that the work group says we really shouldn't decide about that group 2 today. But we need to decide at some point, and I hope we get there pretty soon, in part because of the racial and ethnic disparities in invasive disease. Over.
And this is the second time we're discussing moving it down to 50. So, okay, Dr. Brooks.
Yeah, first of all, thank you, Dr. Lair. As the work group leader, this is a lot, and it's complex. I am in favor of option number 2. I think that you mentioned, first of all, it was 37,000 to 630. So I'm going to look toward the lower end since I'm for the option. I think also that and thank you, Dr. Kobayashi, for presenting a breakout, separate, again, presentation on the equity aspect. It is striking to me that there is this disparity, which we actually already knew, among the Black patients from 50 to 64. Their health profile is equivalent to the 65-year-old. So I believe that it would be very helpful to that community to have a universal recommendation. Now, a lot of them were going to have a recommendation now because they're at high risk, but it's not happening because we see the rates are very low. So I would be in favor of extending it. And then what Dr. Daly said, these things settle. So over the ensuing years, I believe it will settle, that there won't be 3 recommendations for certain age groups. And in another year or two, it's likely that most things are going to be PC21, except now they're in line with other PCV vaccines. So this has definitely been a moving target. But I agree with don't let the perfect be the enemy of the good. So I'll stop there.
I'd like to point out the children have gone from PCV 7 to PCV 10 to PCV 13. And it's been no big deal because we've gotten rid of the prior vaccine each time. For adults, we're hanging on a polysaccharide for our dear life. And I promised Dr. Wharton I would not make a scene about polysaccharides, so I'm dialing it down. I think one of the things we need to think about for adults is we need to be as simplistic as we are for the children. And not wait for perfection or have 1,000 options. The childhood immunization schedule has been much more successful, but once again, it's age-based and it's one vaccine. And so that is something to think about. Dr. Dr. Brooks, did you want to comment on that? Yeah, okay, Dr. Cotton.
Thanks. I think, so there's a lot of information here and there are a lot of different ways to think about it. I am concerned about potential collateral damage on other vaccines, and already I've heard from so many providers that they are overwhelmed by the number of choices and changes. Some people are saying that they don't want to get RSV vaccine or other vaccines because they feel like they've just had enough vaccines and they're a pincushion. I am troubled by making an additional recommendation at age 50, which some people definitely could utilize, but certainly not necessarily everybody would benefit from. So it just seems like more and more and more vaccines are piling up. I find it so troubling that the people who are 19 to 64 who have not yet been vaccinated, and that's a huge population, and they are the highest, other than above 65, but they are the highest risk group. I know we can't really make a recommendation where we would focus on that high-risk group, but it would be great to think about efforts to really target those at highest risk. As someone over the age of 50, I have to say I'm not so thrilled myself to go out and get a vaccine of unclear need, and if I'm quite pro-vaccine, so I do worry it'll have a collateral impact in potentially a negative way on other vaccine issues, and I would rather focus the efforts on perhaps vaccines for which there might be more benefit. Thank you. I haven't fully decided.
Yes, I'm on this work group, and I have not left one work group call without a big headache as we try to weigh this and that and don't know enough about each. I have 3 small comments. The first is about equity, and I really would welcome all my esteemed colleagues' thoughts about this. I think it's likely that there would be decreased equity if we did an age-based recommendation for youngers, because these people who have disparate levels of vaccination right now who are getting pneumococcal disease are already not getting pneumococcal vaccine. And so that if we lowered the age, then I think more of the worried well who are not at really increased or much increased risk at that age would in fact get the vaccine, and it wouldn't have increased, it would have actually decreased because there would be more of a rift between disease prevented. The second is, if we lowered for 21 and could not do it for 20 because the burden of disease that is 21, not 20, it allows you to want to recommend this vaccine, doesn't have it for 20, so it doesn't cut it. And if in fact we did 21 without 20, that would be in fact a preferential as far as what would happen to the market probably, because people don't want to carry too many vaccines for adults. And I think that would be bad because we know we sometimes have shortages, but also we don't have clinical effectiveness on 20 or 21, and we don't know what's going on with 4. So if we lost 20 because we like 21 in everybody and in people younger, that might be very bad if that went away.
So the children's schedule should have 13 and 15 in it, and the doctors get to pick?
No.
But that's what I'm saying you're asking to do for adults. You're saying adults should have options, but children should not.
Adults should have options for, well, you have different brands for children. And I don't think that these are different vaccines for adults, 21 and 20. And we're sorry, but we don't really know. We know that from what's happened in the last 5 years, 21 is superior. We don't know what is going to happen in the next 5 years with 4. That might go away, might stay the same. So we're in between a rock and a hard place, I think, but it is part of the reason not to lower the age for 21, because then you would really have 2 vaccines, 2 different age recommendations.
I'm going to respectfully disagree with you, because we would not do this to a pediatric practice, but we are doing it to an adult. Dr. Shaw.
Thanks. I really, I appreciate that this is kind of a game changer of a vaccine for pneumococcus. I do want to take a cue from Dr. Daly about asking this just got FDA approved, I think, a couple weeks ago. So in terms of supply, when do we think this is going to roll out, or if we make this recommendation, when are they going to show up? I don't know if that's a relevant question, but I'm just kind of curious.
Mark has asked to make a comment. I also think we had such a horrible experience with shingles, but everyone over 60 was recommended. This would be people who have not yet had a pneumococcal vaccine, so it's not the same demand, but still a very important.
Yeah, I mean, I'll tell you, at our place, I think there are still clinics that are starting to just realize they should do PCV20, and so now, you know, we're going to go PCV21. It's going to be kind of their head is going to be spinning a little bit.
Yeah, we're going to spin them. Yeah. Dr. Cenayas.
Thank you. I really appreciate this discussion, and I just wanted to go on the record that I favor a universal 50 to 64 age-based recommendations for all the reasons that people have already mentioned in terms of the disparities that exist, and that 30 to 50% of that population already has underlying medical condition. And as a practicing provider, it's really hard to implement risk-based recommendations, and it's much easier to advise on the age-based, and I think that would help reduce disparities. So.
Dr. Lair?
So I'd like to respond to some of the comments, and my colleagues, thank you for all of them. With regard to the supply will come, but remember, and this is my soapbox, I get to do it, it takes a year approximately for the insurance companies to be required to cover the vaccine. And so it is common in my practice that I cannot give the vaccine if I have it because the insurance company has not covered it. And so that is my bugaboo on online issue. With regard to Prevnar 20, because it is still around, for Dr. Long's comment, in children, I'm less concerned about losing Prevnar 20 in the supply because it'll still be around until we move to Prevnar X in the future. With regard to equity, I respectfully disagree. I do think that if we lowered it to 50, there would be more equity because we'd have more people simply say, you're 51 years old, you need this vaccine, it would happen. So I suspect that the equity would improve. I have my own concerns about cost and everything. To summarize, I've spoken to Dr. Wharton, and we have a couple of options here. And what I'm going to suggest is that
Dr. Lair, can we hold those options? We have several people who want to ask questions, and that may help with the discussion for options. Is that okay?
Well, can I at least lay them out?
Yeah, you can lay them out.
So one option is to simply just vote on the proposal as it is here, and that would be fairly clean. And then we could actually have, if the members feel like they would like to make another amendment, we could have another amendment to lower the age group as a separate motion that we would vote on later. And the work group actually might find that instructive, that if we had that, even if it was voted down, we would have a sense of the committee as to how the committee feels about this option. So I put that out there, that just because the work group is not bringing forth a motion does not mean that individual members of the ACIP could not bring forth a motion if they wanted to. So just putting that out there for you. Thank you.
Thank you. Dr. Clark.
Thanks, Dr. Talbot. Would this be a good opportunity for me to give the IHS perspective given the discussions about equity?
It would be phenomenal. Thank you.
All right. I appreciate this opportunity to comment as part of this deliberation of recommendations pertaining to PCV 21. To start out, I want to be clear that the Indian Health Service supports a recommendation to implement PCV 21. But as I'm going to explain, it's also particularly important to retain the other tools in our toolbox to mitigate the risk of invasive pneumococcal disease in tribal communities. We appreciate the work of our partners at the Johns Hopkins Center for Indigenous Health, the CDC Arctic Investigations Program, and our tribal partners for supporting important epidemiologic research in Indian country, including active laboratory and population-based bacterial surveillance. In particular, I'd like to express appreciation for Dr. Laura Hammett and Dr. Mark Fisher and their teams for sharing important information, both with the IHS and the ACIP pneumococcal work group, about a recent surge in invasive pneumococcal disease resulting from serotype 4 infections, both in Alaska and in the Navajo Nation. Pneumococcal vaccines obviously have been a powerful tool to prevent disease and reduce health disparities in American Indian and Alaska Native populations. However, the burden of invasive pneumococcal disease remains 2 to 4 times higher among American Indian and Alaska Native adults compared to the general U.S. population. And this is primarily because of serotypes not covered by the currently available vaccines. However, in the past few years, serotype 4, which has been discussed as a component of PCV20 but not PCV21, has emerged as a substantial contributor to invasive pneumococcal disease in adults in Alaska and in the Navajo Nation, which are the 2 places in the U.S. with robust IPD surveillance in American Indian and Alaska Native populations. Most cases occurred in people who had not received pneumococcal conjugate vaccine, but who had a risk factor indication to be vaccinated. And this is especially true among adults ages 18 to 49 years. Recognizing this disparity and consistent with the IHS E3 vaccine strategy, in April of this year, our IHS Chief Medical Officer, Dr. Christensen, issued a call to action to administer PCV20 to all American Indian and Alaska Native adults with an indication. PCV21 has a great potential to prevent invasive pneumococcal disease in American Indian and Alaska Native adults and provides excellent coverage for the serotypes causing disease in those ages 65 years and older. However, it does not include serotype 4, so it's important to retain a serotype 4 containing vaccine as an option, especially for our American Indian and Alaska Native adults ages 18 to 49 years of age with risk factors for invasive pneumococcal disease. Neither PCV20 nor PCV21 is perfectly matched to protect against the currently circulating serotypes in tribal communities. But where data is available, clinicians serving American Indian and Alaska Native patients may be able to tailor their vaccine recommendations to the local epidemiology. The burden of invasive pneumococcal disease increases at a younger age among American Indian and Alaska Native adults, and historically we've done better implementing age-based rather than purely risk factor-based indications. A recommendation for PCV21 that includes those ages 50 years and older would be a benefit in the American Indian and Alaska Native population that we serve. And of course, moving forward, continued surveillance and additional expanded valency vaccines will also be useful. Appreciate the opportunity. Thank you.
Thank you so much. That viewpoint is incredibly helpful. Ms. Arthur?
Thank you. Actually, I think many of the things I wanted to say have been said, but I wanted to just raise the overall concern with the
Ms. Arthur, can you get closer to your mic, please?
Of course, I'm sorry. I think that I just had a little bit of concern about the way we were looking at the equity conversation as a zero-sum game, where to some degree it appeared on the slide with the cons that there might be a negative impact on equity for others if we focused on the equity issue in general. I think that's been explained, but perhaps there could be just a little more discussion about how we make sure we think of equity in general is raising all boats, and that if we have more people in each of the groups getting more vaccine, we have an overarching improvement in vaccination status. I feel like Dr. Lair touched on this somewhat, but I just wanted to reinforce, regardless of the vaccine, as far as industry concerned, we are trying very much to focus on bringing interventions to populations that raise equity while still offering great options for all populations regardless of equity. And I hope that's the approach that the ACIP takes in looking at each of these interventions in turn. Thank you.
Thank you. Dr. Zimmerman. Rick, we can't hear you.
Thank you. Sorry there. We recently published a piece on the societal cost in adults 50 of racial inequities in pneumococcal disease, and the cost is $673 million for adults age 50 and over, and that's the racial disparity cost, and that's a large number, obviously. In addition, I wanted to point out in a different paper, in the Pittsburgh paper, there are the strategy that reduced invasive pneumococcal disease deaths and cases the most in Blacks was vaccination with PCV21 at ages 50 and 65. And in the non-Black population, PCV21 at ages 50 and 65. And so that's not an economic analysis, but more of a decision analysis showing the potential benefits in terms of human lives and cases. Thank you.
Thank you. Dr. Hopkins.
Thank you. I'm putting my practicing physician hat on as well as my NFID hat and trying to raise the agreement with what Dr. Sineas said and what you said earlier, Dr. Talbot. We want to make the right thing, the easy thing for implementation for practicing physicians. I wholeheartedly support giving PCV21 down to age 50 to help improve the health of my patients with and without risk factors.
Thank you. Dr. Goldman.
Thank you. Not to be redundant, but echoing much of what has been said, as a private practice physician who is taking care of these patients, I too would want to see age 50 and above. You know, another consideration is many of my patients in the 60 to 65 range are either retired, not working, but not yet Medicare eligible and have lost insurance coverage. Again, why we need a vaccine for adults program. But that being said, those patients are at risk as well. So if we had a lower age to 50, not only is it easier to implement a universal recommendation, it also may improve equity by being able to allow patients who currently have insurance in that working 50 to 60 range get the vaccine, where they may lose their coverage at age 60 and be vulnerable until they then reach Medicare status. So I would be very much in favor of lowering the recommendation to age 50. Thank you.
Dr. Morgan, are you filling in for one of our liaisons? I don't have you on my list.
Yes, I'm Dr. Randall Morgan. I'm past president of the National Medical Association, and I'm filling in today for Dr. Patricia
Thank you.
Whitley.
Yes, thank you.
And also Dr. Virginia Kane, who is the current president-elect of the National Medical Association. And just wanted to second or third the importance of the inoculations for pneumococcal disease at age 50, particularly because of the life expectancy in Blacks, as we all know. Particularly Black men is much lower than other minorities and whites, being at a level of 69.1 as compared with Black women at 72.8, Asians at 84.5, and Latinos at 80.0. The poor clinical outcomes for Blacks also create systemic challenges associated with earlier, longer, and more serious hospitalization stays, as well as possible deaths. So therefore, the new pneumococcal vaccine recommendation to the age of 50, or beginning at the age of 50, will certainly improve the lives of many Black patients and enhance the population health of our community. Thank you.
Thank you. Yeah. I'm sure we'll have other discussion. We're going to carry some of that forward throughout the rest of before we get to the policy. We do have two manufacturers who are going to speak, Merck and Pfizer. So you know, Merck and Pfizer, you each have 3 minutes. And unfortunately, because we're running late again, I'll have to keep you to those 3 minutes. So if Merck would like to start, that would be phenomenal.
Thanks. Hi, it's Rick Halp. Can I just confirm the audio is okay?
Great.
Okay, good. I head up the Vaccines Medical Affairs Organization for Merck, and we would like to thank ACIP for the thorough review of PCV21 for adult vaccine recommendations. As you can see, PCV21 was developed as a unique and differentiated adult-specific pneumococcal vaccine that, due to its serotype composition, supports a broad public health impact by addressing most of the residual pneumococcal disease in adults. And the expansion of a routine age-based recommendation that includes 50 to 64 years of age can really impact that substantial public health effect. While the majority of IPD cases of pneumonia in this age group occur among adults who do have risk conditions, the current vaccine uptake in this group is far too low. And additionally, there are also significant racial disparities in pneumococcal disease risk and prevalence of risk conditions. Therefore, implementation of a routine age-based recommendation can improve access to and uptake of pneumococcal vaccines and reduce disparities in adults 50 to 64 years of age with risk conditions. I just wanted to note a couple of issues and the challenges that were raised by the working group. And I think I would agree with others who have said this, that in fact, lowering the age of recommendation would likely improve vaccination coverage rates in all populations and could have a far greater impact on reducing disparities and improving equity. And this opportunity would be lost if no expansion of the recommendation to 50 occurs. And then it should be noted that the outbreaks of serotype 4 that we've talked quite a bit about has been seen in certain population clusters. And it's been with the highest incidence that occurred in 18 to 49 years of age. Therefore, it really suggests that a targeted vaccine strategy should be considered to control serotype 4. It is not being seen at a population level. And it certainly does not diminish the positive overall population impact of PCV21 in adults 50 years of age and older. And then lastly, I think you can make a much more simple recommendation that can make implementations much more readily facilitated through an age-based recommendation. So in summary, the ACIP has considered expanding the age-based recommendation to 50 years in the past due to the potential to improve vaccination coverage and reduce disparities. And I think the evidence review today for PCV21 provides a justification to do so now. So on behalf of the Merck team, I want to thank you for your thoughtful and objective assessment. And a note on supply, Merck has built a supply that can support the broad recommendations that are being discussed, the routine recommendation over 65, an expanded recommendation to 50, as well as the use as a supplemental dose. So you can be assured that that has been, that strategy has been thought about and prepared for. Thank you.
Thank you so much. We'll move on to our Pfizer colleagues.
Thank you, Dr. Talbot. Can you hear me well?
Yes.
Okay, thank you again for the opportunity to speak to the ACIP again. I'm Luis Joder, I'm the Chief Medical Officer for Vaccines and Antivirals at Pfizer. I just want to say that I agree with almost everything that everybody has said, but let me just give you a little bit of our perspective here. So after the FDA approval of PCV20 in adults and older than 80 years of age, in October 2021, the ACIP considered PCV20 for the use in adults 50 plus, and ultimately voted for an age-based recommendations for adult 65 and older and risk-based recommendations for adult 19 to 64 years. So the current policy question proposed the potential recommendation of PCV21 in populations that currently have no recommendations for use of any PCVs. Specifically, and I think this has been mentioned before, the potential for having one PCV vaccine recommending for healthy adults in 50 plus and other PCV vaccines for other ages or at-risk conditions, PCV 15 plus PPSV 23, PCV 20, etc., would likely complicate rather than simplify implementation of these recommendations. I think this was already discussed during the October 2021 ACIP meeting when the same age-based recommendations for those 50 plus was considered for PCV20, and I think it's being discussed right now. At the time, the rationale for opposing a recommendation at 50 plus years were, well, first, lack of evidence of clinical efficacy of these new vaccines. Second, questions about duration of protection. And third, potential for initial implementation challenges in a new age group. These reasons, we believe, also continue to apply in 2024 for both PCV20 and PCV21. Firstly, similarly to PCV20, PCV21 has been licensed based on immunobridging, and vaccine clinical efficacy has not yet been demonstrated. Secondly, as it occurs with PCV20, it is unknown for how long a single dose of PCV21 at 50 plus would protect an individual, or if and when they would require a booster dose. Thirdly, a difference in recommendations for vaccines where PCV20 is recommended for risk groups and PCV21 routinely recommended for all individuals would inherently result in inequitable access to prevention against the unique serotypes contained within PCV20. In summary, we believe that all PCVs licensed for use in adults aged 18 years and above should be considered as options for the new platforms being assessed, in particular routine vaccination for all adults aged 50 years. Applying different criteria for different PCVs would create a state of an inequality. And just one comment, Dr. Talbot, I think you've mentioned that we would not do this in the pediatric field. Well, there are a couple of options in the pediatric field now for pneumococcal conjugate vaccines, basically PCV15 and PCV20, and are the HCPs, depending on coverage or depending on the confidence or immunogenicity results, that choose one vaccine or another. Thank you very much.
Thank you. Now we get to start talking motions. Unless there's something anyone else wants to say before we move to motions. Dr. Kobayashi. Oh, yes, please do.
All right, thank you, Dr. Talbot. So I'd like to present the proposed voting language that we have right now and clinical guidance for implementation. So the proposed voting language is ACIP recommends PCV21 as an option for adults aged 19 years and older who currently have a recommendation to receive a dose of PCV. And then since this includes several groups, I have a few slides to show in text and also visually how this will be implemented if this were to be approved. So for PCV-naive adults or whose pneumococcal vaccination history is unknown, the proposal is to recommend a single dose of PCV21 as an option for all adults aged 65 years and older and for adults aged 19 to 64 years with certain underlying conditions or risk factors. This adds PCV21 as an option to the current recommendation to use either PCV20 alone or PCV15 in series with PPSV23, so implementation barrier is expected to be low. PCV20 exhibited comparable safety and immunogenicity findings to the comparator vaccines in clinical trials, and economic evaluations were consistently favorable. So this is how the updated clinical guidance will look like if approved. PCV21, highlighted in red, will now be added as an option to existing PCVs. For PCV-experienced adults who completed the recommended vaccine series, shared clinical decision-making will be recommended regarding use of a supplemental PCV20 or PCV21 dose for adults aged 65 years and older who have completed their recommended vaccine series with both PCV13 and PPSV23. This adds PCV21 as an option to the current shared clinical decision-making recommendation for PCV20 among adults aged 65 years and older who completed the recommended vaccine series with PCV13 plus PPSV23. Some work group members were in favor of expanding this indication to adults who received all recommended vaccine doses with a single dose of PCV20 or PCV15 plus PPSV23, especially for adults with risk conditions, but others felt that there was insufficient evidence to support that. A phase 3 clinical trial on PCV21 use among PCV-experienced children with risk conditions is underway, so the proposal is to discuss PCV21 use in children and adults with risk conditions who completed recommended vaccine series together to ensure harmonized review of data. This is how the updated clinical guidance will look like. PCV21 will now be added as an option to PCV20 based on shared clinical decision-making. And this will be the last group for PCV-experienced adults 19 years or older who have not completed the recommended vaccine series. A single dose of PCV21 is recommended as an option for adults who have started their pneumococcal vaccine series with PCV13, but have not received all recommended PPSV23 doses. So this, again, adds PCV21 as an option to the current recommendation to complete the vaccine series with either a dose of PCV20 or one or more dose of PPSV23. In addition to those who started the series with PCV13, adults who received PCV15 but have not completed the series with PPSV23 will have an option to complete the series with either a dose of PCV21 or PCV20 if they no longer have access to PPSV23. So this is how the updated clinical guidance will look like. As mentioned, adults who received PCV15 but have not received PPSV23 will have an option to complete the series with PCV21 or PCV20 if they no longer have access to PPSV23. And there is one slide on serotype 4, clinical guidance for providers in areas with high proportion of serotype 4 disease in the community, and this is still a draft. In certain communities where there are high proportions of disease due to serotypes unique to currently recommended vaccines, those vaccines may provide more protection against locally circulating strains compared to PCV21. Those who may be at increased risk of disease due to serotype 4 includes adults aged under 65 years in the Western United States with certain underlying conditions or risk factors that increase the risk of pneumococcal disease. And I'd like to thank the following groups and individuals for their contributions. Thank you.
Yes, please,
Just
Dr. Long.
Just a quick comment, listening to this very good discussion. So if we did 21 down to the age 50, age-based, it would really be because doctors, primarily because doctors couldn't understand and implement. I have a patient, they're coming to me for care, and they have a condition, and I'm not going to recognize it, or I'm not going to give them a vaccine because of it. I think that's an expenditure of money. I think I'd rather educate doctors to do that better. This recommendation would cost $270,000 per quality to 21 down to 50. Then we would leave 21 to 50, 20 at 65. We cannot think of getting 20 down to 50 so that they match up, because that's $630,000 per quality, and that is just, I think that the 270 is unacceptable, but the 630 is outrageous.
Jason, are you still on the line? Dr. Goldman?
Yes.
Okay. You are a practicing internist. Dr. Freihofer can also answer this as a practicing internist. Do you feel that it's lack of education for internists to vaccinate those at high risk between 50 to 64, or do you feel like there are other reasons? Can you please expand?
Sure. I certainly don't think it's lack of education. I think those of us in internal medicine specialties who are in the vaccine space, we're able to read the vaccine schedule. We understand the chronicity of patient disease and care and what is required. I think the issue comes in with quite honestly, the barriers are beyond the control of physicians, the federal government, the reimbursement, the storage, the insurance companies that create barriers to care in preventing the vaccination, the ability for physicians to be able to take care of the patients the way they need to, as well as the overarching administrative burdens that are created by the system, which makes it difficult to add yet another requirement. That being said, it's not lack of education in giving pneumococcal vaccines. I think that it is imperative to make a simplified process so that we can delegate with standing orders to our staff to make sure the patients are screened appropriately and that they're giving the vaccines that are needed. I think it would be very simple, quite honestly, to stock both 20 and 21 in the office and be able to implement both of them. So in my opinion, I certainly see these as two separate and useful vaccines that are needed. Lowering the age to 50 would simplify the process, not because of a lack of education, but just because of the system dynamics that make it a barrier to patient care. And while I appreciate the expenditure to society and the quality, I always have to go back to the only patient that matters is the one sitting in front of me until I see the next patient, and that's the most important patient in the world. I have to defer that while the committee, of course, is a public body and has to look at the cost of society as a practicing physician, I have to look at what is most beneficial to my patient in front of me, and I would be in favor of making sure they have access to both vaccines. Over.
Thank you. Dr. Kobayashi, I had a question about, can we go back to the 65 plus that you had? Or can you go back to one of the original proposals?
This is the original proposal.
Oh, you had one that said if greater than 65 or 19 to 64 and you have a high-risk condition?
Maybe that was the clinical guidance.
Okay, thank you. That's what I was confused about. Okay, thank you very much. Okay. No, I don't want the clinical guidance. I found it confusing. Plus, that might change based on our voting language. So, Dr. Schechter, you look like you're ready to say something.
If I can just ask for just a quick recap, that if instead of 50 and 65, if immunity was durable, and it was a single dose at 50, and either the combination of durable immunity or the changing landscape of disease from evolving childhood and adult vaccination were to change, it was to be a single dose. It can just recap what the cost-effectiveness implications would be.
I'm sorry, so the comparison between when PCV21 is given as a single dose at age 50 versus both at 50 and 65, was that the question? Yes, so, so I can speak to the Tulane CDC model that was presented. So if we moved the age-based recommendation, or in the model, from 65 to 50 years, the base case was cost saving, but then the caveat was that it actually caused more disease. But then there were quality benefits because there are more qualities gained by preventing disease in younger adults. So that's why we did the alternate approach, which was adding, so in addition to vaccinating at 65 years, what happens if we added a dose at 50 years, to look at the potential benefit specifically in the 50 to 64-year-old age group. So for that one, the Tulane CDC model base case was around 270,000, but it ranged from 3,000 per quality gained to 270,000 per quality gain across the models that we reviewed.
And that also assumed after 5 years, the beginning of a decline of immunity with zero immunity at 15 years, correct?
That is correct.
Dr. Daly?
Yeah, all right, I gotta take a big deep breath here because this is hard. What's that? No,
You can take two if you need.
So, I think it would be really problematic to have a recommendation down to age 50 for a PCV21 vaccine and not for other high valency pneumococcal vaccines such as PCV20. I think that would be really problematic, okay? Even though I acknowledge that PCV21 is not equivalent to PCV20 plus an additional serotype. It is a different vaccine that has broader coverage, which is great. 85% coverage, that is great. And so I personally would ask the work group if they would bring the full proposal to ACIP in October for bringing down universal recommendations to age 50 for high valency pneumococcal vaccines, because I feel like I didn't have that material today for that big of a decision. And the reason I said I need to take a couple breaths is that, you know, there's an opportunity cost. And this is a bit kicking the can down the road, and I hate doing that. And you highlighted that, Dr. Talbot. You said this is the second time this has come up. But I felt like, as an ACIP member, I didn't see the data for all high valency pneumococcal vaccines down to age 50 for a universal recommendation today. But I'm hearing that's a really important question to answer, and we need to answer it pretty soon. So that's my best sort of whether it's threading the needle. And that would be my personal preference. If pushed, I will vote. But I would prefer to ask the work group, and I ask this with all due respect, because I know you guys have worked incredibly hard to get us to this point, but ask to evaluate data for high valency in October. Thank you.
Dr. Freihofer, I see you have your hand up.
Thank you, Dr. Talbot. You had mentioned me earlier as a practicing physician. Sandra Freihofer from the American Medical Association, speaking as a practicing physician. pneumococcal vaccination for adults is the most complicated vaccination recommendation that we have. And I think having a different age group for PCV20 than for PCV21 would add much confusion. As been mentioned, PCV21 is not PCV20 plus 1. It is a totally different vaccine. There are also many questions about the serotype 4, and we need that. We need to have PCV available to cover those patients that are at risk for serotype 4. So I really support Dr. Daly's suggestion that we need more data, maybe come back in October, but making that change now with 2 different age groups for 2 different vaccines that sound so close, sound so much alike, but are really so different, would just make a very confusing vaccination recommendation sort of unintelligible.
Thank you. Dr. Long.
I was going to add to that I think it would be good for us in the work group to look at this again and to answer more succinctly your question about duration of protection from polysaccharide conjugate vaccines, because the data that we saw in our immunology colleagues, there is no indication for conjugate vaccines that there is protection after 12 to 15 years. So that's why that was modeled. So making the decision for the 50 really makes probably, most likely, a decision for 65, which gets to be an awful lot of money. And another vaccine.
Any other comments? Dr. Cotton and then Dr. Brooks.
Yeah, real briefly, I hear
Or
what,
Dr. Brooks and then Dr. Cotton.
mine's quick. I heard what Dr. Daly said. I would ask maybe that the committee come back and give us a proposal on PCV20, but that wouldn't preclude us from voting on 21 today. It's going to take, as Dr. Larry said, it's going to take a year anyway. So there's enough time that if we vote on 21 today, they can come back and give us their position on 20.
I really appreciate what Dr. Jason Goldman said about the patient in front of you, and that's certainly, as a practitioner, I fully appreciate that. I do feel the need for some financial stewardship, and I am worried about the magnitude of the costs that we are incurring, both with RSV vaccine, which is now quite expensive, and then with this vaccine, which is $319 plus administration fees. And I think that we really need to think about cost. I'm hearing about QALYs, but if you do the back of the envelope calculation, or Sarah's doing it on her napkin, it's really, these are quite expensive, and I'm really debating the true, I understand the QALYs, but it is, at the end of the day, we're adding a tremendous amount of cost to American healthcare, which seems to have, no end, but nonetheless, there must be a budget that needs to be balanced somewhere.
I was actually going to have a request for the work group, but it was to get rid of the polysaccharide vaccine. So part of me wants to do the 50 and above today, so we can do that at the next meeting. So that's something to think about too. Dr. Schechter. You're sure? You can go now if you want.
So whatever we decide today, can I have you pull up slide 10 from the ETR, please? And
Could you pull up slide 10, please?
I feel like I should go take this tangent afterwards, but I'll go for it now. Slide 10. So it feels like within the ETR, there's a case for a reinforcement of the importance of pediatric vaccination towards the issues we're talking about today. And on this slide, I see on the age less than 5, 37% of the residual burden of pediatric disease caused by the serotypes that are in 21 and not 20. And then on slide 34, the impact of prior immunization on not only on public health burden, but on reducing disparities and on equity. And my fear is that the serotypes that are in 21 and not 20, or that are in the forthcoming 24 and 31 serotypes, for whatever reasons that led to PCV 20 being introduced in adults before kids, that it's going to take a while for these serotypes to get to kids, and yet there's this tremendous opportunity to address both pediatric and indirect effects on adults through that. And so whatever we decide today, I would hope that there's a way to expedite access to children to these serotypes to address both pediatric and adult disease burden.
Okay. Is anyone ready to propose a motion? Oh, sorry, we have the language back up. And we're going to, for the public who is listening, we are still going to have public comment. We're hoping to delay by just 5 minutes. Dr. Lair?
So I would like to make a motion that in favor of the ACIP recommends PCV 21 as an option for adults aged greater than or equal to 19 years who currently have a recommendation to receive a dose of PCV.
Someone want a second? Thank you, Dr. Jameson. Okay, any discussion on this motion? And this is the only motion that the work group has brought forward. Does anyone want to make a different motion in addition to this one? Okay, my request is when you take back what Dr. Daly has said, that you also come back with no polysaccharide at all on the recommendations. It's done its thing, but it's been bested. Okay, I think it's time for public comment. Yeah, so we'll take a 2-minute break.
So she says
5. 5-minute break. Welcome back, everyone. We are ready for our public comment. I'd like to welcome and thank our public comment speakers for addressing the committee today. All the speakers today submitted a request in advance of the meeting, and the final list of public commenters was determined via lottery. For our speakers today, we have a limited public comment period, and in order to make it through all of the listed speakers, it is extremely important each speaker limits his or her or their remarks to 3 minutes. We will be displaying a timer on the screen so you know how much time you have left. As a gentle reminder, we greatly appreciate diverse viewpoints. However, we expect them to be respectful in nature and focused on the issues that are being discussed. You ready? Okay, so we are going to start with Ms. Humbert.
Hello.
Hello, we can hear you perfectly.
Thank you. Hi, I'm Chloe Humbert. We need better vaccine promotion campaigns from our government. The recommendation for a spring COVID vaccine boost for seniors was not well promoted. Worse, the spring boost excluded 50 to 64-year-olds with underlying conditions, people clearly at risk of hospitalization or death. At a previous CDC meeting in September, it was mentioned twice that there is no group that has no risk from severe illness. The exclusion of 50 to 64-year-olds or any adults from a twice-a-year option is perplexing since there's no evidence of risks that outweigh benefits, especially for people over 50. And there's been evidence presented at previous meetings of profound waning. Many patients at times fail to heed doctors' advice, but that's not a reason to stop encouraging patients to quit smoking, and that's not a reason to stop promoting vaccination. There is certainly no good reason to restrict access to the next COVID vaccine update. And to be clear, catering to private insurance company lobbyists is not a good reason. Of course, the recommendation for the spring booster for seniors on Medicare was not even properly promoted. Uptake for seniors is horribly low, and it's because there are people in their 80s who have not gotten the message, which is the responsibility of the CDC. This is what the public is paying this agency to do. This lack of vaccine campaign is persistent failure, and the anti-vax has been coming from inside the House. The scandalous news about the anti-vax campaign perpetrated by the DoD contractor on behalf of the government is a grotesque pinnacle of our nation's unacceptable public health failures. This disinformation campaign was reported to have undermined vaccination and also masking and testing. It reported that military PSYOPs campaign was forbidden by law from targeting Americans, but in our World Wide Web world in a global pandemic, the idea of undermining public health abroad without harming Americans is ridiculous on its face, and harming innocent civilians abroad during a global health crisis is not itself defensible. CDC officials may think that this is not the fault or responsibility of the CDC, but that's false. This is not just some people online, and it's not a game. Real people are counting on the CDC. Leadership cannot rest on laurels or point finger elsewhere. Infectious disease doesn't recognize geopolitical boundaries or federal agency silos. An amend is needed. And CDC should have a distinct and purposeful goal of actually promoting public health and leading vaccination promotions with an active campaign. Thank you.
Thank you very much. Ms. Rapp?
Hi, good afternoon. Testing my sound.
Perfect.
Hello, and thank you, ACIP members, for your important work in making vaccine recommendations. I am so grateful to have access to this very important tool of COVID boosters in my toolbox during a global pandemic. As a mother of 2 young children, my comments today are focused on timing, access, and frequency of COVID boosters for our little kids, who unfortunately do not have access to the same toolbox. On timing, those of you with small children and who live in the South may be aware that schools here start back up in August. It is August when kids are gathered together in poorly ventilated school buildings and start sharing germs. All populations, including kids, need access to the updated boosters as soon as possible so that we have enough time to get our kids into the pediatrician's office or health department before August. October is not acceptable timing. As we now know, COVID does not care about winter cold and flu season. On access, please increase the number of vaccine options available to little kids, including Novavax for under 12s. Many parents I know would prefer that option for a more traditional protein-based platform. This will help with vaccine uptake for young kids. Young children also do not have the same level of access for vaccination sites because in many states, babies and toddlers cannot just pop into the neighborhood pharmacy or minute clinic for a vaccine. In Virginia, for example, pharmacists might vaccinate kids starting at age 3, but in my experience, many of them won't. Parents and pediatricians' offices need that extra time to make and plan appointments. Additionally, not all pediatricians' offices will carry COVID shots, and parents can't just take their kids to a brand new pediatrician for a booster. The planning time for kids to get boosters is longer. Right now, my parent friends are setting up their before the school year pediatrician appointments to get physicals and required school vaccinations. It would greatly increase the vaccine uptake rate if COVID boosters for kids were available in July when these before the school year appointments are already happening. On frequency, I also implore you to increase frequency of boosters for all ages. We now know that primary COVID shots and boosters lose effectiveness. When you combine this with dominant variant changes, the inability of small kids to mask, and states banning masks, our toolbox is getting smaller. We do not yet have a grasp on surges, and all people need a level of flexibility in booster frequency. Again, thank you for your work in prioritizing timely, accessible, and frequent COVID boosters for all people, including young children.
Thank you greatly for your comments. Dr. Kaufman.
Sound okay?
Yes.
Thank you for the opportunity to speak. I'm here to thank you, but also to challenge you to do more. I'm Dr. Brian Kaufman. I'm a retired family doctor and a CLL or chronic lymphocytic leukemia patient myself. I'm also the co-founder, executive vice president, and nonprofit of the CLL Society that's dedicated to the unmet needs of the CLL community. As the committee already knows, CLL is a cancer of the immune system, and it is well recognized that all CLL patients are immunocompromised, regardless of their treatment status. Similar to other immunocompromised or IC communities, CLL patients were disproportionately affected by COVID-19. This is not a new phenomena, as our increased morbidity and mortality from infections, especially respiratory, and we just heard a lively discussion on Streptococcus pneumoniae, has been long documented with limited remediation available through hygienic measures such as masking and hand washing, prophylaxis with appropriate antimicrobials, and pre-exposure prophylaxis with monoclonal antibodies, and of course, vaccination. However, it is also well documented that our response to vaccines is less predictable and robust than that of the general population. We were therefore extremely grateful to and commend the ACIP for recognizing the IC as a special category and tailoring recommendations specific to our need. It is a welcome first step in offering our high-risk community protection similar to that afforded those with normal immunity. But more is needed. Often the evidence to make these recommendations is weaker than that with other vaccine recipients where randomized control data was used. Sadly and ironically, the IC are often excluded from such trials, so decisions end up being made by expert consensus based on the real-world evidence in the vulnerable population. We therefore ask ACIP to, when appropriate, push to include the immune-compromised as a cohort in randomized controlled clinical trials so your experts can use the highest quality data to inform their decisions. Next, we would challenge ACIP to coordinate its efforts with CIDR, and the others to integrate every available immune measure, including vaccines and pre-exposure prophylaxis with disease-specific monoclonal antibodies, to offer the IC their best package of protection. Please consider recommendations for both active immunity through vaccination and passive through antibodies, so important to those of us who do not mount an antibody response in your guidelines, so patients and healthcare providers and formulate a plan from one reliable source. The I in ACIP stands for immunization, which to me means more than vaccination. Finally, we would ask ACIP to consider what steps are necessary to revisit the near universal prohibition against live vaccines in the immune-compromised. In some diseases, they are the only protection we're offered. Please find ways to explore the safety and efficacy of live vaccines rather than dismiss them all as too risky and leave us completely unprotected. Thanks for listening and considering the challenges that I and others in the immune-compromised face to protect us. Thank you.
Thank you. Dr. Plotkin. Dr. Plotkin, are you on mute?
Hello, can you hear me?
Perfectly. Thank you.
Thank you. First, concerning the impact of vaccine combinations, yesterday ACIP approved a hexavalent vaccine for a particular use. Good, but we need more combination vaccines. The obvious point is that more and more individual vaccines are achieving licensure, which is great. But if you look at the history of vaccine licensure, in the 20th century, 3.4 new vaccines were licensed per decade. But in this century, the figure is 6.5 new vaccines licensed per decade, which raises a problem. If each vaccine is given separately, there will be many post-vaccine periods during which a chance illness might arise that could be attributed as a reaction to the vaccine. In other words, more vaccination dates and more injections could lead to more putative safety issues. Also, scheduling becomes more complex. And of course, more injections means more medical visits. So aside from convenience, there is good reason for vaccine combinations. And that may mean vaccine manufacturers collaborating with each other. I hope the ACIP will express enthusiasm for combined vaccines to induce manufacturers to work together and also to advance vaccine coverage. My second subject is I am happy to see that chikungunya vaccine is under consideration. I became aware of chikungunya during a visit to India early in this century, where I saw how devastating it can be to those infected over months and years, even if mortality is low. As you know, chick is now a worldwide disease, and as global warming increases, it will inevitably spread northward. Ever since that realization, I have been a consultant to Valneva about their chick vaccine, and I'm happy to see it progress to licensure. Inevitably, chick will continue to spread with global warming. The best way to prevent outbreaks is to produce an immune human population that will also reduce the spread of infection among mosquitoes. Waiting for an outbreak and responding only then is a recipe for increased individuals with chronic problems due to chick. You know, chick means all bent up. Maybe we need a new name that will make it seem less exotic, but I hope ACIP will eventually recommend prophylactic vaccination in areas where there are Aedes mosquitoes. Thank you.
Thank you, Dr. Plotkin. Jamie Schonbaum.
Yes. Hi,
We can hear you, but it's very difficult to hear. Does someone need to be muted? Okay, can you?
What's that? Is this okay now? I hope
Perfect.
better.
It's perfect now. Thank you.
Okay, perfect. I'm glad. So yeah, thank you everyone for being available today. I'm reaching out because I'm a meningitis survivor, and I got sick in 2008 when I got sick with meningitis. I was a college student, worked really hard to get my dream university, and unfortunately got sick within 14 hours. And that's the thing about this disease. It typically kills within 24 to 48 hours. 1 out of 10 that gets this disease will die, and 1 out of 5 will have long-term consequences. And that's me. I came out of the hospital as an amputee. But other symptoms that, or not symptoms, but long-term consequences that come out of it is that you can become blind, you can become deaf, you can have mental challenges, organ failures. But I guess you can, to me, I say I'm lucky to just have amputations as part of my result of meningitis. But yeah, I survived. How long was my battle? It was about, a casual 7 months in the hospital. And when I got out of the hospital, I was 80 pounds and I lost all of my hair. But when I was in the hospital, when I first got sick, the symptoms that or the pain that I was enduring, I tell people that I felt like I had 1,000 pounds of sand in me. I couldn't lift my arms over my head until about 5 months into my stay. And, I was literally dependent on nurses to roll me from side to side to prevent bed sores. I didn't lift my arms over my head until I was leaving the hospital. And that was a big deal because I could finally give people hugs. Isn't that crazy? But yeah, so I prevailed, I survived, but the reality is that I will be dealing with prosthetic care for the rest of my life. And it's just really unfortunate that it's because I wasn't vaccinated and I walked onto college campus at a high risk of catching this disease, had no idea, and almost lost my life to it. So, but I mean, it's one thing to survive, it's another thing to lose a child. And I know a lot of people who don't have their surviving children. And so I'm out here trying to be the voice for them and for myself as well, because no one should go through what I did. This disease is commonly misdiagnosed due to the cold/flu-like symptoms, which, for the early onset symptoms. And I didn't even get those clear indicators of meningitis until the last hour. And at that point, there was a nurse there that guessed I had meningitis. So I was very lucky to have that nurse there guess that I had meningitis. But yeah, when I was in the hospital, what did I look like? I was in fetal position. I was super cold. It's not like, oh, that's meningitis. It's just so risky to guess if you had meningitis, which is why vaccines are so important. I know someone that was misdiagnosed when they went to the hospital, and then they went home, and then they went back to the hospital, and they were declared brain dead within 18 hours from their first symptom of meningitis. And that's just really devastating. And so that's why we're out here today, because I don't want anyone to go through what I did. It was truly devastating. And the disease can really have a lasting impact on everybody, including myself. I recently had my leg re-amputated 2 years ago because of an ill-fitted prosthetic.
We greatly
So
appreciate your
meningitis.
story, but I
Oh,
need you
I went
to.
over. Thank you. Sorry about that.
No, that's okay.
Well, thank you everyone for listening. I didn't have the timer on my phone, didn't see it, so I was just winging it. But yeah,
No.
thank you so much, everybody, for
We
your time.
appreciate it. Thank you so much.
Of course.
We're looking for Mr. Ford next.
Here's a mic check. Can you hear me all right?
Perfectly.
Okay, thank you for letting me give this comment, and I have no conflicts of interest. The role of the CDC is to set guidance that will protect people from disease. But between mountains of anti-vax propaganda, state representatives violating the ADA as they try to ban conventional masking, and variants mutating faster than we can keep track, it's a very challenging time for folks to protect themselves. Instead of giving you a big emotional statement, I'm going to give you a list of things that need to be addressed. I want to start by saying that the diseases discussed today are a risk to everyone, not simply the immunocompromised. Looking at it through the keyhole of death is a mistake. When any single infection can destroy someone's quality of life forever, and we need to get everyone we can to limit the risks. We need to do everything we can to limit the risks. We need an earlier vaccine rollout with universal approval for all. 2 vaccine manufacturers are prepared to roll out as soon as mid-July, before the school year starts. A petition just a few days ago for this, and it's already at 1,000 signatures. Moderna is seeking approval of their JN1 as well as Novavax. If in addition to that, a KP2 vaccine is approved as well, we must ensure both types of vaccines are recommended so insurance providers will cover them. Recommendation needs to be for 2 shots to meet the advanced mutations between XBB and JN1, with imprinting being a major concern. COVID vaccines need to be made available twice a year, every year, for everyone. Not having the proper recommendations makes it so insurance can opt not to cover it. The public requires clarity on 2 vaccines 2 months apart, as this should be available to anyone. This rule was designed to allow anyone to have access, and we simply need to remove the additional hoop. The CDC and FDA should consider meeting twice a year to discuss variants and possibly an update to RNA, or if additional Novavax is required. This will also potentially give the Global South a targeted vaccine for their winter surge. Please stop seeing the COVID vaccines only through the lens of RNA. As this committee discussed today, it does have some limitations, including waning with gaps, limitations that are not present in the protein-based vaccines. We can get full coverage without gap that meet our current changing variant landscape, but only if the CDC makes clear guidance so that insurance is required to cover them. As the Bridge program is expiring, access via insurance is the only way that people can access these life-saving vaccines, and your recommendations determine not only if people can access them, but whether insurance will cover the once free but now cost-prohibitive vaccines. Regarding pediatric COVID vaccines, I don't speak for them, but it would appear Novavax has expressed hesitation to file for the expansion of their product after the past regulatory pains. So then it could be administered to children. We need these hurdles removed and this product available. It's the same vaccine we use for adults that is safely administered to children, which means we could be vaccinating our kids with it right now and making them safer, but we aren't, and there's simply no good reason. The benefits of Matrix M alone make this a valuable addition to our toolkit for protecting kids. Even though this is not technically vaccine related, we are currently having state houses, both Dem and Republican, trying to go against CDC guidelines and limit individual freedoms by banning masks or other personal airborne protections under the guise of security. These politicians need a quick lesson in ADA compliance from the CDC. We are significantly less secure when our state reps are trying to ban protective PPE while a new surge is starting just weeks after the WHO took droplet theory to the waste bin and clarified the risk of transmission through the air. Also, please take H5N1 more seriously. It's already mutated into multiple different versions. There is so much what we don't know, but what we do know shows it as a ticking time bomb that needs to be diffused before it goes off, not after. Thank you.
Mr. Ford, we graciously, sorry, my mic wasn't on and then I started stumbling. Thank you for your time. Ms. White.
Thank you. Can you hear me?
Yes.
The Amputee Coalition exists to support, serve, and advocate on behalf of the 5.6 million Americans with limb loss and limb difference and their families, caregivers, and clinicians. We are grateful to have the opportunity to comment today about the important role vaccines play in protecting our community, so many of whom are at elevated risk for contracting the serious viral and bacterial illnesses that occur annually during the fall and winter respiratory disease season. Well over half of the more than 5.6 million individuals missing limbs in the US have serious underlying health conditions, including diabetes, peripheral arterial disease, and cancer, illnesses that have been shown to be the most likely causes of limb loss. And of themselves, they are significant risk factors in increasing anyone's vulnerability. But limb loss patients have additional burdens. First is the impact on patient health from living with reduced mobility, which can result in increased muscle weakness, atrophy, weight management, additional cardiovascular issues, and chronic pain. Another often overlooked issue is that obtaining medical services. It can be a significant challenge as travel can often and does present both physical and economic barriers to seeking care. Limb difference is the phrase used to describe differences in the size, shape, or structure of a limb. When compared to that's considered medically normal. And limb difference can occur as a genetic condition or from trauma, but it puts an individual's health at risk in many ways, including those that were listed above or earlier. The reality of the situations facing our community underscores the need for limb loss and limb difference patients to be able to know about, understand, and easily access the vaccines which CDC recommends for them. The CDC has acknowledged that some people with disabilities may be more likely to get very sick from flu, COVID-19, or RSV due to the number of factors, including underlying medical conditions. Ensuring our communities understand the vaccines that are available to them and have easy access to get them can really make a difference. However, confusion over CDC recommendations, insurance coverage, or having to make multiple trips to a provider to get vaccinated for one condition at a time can present real and formidable burdens to our community members. We urge the committee to consider our community when developing recommendations for the use of these vaccines and ensure that recommendations are as clear and broad as possible to support and increase in awareness and access by those who would most benefit. Thank you so much for the opportunity to provide these comments today.
Thank you. As we have finished with public comment, and we have 3 motions, and we're actually, are we really that far behind? Okay, let's get moving, y'all. All right, let's put up the COVID vaccine motion. Okay. The current proposed language that has been motioned is ACIP recommends 2024-2025 COVID-19 vaccines as authorized or approved by FDA in persons greater than 6 months of age. All right, let's start with Al Shaw. Name, conflicts, and vote.
Al Shaw, no conflicts, yes.
Dr. Schechter.
Rob Schechter, no conflicts, yes.
Dr. Maldonado.
Yvonne Maldonado. I'm currently the Stanford PI for Pfizer pediatric COVID, RSV vaccines, and adult varicella vaccine trials, and so I recuse my vote.
Dr. Long.
Long, no conflict, no cornflakes, no conflict, yes.
Dr. Lair.
Jamie Lair, no conflicts, yes.
Dr. Cotton.
Camille Cotton, no conflicts, yes.
Dr. Jameson.
Denise Jameson, no conflicts, yes.
Dr. Daly.
Matt Daly, no conflicts, yes.
Dr. Sineas.
Sybil Sineas, no conflicts, yes.
Dr. Chen.
Wilbur Chen, no conflicts, yes.
Dr. Brooks.
Oliver Brooks, no conflicts, yes.
And I'm Dr. Talbot, no conflicts, yes. So the motion passes 11-0. Anybody want to comment on their vote or make any comments? Okay, moving on to pneumococcus. ACIP recommends PCV 21 as an option for adults age greater than equal to 19 years of age who currently have a recommendation to receive a dose of PCV. Okay. I think the camera got turned. Yeah. By the way, all of you are on. Okay. We'll start with Dr. Long.
Sarah Long, no conflict, yes.
Dr. Lair.
Jamie Lair, no conflict, yes.
Dr. Cotton.
Camille Cotton, no conflict, yes.
Dr. Jameson.
Denise Jameson, no conflicts, yes.
Dr. Daly.
Matt Daly, no conflicts, yes.
Dr. Sineas.
Sybil Sineas, no conflicts, yes.
Dr. Chen.
Wilbur Chen, no conflicts, yes.
Dr. Brooks.
Oliver Brooks, no conflicts, yes.
Dr. Shaw.
Al Shaw, no conflicts, yes.
Dr. Schechter.
Rob Schechter, no conflicts, yes.
Dr. Maldonado.
Dr. Yvonne Maldonado, I'm the Stanford PI for Pfizer RSV, COVID-19 and adult varicella vaccine trials, and I recuse myself from this vote.
Okay. And I'm Kip Talbot, and I have no conflicts, yes. The motion passes 11-0. All right, ready for influenza? Okay. Dr. Cotton. Oh, I should read it. My apologies. ACIP reaffirms the recommendation for routine annual influenza vaccination of all persons aged greater than or equal to 6 months who do not have contraindications. Okay, Dr. Cotton.
Camille Cotton, no conflicts, yes.
Dr. Brooks.
Oliver Brooks, no conflicts, yes.
Dr. Schechter.
Rob Schechter, no conflicts, yes.
Dr. Chen.
Wilbur Chen, no conflicts, yes.
Dr. Daly.
Matt Daly, no conflicts, yes.
Dr. Maldonado.
Yvonne Maldonado, Stanford PI for Pfizer RSV, COVID, pediatric and adult varicella vaccine trials, and I recuse myself from this vote.
Dr. Sineas.
Sybil Sineas, no conflicts, yes.
Dr. Jameson.
Denise Jameson, no conflicts, yes.
Dr. Lair.
Jamie Lair, no conflicts, yes.
And it appears I missed Sarah Long. Dr. Long.
Sarah Long, no conflict, yes.
Sorry about that, Dr. Long. Dr. Shaw.
Al Shaw, no conflicts, yes.
And I'm Kip Talbot, no conflicts, yes. This motion also passes 11-0. Okay. This seems to be the end of, we do? Oh, crud. Okay, influenza vote 2. Sorry, I was so excited. We only did one pneumococcus. You didn't make a motion. Did you want to make a motion? That's okay. If you would like to make a motion, can we do the influenza vote first and then do that motion? That's what I'm saying. Okay, and then we'll come back. Okay, you got it. All right. Influenza vote 2. ACIP recommends high-dose inactivated and adjuvanted inactivated influenza vaccines as acceptable options for influenza vaccination of solid organ transplant recipients age 18 through 64 years who are on immunosuppressive medication regimens without a preference over other age-appropriate IIV3s or recombinant IIV3. Okay. Dr. Brooks.
Oliver Brooks, no conflicts, yes.
Dr. Chen.
Wilbur Chen, no conflicts, yes.
Dr. Sineas.
Sybil Sineas, no conflicts, yes.
Dr. Daly.
Matt Daly, no conflicts, yes.
Dr. Jameson.
Denise Jameson, no conflicts, yes.
Dr. Cotton.
Camille Cotton, no conflicts, yes.
Dr. Lair.
Jamie Lair, no conflict, yes.
Dr. Long.
Sarah Long, no conflict, yes.
Dr. Maldonado.
Yvonne Maldonado, Stanford PI for the Pfizer pediatric COVID and RSV vaccine trials and the adult varicella trials. I recuse myself from this vote.
Dr. Schechter.
Rob Schechter, no conflicts, yes.
Dr. Shaw.
Al Shaw, no conflicts, yes.
And I'm Kip Talbot, and I have no conflicts, yes. The motion passes 11-0 again. Okay. What? Oh, yeah, I'm so sorry. I skipped comments on everything. So any comments on any of the last 3 votes, please speak up now. Dr. Lair.
Just a comment, we've had recommendations for 18 to 64 and then not greater than or equal to 19 to 64, and I wonder if it could be consistent in the future if there's a rationale for one versus the other. I know it's confusing because VFC actually considers up through age 18. Is that the reason why there's sometimes confusion?
I think that may be a reason why sometimes there's difference. It may have to do also with the data that are available for certain diseases, just in terms of when historically the recommendations were originally put together. But you're right, it is an inconsistency which does create another type of challenge.
Thank you.
All right. Dr. Long?
Yes, just concerning the PCV 21 recommendation, the wording, I think, may be unclear for those who aren't in the room. It was PCV 21 as an option for those 19 and older who currently have a recommendation. It sounds like you could give it if you wanted to somebody who got PCV 20. So I think we need to, the spirit of it, we understand, but the option, it sounds like shared clinical decision-making.
I believe, Dr. Kobayashi, there will be clinical recommendations that explain and have information about that will go along with the new recommendation, correct?
It really means an option among vaccines.
Yes,
Not
yes.
an option yes or no.
Yes, yes.
Yes, that is correct. And we kind of rushed through the clinical guidance slides, but we will elaborate on that.
Okay. Dr. Brooks? Would you like to make a motion?
Not at this time.
Okay. October? You got it. Okay, that is the end of our business as written on the agenda. Does anyone want to bring anything else up? I would like to make one comment. I'm taking chair's prerogative a lot today. It was mentioned earlier today that insurance has a year to pay for vaccines. I find it interesting that we have a mandate to review and vote on a vaccine very quickly after FDA licensure, but insurance has a year after we. I think it's critical if we have to rush or hurry to evaluate and recommend a vaccine or not recommend a vaccine. It's just as imperative that the insurance companies have a very abbreviated time for our vote to start paying for these vaccines. So I think that's something that should be considered in the near future. Dr. Daly?
Quick question, and my apologies if I missed this. Are there any VFC votes like for influenza vaccine, or no, we don't need that? Okay, perfect, thanks. Just checking.
Everybody go home. Oh, wait, sorry, Dr. Cotton.
Thank you. I'd like to second what you said, Kip. And furthermore, I think that is actually CMS policy, so it would be CMS that would need to alter their policy, which would then influence private insurance. No? Well, if it's, my understanding is I was told it was CMS policy.
All insurers, including CMS, would be great.
Okay, all insurers.
Would it take a modification of the Affordable Care Act provisions?
Yeah, this is Mary Beth Mann from CMS. That would require a modification of the Affordable Care Act. It's the Affordable Care Act that gave private insurance that year after the vaccine is recommended.
Thank you. And so similarly, I would like to ask that we consider, not ACIP, but perhaps CMS and other regulatory bodies, consider how we are supplying vaccines and the fact that many of us can't give vaccines that are covered under Medicare Part D in our offices. So the minute the patient leaves clinic with a recommendation to go to a commercial pharmacy, they often don't get the vaccines they need. And this is a major impediment towards broad vaccination of adults. And as we've seen today and yesterday, we are really missing the opportunity to prevent vaccine-preventable illness. So if we could have support on the regulatory aspects of vaccine coverage, that would be much appreciated. Thank you.
Dr. Brooks.
Yeah, thank you for those comments. And in the discussion regarding PCV being moved down to universally recommended at age 50, in the interim, while we make more deliberation, have more deliberation, we can focus on those that already have the indication for the vaccines that are now available that are not getting vaccinated, the 30 to 50% that are of high risk that are unvaccinated in that age group.
Thank you all. I appreciate the service. You're not done yet. We will see you tomorrow, but have a lovely evening. 8:30. Sorry, I must recess the meeting.